Here we go. Here we go.
Yeah.
Like
yeah.
he would scream at you.
Yeah,
He would scream
that's
at
right.
you.
That's right. But yeah, he loves music. He loves. I think it's just gotta be genetic. We're here today and talk about our son Callum, our firstborn kid. You know, he came into this world hot. He was born early, 33 weeks, and in the hospital for a little bit longer.
He was in the NICU for a little over 2 weeks, and then we got home and had a newborn, and it was COVID, and it was crazy, and we started noticing that Callie wasn't hitting milestones really at all, but we mostly thought that it was because he had been born at 33 weeks.
Yeah, 7 weeks early. So we were just kind of waiting for him to catch up the whole time.
Many levels of genetic testing.
A result came back saying he was positive for STXBP1, which we had never heard of before, and
no one
has ever heard of. It's a rare genetic disorder.
It's a neurodevelopmental disorder.
And at the time of his diagnosis, there were maybe 300 cases, because the test was so new. And it basically, you know, it's very scary sounding. It's a neuroencephalopathy, and
our neurologist told us to Google it, which bad advice. And when you Google it, you see words like hard to control seizures and
never walk,
intellectual
never talk,
disability, never walks, never talks,
very disabled for life.
Worst case.
So, you know, yeah, we pretty much panicked.
Totally panicked.
I remember thinking for many, many weeks after that, I was hoping to wake up and it not be the reality that we were living, you know.
We joined the Facebook support group, and that was a really, really scary place at first, like super scary and triggering, but now we've met like some of our best friends from that group who are living parallel lives to ours and are really working. Everybody in our STXBP1 community are working really, really hard to find a cure for our kids.
There's a foundation and
parent-led, parent-run.
A parent-run foundation, and a big research study going on at Children's Hospital of Philadelphia. Yes. They know more than anyone else in the world about this.
And that was really encouraging. And we left there, like, I was really scared, but we left there just incredibly hopeful and excited about all that we know that Callie can do. We know that Callum will walk, and we think that he will walk really soon.
Are you taking little steps with your dad?
Callum is in preschool, and he loves it so much. He's absolutely thriving there. I think maybe Callie will talk. I feel hopeful about that. You know, he sings songs now. But I think that Callie will continue to just absolutely blow us away with what he can do and what he understands.
But we are in it for the long haul. I mean, he's gonna need help for the rest of his life, you know, on some level. And one of the main things that we need to do is just raise awareness and try to raise money to help them further their research and try to find an actual cure for this, which turns out is
possible.
More of a reality than we ever knew it would
I thought
be,
we were decades away from any type of treatment or cure, and it turns out that's not the case. So now we just are trying to do our part and raise money and awareness so that we can get that therapy and treatment to our kids.
Yeah, buddy. It's a lot of science, but we are happy to be a part of this effort to really try to raise awareness and raise money for this disorder.
Yeah. Because also Callie is awesome.
Yeah, and all the kids are awesome.
They're so good.
It's a, you know, as sad as it is to see a kid not develop and not be able to learn what you want them to, These kids are the brightest shining rays of sunshine, and they're just amazing. They're so inspiring. They work so hard, and they're just happy, beautiful kids. So we want to do everything we can to help them as much as we can.
It's my pleasure to introduce Julianne and Callum.
Hi. I don't think I've ever watched that video without crying. Anyway, my husband John isn't here today, but they have another video that we have a message for you.
They made a special message for you, so here you go.
Each person here is a part of something way bigger than just this event. We are all a part of changing our children's lives, each of our family's futures, and our community's story. When we first received Callum's diagnosis in 2022, we felt incredibly alone and hopeless.
Because of this community and the STXBP1 Foundation, that's no longer true.
When we were planning to attend our first STX Family Summit, we really didn't know what to expect. We figured it would be a really positive place because of all of the amazing parents we had met who are actively moving mountains. But we didn't expect that it was going to sound and look like Callum in there, that it was going to sound and look like hope. So for 3 days, we sat in a conference room and watched and listened. We saw and heard the familiar sights and sounds of our Sunshine Boy. We saw STXers happily hop crawling around the event space and fiercely gnawing on their chewy necklaces. We heard their random clapping and vocalizations and the sound of dropped or thrown cups, most identical to Callie's, because I think a lot of us buy the exact same brand of cup for our kids. But there were new sounds and sights too. We saw some older STXers walking and running and high-fiving people. We heard some of them talking and using their AACs to communicate. And somehow, these weren't even the most hopeful parts.
STXBP1 was discovered in 2008. The foundation formed in 2017, and in 2019, the first scientific meeting mapped out 4 roadmap priorities, and they've made incredible progress since. From 2020 to 2022, they developed a disease concept model, multiple natural history studies, an early phase clinical trial of a drug, and by the end of 2022, more than 9 potential therapies were developed. Then by the end of 2024, 16 potential therapies.
16 potential therapies. That's 16 potential cures. Not just for some distant faceless group, but for our Callie and all of the other STXers in this room, and the roughly 1,200 or so STXers all around the world.
What a beautiful and eloquent way to start off our summit. Thank you, Julianne, John, and Callum. I want to welcome you here this morning. Welcome to all of our families. Welcome to our dedicated researchers and clinicians, and also to our valued industry partners. Thank you very much to Children's Colorado for hosting us here in Colorado, and for seeing many of our star participants this week. That was really fantastic. I heard some really great things about visits last night. I'm Charlene SYNRGY. I am president and co-founder of the STXBP1 Foundation, and I'm also mom to Juno, who just turned 12. Some of you may remember that Juno stood next to me on this very stage 2 years ago, and she was holding my hand, helping mommy through her presentation. And last year, she arrived after Summit happened, 2 days late because of the CrowdStrike events. Some of you may have remembered how that messed up a lot of computer systems and also stranded a lot of people in terms of flights. So I'm extra happy that she's here running around and pulling hair and giving high fives. And she is truly my why. So I have some slides here. She is truly my why. And I want to bring your attention to the picture on the right. So Juno is entering 7th grade this fall, and on the right, she's proudly carrying her lunchbox down the stairs to the cafeteria. And this is something that took her quite a long time earlier this year to learn. She had to learn to hold her lunchbox and not drop it, so that she had something with purpose. She had to learn how to navigate walking downstairs with an extra load that, was unbalancing, and then make it all the way to the cafeteria. And I just want to say that I am so proud of this small victory for her, this milestone for her, and it makes me proud of all of our STXers with all the hard work that they do and those milestones that are so hard won, that we call inch stones. So after Juno was diagnosed, we found 5 other families on Facebook, and together we started the STXBP1 Foundation in 2017. At that time, there were maybe 200 families in the world who had been diagnosed. And our community has grown by leaps and bounds, as Julianne said. And in 1378 in our census, published at the end of June. 1378. We are not alone. In fact, we're here at the Summit 2025, and I'm so excited to be here in Colorado with many of you, as well as with those of you who are online. We are trailblazing together. You may have noticed that that is our theme, and what does that mean? What does it mean that we are trailblazing? We are taking bold steps together in science, in care, and in community. And I want to be maybe more vivid in terms of what trailblazing means. Sorry, hold on. I'm short. We are trailblazing a new trail. We're making a new trail together. And it's not always smooth. In some places, it's actually been pretty rocky, and we're expecting it to continue to be. But what we need to do is we need to do this together as individual families coming together in a community with our doctors, with our researchers, and with biopharma. This is how we are going to trailblaze. And so what does trailblazing actually look like? Dr. Ingo Helbig, who's going to speak a little bit later, always says we are one of the fastest moving rare diseases. And so I'm going to show you some evidence that we are actually one of the fastest moving rare diseases. So warning, I am not going to want you to read all the fine print on these slides. Oh, here was my trailblazing slide. Look at that. We are trailblazing together. But I'm not going to want you to read all of the detail on these slides, but I want you to get the gist of this. So most of you have probably heard of cystic fibrosis. It's a terrible disease where mucus fills up the lungs and the digestive system, and so they're not able to do their jobs. Cystic fibrosis was first identified in 1930. So that's the beginning of this timeline. And all you need to look at is the black timeline. Cystic fibrosis was first identified in 1930, which was 95 years ago. Patient families got together and started the Cystic Fibrosis Foundation in 1955. And they worked incredibly hard to push forward progress. We didn't even know the gene that was responsible for cystic fibrosis until 1989. So they were working all of that time to raise money and move science forward, and we didn't even know the gene that caused cystic fibrosis. So it took them 90 years from the time that the first patients were identified to having an approved medicine that treated many patients. And this disease was previously fatal for all patients. An enormous, incredible transformation driven by an incredibly strong patient foundation and community with committed researchers and biopharma. This took 90 years. Now, Angelman syndrome, another neurodevelopmental disorder with a lot of similarities to STXBP1. The first patients were identified in 1965. A very strong foundation, an incredibly activated community, and strong researchers. And now, 61 years later, they are now in late stage 3 clinical trials for genetic therapies. 61 years. This is STXBP1. And yes, the black line is the same length, but this is only 16 years. The first patients in STXBP1 were identified in 2008, and the foundation was started in 2017. And now, fast forward 16 years later, our community is embarking on its first clinical trial for a gene therapy starting this month. And you'll hear more about that this afternoon when Melanie from Capsida speaks, but 16 years. It may seem like a long time, for those of us who are watching our kids getting older, but truly, we are bending time and space. This could not happen, with our amazing and dedicated researcher community, and that includes both the academics and our industry partners. We have also been able to stand on the shoulders of giants. Those, the cystic fibrosis community, the Angelman community, they have taught us so much. We are very, very lucky about this time. And we have a lot of committed patient advocacy organizations. You know the STXBP1 Foundation because obviously you're here. But we have 12 organizations worldwide. The last 5 years, we have seen these organizations sprout, and we now have a very vibrant STXBP1 Global Connect around the world. I want to talk to you a little bit about, and sorry about the top here, but what Trailblazing looks like in terms of numbers. These numbers are incredibly exciting. 146 patients seen in our STAR natural history. We are only in the second year of this natural history study. Incredible activation. Over $3 million in grants and research funding from the STXBP1 Foundation. 17 therapies in pipeline. I'll talk a little bit more about that. And then I want to highlight that we have 2 natural history studies that are happening. You know about STAR, and we'll talk about that more today. We also have the ESCO natural history study that is starting up in Europe. The first site is live, the first country is live, and so we're really excited about that. This is bringing not only research advancements, but it is also bringing clinical expertise to many more of our patients, and we're committed to working to expand this. And then, of course, our first gene therapy clinical trial. Wow, a lot is happening. I'm now going to talk about our therapy pipeline. And y'all, many of you have seen this slide before. I know there's a lot of new families. I want to give a special welcome to the new families. This is what things looked like in 2019. We were very lucky as a community that a lot of basic research had been done to understand what STXBP1 does in the body. But nothing had happened in terms of therapy development. And so in 2019, Jacqueline Bourret's lab at Weill Cornell had identified 4-phenylbutyrate as a potential repurposed drug for STXBP1. And with partnership with Lulu's crew and Clara Inspired, we were able to start the first clinical trial for STXBP1 in 2019. Actually, it was 2020. COVID kind of got in the way, but we did it. This is what things looked like in 2023. We had 10 therapies in pipeline, and as you can see, what we really were trying to do was start to develop a diversified pipeline. This is the Sweet 16 that Julianne and John mentioned. This was last year what our pipeline looked like. And again, you can see this real focus on diversifying our portfolio. This is what happened after that. And I want to talk to you about this because it's important to understand we have to follow the science. Like, does it seem like the therapy is working? Because these are all potential cures, potential therapies, and sometimes business decisions have to be made because of the reality of the environment. And so we've had some programs put on hold and also and canceled due to different reasons, but this is what our pipeline looks like now. So we are continuing to invest in this diversified portfolio. We have 2 new small molecule trials you'll see at the top from Lundbeck, and a new trial that's opening up with Praxis. These are focused on seizure control, and we're lucky that we have someone from Lundbeck coming to speak later today in the clinical trial session. And then we have also just and this got signed yesterday. Thank you, Jim Goss, our scientific director. We have a new grant going out to UC Davis for a CRISPR-A technology. So the foundation is really committed to supporting advance of all of these therapies and following strong science, as well as pushing with unrelenting urgency. So I hope you see that my and our entire foundations team are very excited about the progress that we're making and our momentum. And with this momentum, we have entered a new chapter. In December, we hired our first executive director, and I'm thrilled to introduce him now, Mark Quinlan.
I'm a little taller than Charlene. So, good morning, everyone. And as Charlene said, I'm Mark Quinlan. I'm truly excited to be here today as the first executive director of the STXBP1 Foundation. Before we dive into the exciting science and updates, I wanted to tell you a little bit about myself. This is my wife, Cheryl, and our daughter, Sydney. We live in Coburg, Oregon, which is a quiet little town just north of Eugene. It's peaceful air, and we really love it. And when I'm not working, you can usually find me on my bike. I like to ride in the foothills of the Cascade Mountains, or I like to fly fish in the beautiful rivers that are in Oregon. Those 2 activities kind of help me reset and re-energize and relax a little bit. Professionally, I spent my career leading nonprofit organizations. For the past 7 years, I served as the executive director of the Fanconi Cancer Foundation. And that work gave me a deep experience in rare disease, translational research, and patient-centered advocacy. What drew me to the STXBP1 Foundation was the energy, the momentum, and the people. This is a community that refuses to sit still. Families, researchers, clinicians, industry partners, everyone here is leaning in and pushing forward. And I knew immediately I wanted to be a part of that. So, my first impressions. Oops, that slide got a little messed up. In my first 6 months, I had the privilege of listening, learning, and meeting many of you. And there are a few things that really stood out. First, the strength of what's been built. This is a relatively young organization, as Charlene mentioned, and the foundation has created a rock-solid infrastructure for progress. From the STAR study to Global Connect to our funding strategies and our scientific collaborations, the groundwork is impressive. Second is the passion and expertise across the community. I've seen parents become advocates, researchers who treat this as more than just a job, and clinicians who truly care about the families they serve. That mix of purpose and professionalism is rare, and it's also very powerful. And third is the culture of urgency and compassion. There's a real sense that the clock is ticking and that every day matters. But it's also matched by deep empathy, support, and a shared understanding of how hard this journey can be. That combination is what makes this community so special. It's also what makes it effective. So, what is my role in all of this? First and foremost is to sustain the momentum that's already in place. The foundation has built an incredible platform, and my job is to keep that engine running smoothly. But I also want to scale what works, whether it's expanding the reach of our STAR study, growing the state experts program, increasing our research investments. We have opportunities to grow further and faster. And just as important, I'm committed to staying open and collaborative. That means listening to families, creating space for diverse perspectives, and ensuring that transparency and partnership remain core to our culture. I don't come into this with all the answers, but I do come in with a deep respect, a clear strategy, and a desire to build with you, not for you. So let's talk a little bit about where we're headed. Our 3-year roadmap is called the Fast Forward Strategic Plan. It focuses on 4 key pillars: propel precision therapies, prepare for clinical trials, build biotech and pharma interest, and of course, support patients and families today. It's bold, it's focused, and it's already working. Over the next few slides, I'll share a few things we've accomplished in the past year in each of these areas. So as Charlene just mentioned, we now have 17 therapies in active development for STXBP1 related disorders. That includes gene therapies, RNA-based treatments, small molecules, and other emerging modalities. And of course, one of the biggest milestones was when Capsida Biotherapeutics received their FDA IND clearance and fast track designation for their AAV-based gene therapy CAP002. That trial is the first of its kind for STXBP1, and it is a huge step forward. This kind of progress shows that our strategic focus on diverse therapeutic approaches, or multiple shots on goal, is working. And it wouldn't be happening without the support and partnership of this community. So to support therapies, we have to be trial ready, and we're making strong progress there too. Our STAR natural history study continues to expand, collecting high quality longitudinal data on development, seizures, and other key outcomes. And we now have a global patient census, as Charlene mentioned, of nearly 1,400 individuals across 50 different countries. That's a big jump from the 900 families when we first started the census just a few years ago. And it makes a real difference in trial planning. We've also strengthened our data infrastructure and engaging with partners to ensure that we have the tools, standards, and coordination needed to support meaningful and efficient trials. All of this is about laying the groundwork so that when therapies are ready, we can act quickly and ethically. STXBP1 is now seen as a high opportunity target by an increasing number of biotech and pharma partners. We've seen growing engagement from companies all working on STXBP1 related therapies. This momentum is a result of community building, research investment, and transparency. By showing that we're organized, informed, and data-driven, we've made STXBP1 a space where companies want to work. This is how we turn hope into investment, strategy into science, and patients into partners. And of course, we can't always focus on the future. We have to support families today. This year we launched our State Experts Program. This is a network of STXBP1 parents in 23 states who serve as local guides for services, support programs, and educational resources. It's practical, grounded, and it's deeply appreciated by our families. And at the global level, our STXBP1 Connect network now spans 26 countries. So this is offering connection, community, and shared experiences across borders. Together, these programs help ensure that families feel less isolated, more informed, and better supported, whether they're newly diagnosed or years into their journey. So, we have a full weekend ahead, and I think it reflects everything the community is about. So today you're going to hear from world experts on gene therapy, STXBP1 biology, clinical trials, and behavioral science. And you'll hear powerful stories from families, stories that remind us why this work matters so much. Tomorrow, we're going to shift our focus to family support, and sessions will be on behavior strategies, emotional wellness, and peer-led discussions that will offer practical tools and connection. And tonight, of course, we're going to celebrate with our Trailblazing Together dinner and dance. It's a moment to step back, take a breath, and recognize all we've accomplished together. But before we do that, one other thing I wanted to let you know is today, you guys are going to be receiving an email from us that's going to have a clinical trial readiness survey. And the reason we're doing this is because we want to help prepare for clinical trials better. And so we're going to ask you to share what you know and what you still need when it comes to thinking about clinical trials. And tell us, what would help you to participate in future trials. And that'll help us guide how we plan, communicate, and support families in patient-centered clinical trials. So when you get that email, I would greatly appreciate it if you'd take a few minutes and fill out the survey. It'll probably take about 10 minutes or so. But that information will be super valuable to us. And again, we're trying to help us build trial-ready community together. So with that, I'm going to turn it back over to Charlene. And we got a little fun exercise for you guys that we're going to do here in the room.
All right, we're gonna move into the talks in a minute, but before we do that, we have 2 interactive polls. So get out your phone and, I don't have my phone, but get out your phone and go to menti.com, menti.com, and those of you who are on the virtual live stream, you can also do this. And please enter the number at the top that I cannot see. (8587), thank you, 8587, my old eyes, 8587-9769, 8587-9769, and you can put in a short phrase, a single word. What are you looking forward to at Summit? 8587-9769. And Daniel, can you go back to the word cloud? All right, look, things are starting to fill in. Don't be shy. Community, connection, therapeutic advancements, understanding, clinical trials, visiting families, reinforcing the why, trial awareness, behavior understanding, seizure control, siblings, hope. We'll give it another 30 seconds or so. Oh, that's beautiful. Be involved. Breakthrough. Awesome. Learning. Knowledge. Family stories. That's great. Okay, thank you all. All right, we have one more poll because one wasn't enough. Can you go to the next slide? Same code, so you can keep using the same code. And then go to the next slide, please. Describe your STXer in one word. Same code, 8587-9769. 8587-9769. And again, those of you on the virtual are welcome to participate. Magical. Joyful. Bold. Tough. Funny. strong. Sweetness. One of a kind. Awesome. A fighter. Blessing. Rowdy. Chill and happy. I love it. Let it go for another 15 seconds. Engaged. Perfectly imperfect. Adorable. Sweetness. Thank you. And we'll make word clouds of these and we'll put them on our website. That was really awesome. Well, we got to get to the talks. I know we're already running a little bit late, but my heart is really full looking around this room. And I'm just so awestruck at how our community continues to grow. We are trailblazing here together this weekend and going forward. I really encourage you to meet people, meet other families. Our researchers and clinicians are here. People from our biopharma partners are here and really want to learn your stories. We're going to share important advances in research and therapy development as well as clinical care. And tomorrow we're going to focus a lot on support tools and community building. So I want to give a thanks to our sponsors for helping us make this event possible, and also to our collaborators and the community. And with that, I am going to hand things over to Jim for our first talk. Thank you.
Little taller than Charlene, not quite as tall as Mark. So before I start my talk, I want to basically tell everybody that we are asking again for your blood. So we have Combined Brain here who is collecting blood samples. Please give generously. Well, maybe not generously, but it really helps us in collecting biospecimens from everybody, from the STXers, from family members, especially siblings. So find the time, find the Combined Brain people, sign up. They'll poke you, they'll prod you, they'll take your blood. It's fantastic. They also will take nasal swabs. This is for another study that we may be collecting or performing in the future. It's not as invasive, just a nice little nasal swab, an STXer in somebody of the same sex who lives in the same household. That's what we need, all right? So thank you. So what I'm going to talk about today is gene therapy approaches for STXBP1. And if you've watched the seminar that I gave online and thought to yourself, boy, I would love to see that live, this is your chance. So I'm going to cover these topics today. Basically, I'm going to first give a little biology background so everybody is kind of level set. Then I'm going to talk about 3 different types of gene therapy that are appropriate for STXBP1. And then I'm going to finish it off with talking about some delivery methods. So first, a little biology background to get everybody, as I said, level set in the idea of going from a gene to a protein. So genes are made up of DNA. DNA is found in the nucleus of our cell. This is a big fat neuron cell here, and you can see the nucleus and the DNA in there. You can see STXBP1 genes. Everybody has 2 sets of genes. You get one from your mom, one from your dad. both genes make RNA. So what does that mean? Well, in order to make protein, protein is made in the cytoplasm of the cell. And so the genes are instructions on how to make proteins. But the DNA can't leave the nucleus. So what it does is it makes something else called RNA, which is a copy of the DNA, and that is through a process called transcription. The RNA goes into the cytoplasm, and then that RNA can be used to make protein and used to make STXBP1 protein. Protein is made from both copies of RNA, and therefore it's made from both copies of the STXBP1 gene. Proteins fold into specific three-dimensional shapes. The three-dimensional shape is important in allowing the protein to function the way it's supposed to function. In the case of STXBP1, that function is to release neurotransmitters. These neurotransmitters are how neurons communicate with one another. In order for neurons to function properly, they need a lot of STXBP1 protein. So they need the protein to be made from both copies of the genes, your mom's copy and your dad's copy. So what happens if you have a pathogenic variant in STXBP1 or you have a defective STXBP1 gene? Well, what happens is you make a defective RNA from that gene. You're still making a normal copy of RNA from the other gene, but now you have one defective copy, one normal copy. The normal copy makes a normal protein, but the defective RNA copy makes a defective protein, and it can be defective in several different ways. It can be misfolded, it may be truncated, it may not be made at all. In some serious conditions, it can actually make a protein that interferes with the normal protein. We don't really have any strong evidence this occurs in STXBP1, however. But the upshot of that is you only have one good gene making half the amount of protein you really need, so you only get half the amount of neurotransmission. This is what we call haploinsufficiency. So how can we fix this? Well, we fix it through gene therapy drugs, or this is at least what I'm going to talk to about. So what is a gene therapy drug? Well, the FDA defines a gene therapy drug as a product that mediates its effect through transcription or translation of transferred genetic material. Well, what does that mean? Well, it basically means a gene therapy product can be something where you add DNA or RNA into a cell. Right? So it's exogenous. You're just adding it in there. Or a gene therapy product can specifically alter the host DNA. And that what this means is you're not adding any DNA or RNA into a cell. Instead, what you're doing is you're fixing what's wrong in the cell. And so gene therapy has been around for many decades. And in the last 40 years or so, there have been many different types of gene therapy approaches developed. However, we're only going to focus on a couple of them, which are most beneficial or most appropriate for STXBP1. The first one I'm going to talk about is called gene replacement. And so here we have our neuron with its defective STXBP1 gene and its normal gene making normal RNA and normal protein. Well, gene replacement is simply adding a working copy of the STXBP1 gene into the neuron to take the place of the defective gene or the malfunctioning gene. And here you add a gene that is a normal gene, it makes normal RNA, that makes normal protein, and that protein is added to the protein that's already made by the endogenous normal gene. And so now you have the full amount of STXBP1 protein, so you get full amount of neurotransmission. This particular approach for gene therapy is technically straightforward. It's easy to understand. By technically straightforward, don't take that as meaning it's technically easy. It takes a long time to still develop these kind of therapies, but the technology behind it is a little bit more straightforward. It's well studied. This has been done for years and years. So we know a lot about how to make genes and how to get them into different cells. It can be used to treat any pathogenic variant. So regardless of what variant your child has, this is an approach that could be used to help them. One thing, gene replacement can cause what's called overexpression. And so what this means is that when you add exogenous genes to a cell, you can't control if you're adding 1, 2, 3, 50 genes. So if you're adding a lot of genes, then they make a lot of RNA, and that makes a lot of protein. And so you may end up a case where you're actually making more STXBP1 protein than the cell actually needs. As far as we know, we have no strong evidence that this is an issue for anybody, that it's not a problem if neurons make more STXBP1 than normal. This is a type of therapy that is one and done. Once you introduce a gene into a neuron, you don't have to do it again. It just works, and it will make RNA and protein conceivably for the rest of that neuron's lifespan. And this can be a good thing because you only have to be treated once. However, it could also be a negative. So if you have an adverse reaction to the gene, to the exogenous gene, then there's no way to turn it off. It's going to be there, and so that can be a concern, something to think about. And this requires a delivery method, which means that you just can't take a gene, a piece of DNA, and stick it into a cell. You have to have some way to actually deliver it into a cell. And I'll talk more about that at the end of my talk. Another type of gene therapy is what we call gene manipulation. So here we have our neuron again, and its defective gene. In this case, you're not adding a gene. What you're doing is you're adding what we will call molecular tools into the neuron, and those tools interact with the person's own genes. In this case, this is a tool that may interact with the defective gene. And the idea here is you try to fix it. You're repairing the defective gene. And this is called gene editing. And you may have heard of CRISPR-Cas. If you hear that term, that's what it's referring to. It's a form of gene editing, trying to fix the damaged gene. There are other ways of doing this as well. One's called base editing. There's another prime editing. This is technology that is advancing very rapidly. And so there will be more and more of these types of editing approaches being developed all the time. Another way that you can interact with the endogenous genes that is not involved in actually trying to repair the gene, but you interact with them in another way. You can turn genes on or off. Basically, what that means is if you're turning it on, you're just making it more active, and if you're turning it off, you're basically stopping it from working. For STXBP1, how this would work is you would want to turn on the normal copy of the gene so it's more active. In this case, as you can see here, the normal copy of the gene is making more RNA, and since it's making more RNA, that's going to make more protein, and that extra protein will take the place of the protein that isn't made by the malfunctioning gene. So there are a number of ways that this can be done. Part of that is using what's called CRISPR-A or CRISPR activation. And then there are other sorts of compounds called transcription factors that can be utilized to do very similar sorts of things. So gene manipulation and the molecular tools that are involved in trying to do this are technically more challenging than gene replacement. And obviously very difficult, but as I said, advancing very rapidly. depending upon the type of gene manipulation you do, for example, if you're doing gene editing, because you're fixing the gene, you actually maintain the cellular control over expression. So you will never get overexpression of a protein if you just fix the endogenous gene, because then the neuron will work like it was always supposed to work. This type of therapy is also one and done. And has the same issues with gene replacement in that way. Good in one instance, that you never have to have the therapy done again and you're good to go. The other is if you have a reaction against the particular tools, they're going to still be in your cells. And this also requires a delivery system. So another approach is, instead of working with DNA, you work with RNA. And so this is called RNA therapy, and this is just interacting or manipulating RNA in some fashion. So again, here's our neuron, normal and defective. And so what can you do? Well, you can just add a working copy of RNA, just like you added a working copy of DNA. And in fact, most people in this room have had RNA therapy to do this. The COVID vaccine is an RNA therapy. It introduces a copy of a COVID RNA so that you make a COVID protein and make an immune reaction against that. And so you could do that with STXBP1, but the problem is RNA doesn't last very long, a couple days in a cell. And so what happens is eventually the RNA you add just disappears. And so for STXBP1, that just wouldn't work. Instead, what most people do is, when they're focusing on RNA therapy, they use what are called antisense oligonucleotides, which are small sequences of DNA that interact with RNA, different parts of the RNA. And depending upon what part of an RNA they interact with, in this case, they're the little green squiggles that you see next to the RNA. And depending upon where it interacts with the RNA, it can either silence the RNA or stop it from working, or it can make the RNA make more protein. And again, this is the approach we would take for STXBP1. We don't want to silence the RNA, we want to make more of it. And so that is an approach that is being well studied and looked at now. But again, you're increasing translation, more protein to make enough of the STXBP1 protein you need. You can also use what are called read-through drugs, which are just compounds that can basically allow protein to be made from defective RNA that have specific types of pathologic variants. So types of variants where you have what's called a premature termination codon. These are nonsense variants. Read-through drugs can work in those, but not other types of STXBP1 variants. So RNA therapy is a fairly simple technology. It's easy to make oligos. Again, simple technology, but the science is, actually doing it and working on it is very complex. You need to test hundreds of these ASOs to find any that work in an RNA. So there's a lot of research involved in doing that. RNA therapy can be used to treat any pathogenic variant. The effectiveness of ASO therapies may depend on the gene itself. And the reason for this is because since the ASO interacts with a specific part of the RNA, for some genes, they may not have what are called regulatory areas of the RNA that are amenable to this type of treatment, or those regulatory areas of the RNA may not be powerful. So you may get some increase in protein, but maybe not enough, or you may not get enough at all, or what have you. But this is all part of working out this, this type of therapy. This is not a one-and-done therapy. So oligos, ASOs, even though they exist longer than RNA in a cell, because the oligos are made of DNA, they will eventually disappear. And so this is a therapy that needs to be constantly repeated and given to somebody. So every 2 to 3 months, perhaps, would have to be given to somebody. So this is a negative in one aspect, that if this is a therapy that you are undergoing, you need to get this therapy constantly for the rest of your life. On the other hand, there's a positive to it, because if you did have a negative reaction to this type of therapy, that negative reaction will go away once the oligo disappears from the body. And ASOs don't necessarily need a delivery system. Some do use them, but they don't necessarily have to. You can inject naked ASOs into people. So let me talk a little bit about the delivery methods for using gene therapies and stuff. And by far, the most common delivery method are what's called viral vectors. And so nature has already evolved something that does gene therapy. They're called viruses. Viruses have evolved to basically go into cells, inject genetic material, and make that cell make that genetic material. And so we can co-opt that by taking the viruses and putting in the genetic material we want, like the STXBP1 gene, for example, and at the same time mess around with the virus itself so that virus no longer causes a disease if it did in the first place. And then we just use the virus to do what it does. It just delivers the gene, the material, the genetic material into the cell. And there are a lot of viral vectors that have been utilized in gene therapy research. By far, the one that's the most common currently is AAV. And this just lists some of those and the size, and they all have their positives and negatives. Charlene's telling me I've got 2 minutes or I'm going to get the big hook. And so, as I said, AAV is the most common, and it is a very simple, tiny little virus. It only has 3 genes surrounded by what's called a capsid, and it's easy to manipulate, and you can put your gene of interest in there. Because it's small, the gene has to be somewhat small, so it can't really hold big genes. But nonetheless, it's easily usable. One issue with AAV is that in high doses, if you give it to somebody, you can have an immune response to it. It is a virus. Everybody has immune responses to viruses. And there can be some tissue toxicity at those high doses. So one way that you get around that is you can make changes to the capsid, which is that surrounding part there. If you change that capsid, then you can hide this from the immune system, and you can direct the virus to specific tissues, like neurons, and away from other tissues that might be toxic, like the liver, which is one of the main organs that have toxicity if you inject in just normal AAV in high doses. Other types of delivery methods include what are called nanoparticles, which are either lipid or fat-based molecules or chemical polymers that are used to encapsulate a gene or genetic material or molecular tool. And then these are non-immunogenic, which means that there's no immune response to them. And so they're good that way. But you have to figure out some way to try to target them to the tissue that you want to do that to. There's a lot of research undergoing different types of these nanoparticles, and so hopefully this is a technology that will get better in the future. And then lastly, another way is using what are called exosomes. Exosomes are what are called extracellular vesicles. These are made in practically every cell of your body. They are already made, they're already released into body fluids like blood, and they already contain things like DNA, protein, and RNA. And then the idea is you could utilize this sort of system and make exosomes with the gene of interest to you. And the nice thing is, if you make exosomes from neurons, then they will tend to target neurons. So if you put them into the body, they will tend to go to neurons and then release their material. And so this is a kind of a newer technology, but again, quite a bit of research is being done in this. And that is it. So thank you very much. I've been told I can take questions. So if I can take one very important question. Yes.
Thank you. That was a quick delivery. With the different variants, I believe the current test that's coming up is the gene modification, technically gene addition for DNA, if that's correct. But I'm really curious with upcoming trials, are we looking at like what is kind of restoring a normal amount of the relevant protein going to do to kids long term who are kind of past some of those normal developmental milestones if we can restore kind of a normal level of the appropriate proteins?
That's an excellent question, and I wish I had an excellent answer to that, but we don't really know. We're hoping, obviously, that if you restore normal neurotransmission in our kids, that you will regain function. You may not regain complete function, but you should regain some function. And to what extent that will be, we won't really know until we have more trials that do exactly this, and so that's, the Capsida trial, which again will be talked about more. That is a gene replacement trial with an AAV where the capsid has been engineered so it evades the immune system and what have you. But that is very important. So we will have obviously a better idea about what is changing. And I'll say that that's one of the, if you are involved in the STAR study and you go in and you go, why am I spending my entire day taking all of these tests, and why are we looking at all of these things? Why am I taking all of these parent-reported outcomes and stuff? That's because we need that information, because we don't know if you get the Capsida treatment or another treatment that comes out next year or what have you, whether or not that's going to improve seizures. We don't know if that's going to improve motor behavior or cognition or communication or more than one of those. So that's why we need all that information, so that we can better understand if a drug is working, so that we can look at several different symptoms.
If you'll be willing to call that the first half of a question, then I would love to hear if the foundation ever identifies perhaps other rare genetic disorders where reintroducing normal neurotransmitter levels, just what impact is that going to have on our kids long term? It'd be interesting to see if there are other rare genetic diseases that, like, hey, what are the long-term outcomes if we make a correction?
Yeah, another very, very good question. And we are just entering that phase now where there are clinical trials for somewhat similar sorts of events. So Charlene talked about Angelman syndrome, for example, right? So they're in their phase 3. And so from my understanding, there has been shown some benefit so far for what they're doing. So, I'm very hopeful. I have, before I joined the foundation, I did gene therapy research for years and years and years. And I'm very pro gene therapy. I think it holds a lot of promise. But it's like any other therapy. It's going to take time, and it's only going to get better, right? So as we utilize it more in a patient population, we understand the effects that we're seeing in initial gene therapies, then that will be improved and improved upon. So thank you for your question. So, without further ado, I will hand over this microphone to Mingshan Zhu, who is Associate Professor of Neuroscience and Human Genetics at Baylor College of Medicine. Many of you may have seen Mingshan give talks before at this meeting. We always have him give a talk at this meeting. He's going to talk about doing gene therapy in preclinical studies. Now, preclinical means before humans, so animal studies and cell studies. Everybody loves Mingshan's talks because he always has great videos of mice being cured. So, Mingshan, floor is yours.
Thank you, Jim. I wish I'm as funny as Jim, so. Okay, first of all, really appreciate Jim and Charlene for the invitation to be able to speak here again. As Jim said, I will be talking about gene therapy development in the lab. This is specifically referring to the gene replacement therapy that are currently entering the phase 1 clinical trials. Therefore, these are the important disclosure because my colleague and I are listed as the inventor of several intellectual property related to this gene therapy. They have been licensed by our employer, Baylor College of Medicine, to Capsida Biotherapeutics. Capsida also provided some research funding for part of this research. Finally, I was a paid consultant for Capsida in the last few years. So, Jim and Charlene asked me to sort of give a talk about how we develop the gene therapy, and how this process is like. So this gives me a great opportunity to looking back this 15 years journey that towards these goals for developing a potentially disease-modifying therapy for STXBP1 disorder. So this, I wish I can call this 15 years straightforward, but we have a lot of memorable moments. Some are exciting, some are sad, but all of this journey started with my very first meeting with Elizabeth and Caroline. So that was back in 2010, and when the first time I heard about STXBP1 disorder. Caroline had STXBP1 disorder. So many of you actually know Elizabeth Caroline, and many of you probably have seen these recent stories about how Elizabeth is trying to help Caroline. And in fact, throughout these 15 years, Elizabeth, Caroline, and their entire family are with us every step of the way and helping us reach to this particular point. So after I met them, I decided to, I would start thinking about how to work on this disorder. And we officially started this research program at Baylor College of Medicine and Texas Children's Hospital back in 2014. But with all these incredible and generous people listed on this slide, we actually was able to start generating the mouse model a couple years before we officially started. So over the years, we generated several mouse models, including the STXBP1 haploinsufficiency models, because this is one of the most important disease mechanisms. We realized that these mouse models are incredibly useful because they recapitulate a variety of neurological symptoms of the human individuals, including multiple phenotypes in the domains of cognitive function, epilepsy, motor impairment, and some of the psychiatric dysfunction. So as you can see, a large group of people were involved in this process, as shown on the slides. So by the time that we have this mouse model, we want to ask a very important question, which was just asked by, a minute ago, which is that how much the damage to the brain can be reversed if we were to correct the molecular deficits in this disorder. So this is important because obviously we want to know if we would develop a therapy, can this therapy be useful for kids at different age? So to do this, we use the mouse model and we play genetic tricks. So here's my version of the genetics. What we did here is we installed a stop signal in the middle of the STXBP1 gene. So that one particular copy of the STXBP1 gene cannot produce functional protein. However, this stop can be reversed by an enzyme called FLIPO. So what this enzyme would do is that it will remove this stop signal, therefore the gene can produce the normal protein again. So now we can use this system to deliver the enzyme, the FLIPOs, at different time points to see whether we can reverse the neurological phenotypes. So we have done this in adult mice. So we found that indeed all of the neurological phenotype can be reversed if you remove the stop signal and restore the STXBP1 function. So here are the two assays that we often do in mouse model, which tests their memories. So on the y-axis is the memory score. The better the score, the better the animal can remember. So as you can see here, is this version 2 or version 3? Sorry, I think this must have been an older version, but that's okay. I can continue. So, and as you can see, the STXBP1 mouse, right, the magenta mouse, has a lower score than the normal mouse. However, once the gene is restored by the FLIPO enzyme, then their score can be recovered back to the same level as the wild-type animal. And this is true for both assays. We also test their epilepsy phenotype. So these are the two videos. And as you can see here, one video is not playing, but you can see that there's multiple seizures on the mutant animal that was treated with vehicles, whereas the video on the right is moving. It's showing that the animal received the FLIPase, which removed the stop signal and recovered the STXBP1 gene function. It does not have seizure anymore. So right, these are the EEG recording from the mouse brains. So therefore, by 2018, we discovered that the disease is actually reversible. So this is very important because it opens the door for us to developing many potential therapies as long as you can increase the STXBP1 level in the body, right? So therefore, many therapeutic, as some of has illustrated in James' talk, is being developed after that. So for us, it became natural that we wanted to test the gene therapy. We chose the AAV-based gene replacement approach, as Jim just described. So I'm not going through this one more time, but essentially you can see that this is the approach that we will bring a normal copy of the STXBP1 genes. So again, a large group of people were involved in this effort. So what we found is that, again, the STXBP1 animal treated with AAV recovered their motor function if this video play. Yes, they are. So as you can see here on the left, the normal animal struggles because they have pretty good motor function when you lift their tails, whereas the STXBP1 mice in the middle is showing this classical hindline clasping phenotype. However, if you treated this animal with the AAV gene therapy, they return to pretty much the normal levels. Again, their memory improves, and so in this particular case, we also want to answer the question that Jim was mentioning. If we would have a little bit too much of the STXBP1 protein, would that be harmful? So at least in this case, in the mouse model case, when we give a normal animal additional copy of the STXBP1 gene, they don't seem to care, so they seem to be quite normal. Importantly, the STXBP1 mice received the AAV gene therapy, improved their memory function back to the normal animal levels. Again, this is the video showing the AAV gene therapy can suppress seizure. Let's see. Okay, yes, both are working. So as you can see here, when the EEG trace is moving along, I'm sure everybody's familiar with this, you can see this mouse experience an episode of seizures. So the same mouse, right? So this video was taken from the same mouse. One is before the AAV treatment, the other one is afterwards, right? So obviously, after the treatment, all of this epileptic event disappear from these particular animals. So by 2019, we discovered this AAV gene therapy. Then I start talking to several companies, including some of you actually sitting in these rooms. So, and I was also had the opportunity to be introduced to a friend of a friend who at the time works in a venture capital firm. So then a year later, I received an email from a startup company called Capsida saying that, well, their founder asked them to reach out to me because the gene therapy program that we have in the lab. So that's when we started working with Capsida Biotherapeutics in the last for almost 5 years now. So from this collaboration, we really wanted to answer an important question. We want to determine how much how different dose of AAV can change the phenotype in the STXBP1 mouse models. So the scenario is the following. You can have a low dose of AAV that introduces the STXBP1 gene into a small fraction of the cells in the brain, as shown in this dark blue color on the left. Or you can increase the AAV dose and get to a medium level or high levels. So the question is, at which level we will start seeing therapeutic benefits, right? Because it's incredibly challenging to achieve the comprehensive coverage in a large brain like non-human primate or humans. So therefore, we want to know what would be the threshold to be potentially beneficial. So for these studies, we have a set of animal, right, that received the AAV gene therapy with a different dose, low dose, medium dose, and high dose. So this figure shows you the protein level in the brain from the anterior cortex. So as you can see here, the STXBP1 mouse received a vehicle treatment, had about 50% of the protein, right? This is what the haploinsufficiency means, right? We just don't have enough protein. We only have 50% of the protein. So when the animal received the AAV gene therapy, you can see a dose-dependent increase of the STXBP1 proteins. Now, we look at all of these animals. We found that this AAV gene therapy can improve their motor function, again, in a dose-dependent fashion. So on the y-axis is the motor impairment scores. The higher the score, the worse the motor function is. So therefore, you can see the mouse treated with vehicle control had a worse score, and this motor impairment is improved by the AAV gene therapy, again, in a dose-dependent fashion. So even the lowest dose can improve this function. In the memory assay that I showed you earlier, again, you observe this improvement of the memory in a dose-dependent fashion. The effect is small in the low dose, but gradually increase when the dose increase. And for the epilepsy, or for the seizure phenotype, this mouse model, in fact, have two different types of seizures. One is the absence seizure that I showed you earlier. Another one is called myoclonic seizure that I am not able to show you the video, but I will show you the data in the next slides. So from this graph, you can see that before the AAV treatment, all of the STXBP mouse had a high frequency of seizure. However, after the treatment, all of them, the seizure frequency reduced, even for the low dose. So for the myoclonic seizures, the improvement is even more dramatic. Almost all of the animals have almost no seizure anymore. So this is very encouraging for us. So from all this data, we basically realized that even at the low or medium levels, we are able to improve the neurological function of the STXBP1 mouse models. So therefore, these essentially sets the threshold of STXBP1 expression to achieve in the non-human primate that are expected to have a prospect of direct benefit in humans. So once Capsida Biotherapeutics find out that the AAV can achieve this threshold of expression in the non-human primate brain, then we are ready for the clinical trials. This is where we are at 2025. So at this point, some of you might ask, so what's next, right? So for my lab, we are particularly interested in additional therapeutic modality because, as Jim illustrated, gene therapy is great, it's one and done, but potentially you might benefit from additional treatments, right? Perhaps a small molecule. So this will be something like maybe you get gene therapy as a primary dose of your vaccine, but then on top of that, you might want to take a different drug like small molecule to fine-tune or improve the phenotypes. So therefore, we are working with several partners and trying to have additional medicine to control specific phenotype, for example. So before I stop and take questions, I just want to use this opportunity to acknowledge all the people that have helped us, so especially the people from our core facility that we benefit a lot from them in terms of generating the mouse model, characterizing the mouse model, and also prepare some of the viral vector. I'm grateful for all this collaboration with Capsida, and I only list the 4 people here, but really they have a large team of people involved in these programs. So below is all my funding source and that were involved in this research program. Last but not least, I hope that everybody remembers Caroline. I'm pretty sure that she's still watching because we are only at the end of the first half, right? So the second half, the clinical trial is just about to start. So she's going to see us through all the way to the finish line. So I'll stop here and take some questions.
So my question was just, the mice models that you guys looked at, they were all born with working copies of STX, is that right?
Yes.
Were you ever able to test any that actually were born without working copies to see if that had a different outcome when you replaced the working copy? Does that make sense?
Actually, can you rephrase your question?
Yeah.
I didn't understand, like...
I'm trying to, okay, so, sorry, hold on. Okay. Well, I'm just thinking, okay, so all the mice you tested had normal working copies. None of the mice were born without the working STX gene, right?
No, they all born without it.
Oh, they were?
To exactly mimic what happened in human patients. So yeah,
I missed that.
Exactly.
Okay. Good. Then that's my question. Thank you.
So my question is, you mentioned 2 types of seizures during this. Is the assumption that other types of seizures would also be reduced with this?
Yeah, so here's how we think about this question, right? So mouse is not human, right? Mouse brain is a lot simpler. So in this particular model, they are only able to generate, at least as far as we can tell, 2 types of seizures. But in human individuals, there are many different types of seizures, probably because the mouse brain is a lot more complicated. patients. However, we believe the underlying biology are similar between mouse and human. In fact, the STXBP1 protein itself is 100% identical between rodent and humans, right? So we are hoping if we correct the underlying genetic or molecular problems, and then the biology is going to do its job correcting wherever the downstream problem is, right? So in this case, we correct the 2 seizure type in rodents. We are hoping the same thing will happen, but to all different seizure type in human patients. So.
Perfect, thank you.
When you had the different levels of the correction introduced, did you attempt to reach a point where there were negative outcomes, or perhaps from producing too much of the protein, or was that not something that you observed at any of the doses?
Yeah, so we follow this animal for up to a year. So even for the highest dose, we have not seen anything obvious. But we also have done a study where we just take a normal animal and give them the high dose of AAV gene therapy, and we didn't see anything very unique or special there either. So perhaps because the so-called high dose we use is not really ridiculously high, right? So still reasonable range. We increase the protein level, but it's not something like 10-fold or 100-fold increase, right? This is not going to happen in clinical trial either. So that's basically the thing we were able to test. So
wonderful, thank you.
Okay, thank you.
Thank you, Mingshan. I'd like to introduce our next speaker, Scott Demarest, who's an Associate Professor of Pediatric Neurology at the Children's Colorado Hospital. I don't think Scott has any cool mouse videos in his talk, but nonetheless, Scott is going to give us a talk on kind of clinical trials for gene therapy, what to expect, how to prepare for them. All right, so Scott.
All right, thank you, and thanks for the opportunity to come and chat with all of you today. This is me, and I'm sure that everybody is very interested in hearing about the Capsida trial and what's happening with that and where it all fits in, and I'm not going to talk about that at all. Melanie's going to talk about it in the last talk of the day, so you're not allowed to sneak out early. But I hope I can kind of set the stage for it a little bit, and I'm going to jump a little bit from, okay, we've talked about theoretical ways in which we can treat things, to treating them in mice, to what does this look like in people, what is involved in actually doing these treatments. And my goal here is to try to help everyone in the room who might be facing a decision of, do I actually want my kid to participate in one of these trials, to have some of the background information to help you with that. The specific details of any one trial, I'm going to leave to the companies who are running those trials to talk about, including Capsida. So that means we're going to talk about what a gene therapy is. Jim already helped us jump off for that a little bit. What are those risks and the potential benefits look like in a clinical trial? And then what is kind of the clinical trial process, and what do we need to think about for that? This is pretty similar to the broad definition that Jim provided earlier. Gene therapy is seeking to modify or manipulate in some way the expression of a gene to alter biological properties of a living cell in therapeutic use. What the heck does that mean? So this means that if you have a gene-based issue, we're going to try to adjust that so that we can solve the root problem of the issue, that gene or the products of that gene. And when we say product of those genes, we mean proteins, as Jim set up for us really nicely in his talk. Okay, that's fine. So we've got cells in our body, and for us, we're primarily interested in brain cells. Mostly neurons. We have other types of brain cells as well. We've got like a few billion, trillion brain cells. So that's important. That's the unit we're talking about here. We have to try to get a treatment into all of the cells so that those cells can then use that DNA instruction to be able to create a protein that does the function we need it to do. Jim already talked about this, so I'm not going to go through a lot of details, but this is, again, the idea is we have DNA, then we have RNA, then we have protein. That's the really simple way of thinking about this. Every one of our cells does this constantly for all of the things that that cell needs to do. It's got thousands and thousands of different gene instructions that it's using constantly to make that cell function the way it's supposed to. And our brain cells, our neurons, have very specific ways they need to function in order to work properly, talk to each other. That's a big thing for STXBP1, and have a healthy brain. So genes and proteins. So the gene is, again, the DNA coding. The protein is what actually does the function that we care about, and the RNA is sort of the in-between step. This is actually kind of a reference slide, so I'm going to skip past this. But I've included here a video that I think people could link to or watch on their own time, just to sort of get a sense of like, what does that actually look like in our cells? There's some nice animation about how we use DNA to make proteins in cells all the time. All right, so this is again what Jim sort of set up, right? We have different ways that we can treat this. We can target the DNA level, we can target the RNA level, we can target the protein level. All of these are being done. There's examples of these that are actually FDA approved in each of these cases. I listed Capsida here in the DNA one because that's where we're targeting. We are replacing the gene that's not working properly. Jim talked about RNA approaches. Nusinersen or Spinraza is an example of one of these, one of the first that was approved for something called spinal muscular atrophy. It's also a neurologic disorder, but it's a pretty different one. It's a neuromuscular disorder. It doesn't have quite the complexity that brain disorders do. It's just about our nerves that go from our spinal cord out to our muscles. So it's a little bit simpler system, but ASOs were used in that case and still are to treat that condition with really incredible results. There's other conditions where we have brain-based disorders where we don't have the final protein. Instead of doing the DNA or the RNA, they just jump to the final product. They give the protein. So there's pluses and minuses on each of these. DNA, as Jim set up really nicely, and we'll talk a little bit about, one and done. That's the goal there. RNA, this breaks down over time. Our cells break down our RNA. Even the synthetic RNA, which is all that an ASO is, it's a synthetic RNA designed to hang out longer in your cells, so it lasts a few months, but it still gets broken down, so you have to repeat that dose. And in this case, for neurologic disorders, you're generally talking about a lumbar puncture, so you have to kind of get into the brain space, and you can do that by accessing the CSF and the spinal cord. So you go through a lumbar puncture, you inject that ASO, and then you have to do that every 3 months for that type of treatment. For protein, again, you got to get into the brain. It's not easy for most proteins to be given IV and actually get into the brain. So we have to somehow get past what we call the blood-brain barrier. We get into the CSF, that goes around to our brain. But proteins last even less time. So usually you're talking about 1 to 2 weeks max that a protein's going to hang out before our body breaks it down. So again, you have to give repeat doses, and that can be a complicated process to try to do. I'm going to talk the rest of the time about the DNA-based approach in practice because that's kind of what's immediately before our community. So the goal, again, is to correct or replace the gene that's causing the disease. Ideally, this is one time, and we really, really have to think about safety, and that's what I'm going to harp about. So how do we get our replacement gene into every cell in the organs that matter, and what kind of things can go wrong? That tends to be actually the really hard part. The actual gene itself, we can make the gene, we can tell our cells to use the gene. We have to give a little bit of instruction that says, cell, use this gene that's hanging out there. But getting the gene and that instruction into every cell where it's important is the hard part. So we have some things we think about in general, not specific to STXBP1, but are these cells replicating? So if cells are replicating throughout our life, like our blood cells, for example, if you just went and replaced it, then every time it replicates, only one of those cells is going to have that copy, if you got one copy in there, right? So you would lose that effect over time. Neurons don't replicate, so neurons, we think, are going to be okay. We think if you get it into that cell's going to have it for the life of that neuron. Sorry, we don't replicate neurons. That's why we all get old and then our brains work less well. But that's good news for us because it means that we can replace it one time, and we think it's going to last a long time. And in humans, we have evidence of years of it lasting. In animal models, we have years. We don't have 2 decades, 3 decades for it. This technology hasn't existed long enough. But we think it's going to hang out for a long time. Non-neurons in the brain do replicate. So to the extent that that is an important part of what's going on, that could be an issue to think about. Other organs are more complicated. They have replicating cells more often. We're not going to talk a lot about that because it's not as important for STXBP1. We also have to worry about, does it do anything else when it gets in there? Does it cause any problems? When's the timing that we need to give this? That's a big question for neurologic disorders. Does earlier make a big difference compared to treating later? And the answer is we kind of have some sense of this. We used to think, if we rewind like 10 years ago, we would say, you know, you got to do it right away or you're not going to get any benefit. And we actually have seen from some of the other trials in other neurogenetic conditions that that's probably not true. That teenagers have experienced meaningful improvements in some of those trials. It's exciting. We don't know how much that changes. Okay, so that's still a question that science hasn't answered, and these types of trials are going to try to answer. But we do know that it's not like there's no prospect of benefit as you get older. So we're going to try to answer those questions together. So what are we really talking about with this? And Jim talked a little bit about this. I have a slightly different figure that shows the same thing. We're going to use this virus that we've adjusted, reprogrammed, and Sean's done his work, Capsida's done their work, other companies are doing this, to try to give it properties that help us get it to every cell that needs it one time, not 20 times ideally, and to not cause problems when it's doing it. So what kind of things can go wrong? There's a lot of scary things on this slide. This is the like Debbie Downer of the morning, guys, I'm sorry. But we need to be really honest about this when we're talking about gene therapies. I'm super excited about aiming for cures. We've talked about cures a lot today, but we need to talk about what are the risks. So when we're talking about a viral vector gene therapy, there is a tension between trying to get a new copy of the gene into every cell in the brain so that we can have the biggest impact for good. That means we want to give as many viruses with that payload as possible. The more viruses we give, the increase the risk. Because that is something our body's going to react to. Our immune system is designed to attack viruses, to get rid of them, to protect us. We are harnessing these viruses to try to do this special thing for us, but in the process we are going to get some immune response and we can get some other challenges. One of the big ones that we've seen is that we can stress the liver. The liver is a big filter for our body. It does a lot of things to try to keep us healthy and get rid of toxins. So we can stress the liver and we can even cause the liver to fail. And this has been life-threatening and has resulted in death in patients who have received gene therapy in the last year. Okay, this is a really serious thing. It can lead to challenges about the way that we clot and our blood, either clots or bleeding, and so we can get bleeding into organs that damages organs. We can get clots that form that can damage organs. We can get damage to the heart and the heart muscles as a result of inflammation from the virus getting there. We can get damage to our nerves, specifically the nerves that are coming out of our spinal cord that go down to our muscles. Those are nerves that just tend to take up these viruses very strongly, and sometimes it can damage those nerves so that they don't work as well. We talked a lot about the immune system. You can really get a very, very strong immune reaction, and in some cases, that can look like what we call sepsis, which is a systemic, very, very sick individual who's got a really strong reaction that puts them in the ICU and can be life-threatening. So the immune reaction is something we have to take very seriously. And I have to list the last thing here, which is death, because this is happening. There are many, many more patients who are benefiting from gene therapies than are having these really serious complications. But we are still in the infancy of treating humans with gene therapies. Gene therapies have existed for a long time, as Jim said. Decades of knowledge and experience have gone into developing the treatments that are now hitting humans in the last decade, but we're still very much in version 1.0 of gene therapies, of trying to do this and learn about what is the best way and the safest way to do this. And some patients still have harm happen as a result of this. So how do we try to avoid those negative consequences? The mainstay of the vast majority of gene therapies that are out there is steroids. So steroids are a way that we can blunt the entire immune response to things. And we're usually talking about pretty high doses of steroids and for a decent amount of time, like 4 to 8 weeks, kind of depending on the protocol and the gene therapy and the trial or treatment that you're talking about. Steroids can be kind of nasty. Like they're okay for like a day or 2 or 3 for those that have ever experienced that. But for longer periods, they have their own side effects. And in some cases, we're going to have to use other drugs to manage the side effects of the steroids that we're using to manage the side effects of the gene therapy. So things like controlling our stomach acids and stomach irritation. We're going to have increased vulnerability to infections potentially when we're on steroids for a long time. Steroids affect our mood. They can lead to significant irritability or aggression or behavior challenges in children. It can in adults probably too, but we can control that maybe a bit more. It can affect your blood pressure and your kidney function and things like that. So there's a lot that we have to do just to monitor the treatment that we're doing to try to protect us against the treatment we're giving. Sometimes we need to use other types of immune suppression beyond steroids. So sometimes it's steroids plus other types of immune suppression. And this really requires very close monitoring. I've listed 8 weeks here. Depending on the gene therapy, there's kind of different windows of time in which we consider the at-risk time. So when you're actually giving a gene therapy, whether it's IV or into the brain or wherever it is, you can get an acute reaction to that foreign thing that's going in. But you can also have a little bit of a delayed reaction where that liver injury and the immune response can happen in the weeks following a gene therapy. So really close monitoring by the treating group is necessary, minimum of 4 weeks, ideally even a little bit longer than that. And that's going to be a little bit variable from one protocol to the next. But very close monitoring is our important way of reacting if anything comes up and trying to make sure we're treating it. What about the long-term risk associated with gene therapy? There's a lot we don't know about this. Because again, we just haven't been doing it that long. So it's hard to say what's going to happen 10 years or 20 years from now from a gene therapy. So we're learning that as we go along. AAV vector gene therapies, the ones we're kind of talking about most relevant right now, generally are not supposed to do what we call integrating. What's integrating? So we're going to take this little bit of DNA and we're going to try to get it into all the cells. Integrating means that it actually goes into our chromosomes, to our DNA molecules. We insert it into them. That is not what AAVs do. They just hang out in the nucleus like an extra little piece of DNA. It's not in the DNA that our bodies naturally have. Why does that matter? Because when we insert it into our DNA, we might insert it someplace that actually causes a problem, that disrupts something that is also important in that cell, some other coding region or instructions. And often we worry about that can cause cancer. More recent evidence with AAV does suggest that it is mostly not integrating, but sometimes it might. So there is some risk that we need to think about, at least theoretically, of things like cancer long-term. We don't know how much of a risk that is. We think it's probably quite low, but we need to acknowledge it and monitor for that for anyone who's had a gene therapy. We talked a little bit already, how long will this last? How long does it stick around in the cells? We think, again, for neurons, quite a long time, but we don't have a perfect answer for it, and we're going to have to follow that. So what about expectations? This is what you guys are all sort of like, okay, well, what is this? What is a cure? This is the way I define a cure personally. A cure is you don't have disease anymore. I love talking about cures, and that is ultimately the goal. But getting to a cure is an iterative process. That is not a one-shot thing. We don't just do one treatment and now we're at a cure. We do a treatment and we get closer, and we do more treatments, or we iterate that, we make it better, we improve on it, and we get closer and closer to cure over time. This is going to be a decades-long process. I'm just trying to be very realistic and honest. And I feel like I'm the Debbie Downer of the entire meeting here, and I apologize. Everybody's like, yeah, cure! And I'm like, okay, but we're not getting a cure. I hope we get as close as possible to a cure. I hope that we are making dramatic improvements in function, reduction in symptoms, but actually getting rid of disease is not what we're talking about or would expect based on current technologies. Our ability to get it into every cell and do it in a way that is safe is probably just not there. So we are hoping to alter the course in significant and important ways, reduce seizures, we hope all kinds of seizures, reduce other symptoms that are problematic, improve function, communication, motor, etc. The point of a gene therapy is to try to make all the things better. How much of those things are going to get better, which ones are going to be most impacted for the better and which are not, we don't know. That's why we're doing a trial. The fact that it is a trial means we don't know what the outcome is going to be. Otherwise, it would already be FDA approved and we'd be treating people with it. So we are going to continue to follow that. We're going to look at what's the risk. There is a chance that in making some things better, you also unearth other issues in an individual. Particularly, you might see, well, they never really had any issues with behavior. They are now more functional, they have more opinions, they have more ability to express themselves, and that comes out as more behavior challenges. We've seen some of this in other disorders, and so this isn't totally theoretical, but it's something that can happen and we should be aware of. We're hoping to improve lots of different things and ultimately get to improve quality of life, but the reason we're doing the clinical trial is to figure that out. Important thing here is the AAV is how we get this into the cells, which means if you have been exposed or the individual being treated has been exposed to AAV previously, they are not eligible for these types of treatments. The immune system is primed and ready to react in that situation. We already have antibodies, and so if we were to treat in that situation, we would have a very high risk of a very strong immune reaction that would be dangerous. There is no way of knowing whether an individual has been exposed to AAV previously or not without testing for it with a specific lab. That is the first step in most gene therapies trials, is to actually screen for whether someone has antibodies against the vector that is being used so that you can determine whether someone can safely get that or not. Because of that, this is one shot. People are working on thinking about how can we get things into cells in other ways, other vectors, other stuff like that. But for right now, we should say, if you get an AAV gene therapy, you are not eligible to get another AAV gene therapy at any point in the future. That's what I mean by it's one shot. Because you will then be primed, just like having been exposed naturally to AAV, you will have those antibodies and no longer be safe to treat with an AAV gene therapy. Last little bit here just to kind of set how are clinical trials done. We've had a little bit of discussion about this already and at prior meetings. We've talked about doing lab studies. We've talked about animal studies that all lead to this. The first part is then to say, can we do this safely in people? And that's our number one goal, what's safe? And then we want to say, can we do it safely and what's the best dose that gives us the best chance of helping and the least risk, managing those. And then we move on to treating larger numbers of patients and really demonstrating, yes, this works and it continues to be safe. And then sometimes we even do these really last stage things, which we would expect in a gene therapy, which is the FDA says, great, you can do this, treat who you want, but you need to continue to monitor because we want to know about really long-term impacts and larger populations. A lot of times for rare disease, we grab these first few human components and push them together. Because rare diseases are hard to get lots of patients, we try to get as much information as quickly as possible. So we do combined phase 1, phase 2, where we're really focused on safety. We're also trying to figure out dose, and then we move to larger numbers of patients. But this is still usually very small numbers of patients in these first few phases of a trial. And so many patients may be interested or eligible more than we can actually treat in a trial. And that can be frustrating for families, and I get that, but part of why we're doing that is if we treat 10 patients at the same time and then find out there's actually a really serious safety problem, we've now exposed 10 people to that safety issue rather than one. So if we go one at a time and are really careful until we can say, we think this is safe, now we're gonna treat more patients and do it more at the same time. That's one of the ways we try to protect against harming people. And we need to be really focused on that with gene therapies. So really quick summary, lots of awesome efforts about developing various novel therapies. I've talked to Jump about gene therapies, but you saw the development pathway. There's other types of modalities that are also being developed. Gene therapy clinical trials are getting started. These are high risk. We're hoping for high reward also, but we need to be really careful and thoughtful going into this. And it's a discussion for every family with each of you about what makes sense for you. And that's what us clinicians are all here to do. We start with really small patients for good reasons, even though that can be frustrating. It helps us make sure that the community is safe as we are learning about this. And hopefully, as we see safety and efficacy, we get to bigger and bigger patient populations and more people that we hopefully are impacting for the better. And that's it for me. Thanks. I don't know if we have time for... No questions? No questions. I'm blaming everybody before me.
Yeah, if you have questions, Scott will be around. And I think go to Scott, make him feel better. That was not a Debbie Downer talk. That was, in fact, very useful, and I'm glad that he gave that talk. Everybody really needs to understand what gene therapy are, what the risks are for gene therapy, so that everybody goes in with open eyes. But yeah, find Scott if you have additional questions. So next I'd like to introduce Ingo Helbig, who's going to give a talk on STXBP1 clinical update. Ingo probably doesn't need any introduction, but I'm going to give him a little one anyway. He's Associate Professor of Pediatric Neurology at Children's Hospital of Philadelphia and a recent American citizen this year. And he is also the principal investigator of the STAR Natural History Study. And so without further ado, I give the microphone over to Ingo.
Yeah, so thank you, and maybe just, Jim, to add to your comments and to Scott's comments, just so that everybody know that safety is really on all our minds right now. So this is many of these things happening that families don't often see happening in the background, but we're really, really concerned about making this as safe as possible. So what I'm typically doing every year during the summit is to give a clinical update on STXBP1. This is the first year where I'm actually cutting down on my content. Because Scott just gave a very great overview of our trials, so I don't need to do this anymore. And then we have Sarah afterwards talk about the STAR study. And this has become so enormous and so impactful that I'm just going to focus on the basics here. Yeah? I wanted to explain STXBP1 for the families who have already heard this, but also for the families who are hearing this for the very first time. This used to be 5, now it's 4 bullet points I cut down. And we're going to talk about the fastest growing knowledge. So STXBP1 still holds the title of the rare disease with the fastest growing knowledge. I think this came up during a Simon's meeting 2 or 3 years ago, and no one has beaten us since. Yeah, a little bit of competition is always good. Yeah, I'm going to mention seizures. I will talk about what we know about the development, and then an ongoing mystery that is slowly dissolving, but is still worth pointing to is what we call recurrent variants. So as you may know, there are some genetic changes in STXBP1 where we have more than one patient with the same variant, and those are called recurrent variants. So here's my little build-up of what STXBP1 does. And I think you've seen different versions of this, but I always like to point this out for families that were in the brain, we're in the nerve cell, which is called the neuron, and then we're zooming into this kind of part where two brain cells connect to each other. And this is the synapse, and this is the S in STXBP1. And what STXBP1 does at the synapse is helps these little bubbles, which are called the vesicles, to open up and release the neurotransmitter. And sometimes in clinic, when I explain this to families, I use the analogy of the impossible task of trying to stitch together soap bubbles. Yeah, you can imagine if you sit in a bubble bath, you try to kind of merge bubbles, you end up with 1,000 little bubbles. Yeah? And what STXBP1 does, it accomplishes this. It's part of a machinery that is able to kind of stitch together soap bubbles. Yeah? And so this is what STXBP1 looks like. It is not a very memorable protein, but it is a protein that is important to help our brain cells communicate. And as you've heard this from Mingshan and from Jim, if there is no STXBP1, brain cells can't talk. So this it's a little bit kind of boring now because Charlene, your slide was so much more powerful, but here's just my view on how we've slowly ramped up our studies on STXBP1. I focused here on some of the scientific publication and milestones. Again, it was found less than 20 years ago, actually. Yeah? And now we basically have first gene therapies on the horizon. And this is backed up by an entire data that comes from disease concepts model that I'll talk about briefly, and lots of information about clinical data on large patient cohorts, but also in natural history studies. So first, when you have any disease and you know nothing about this, the first thing that we would typically do is a so-called disease concept model. And I have to say, it took me almost 2 years to understand what a disease concept model actually is, after Charlene had been nagging me for time and time and time after again. Yeah? So a disease concept model is kind of just a reflection of what you perceive STXBP1 to be like. It is the lived experience of, in this case, caregivers. And we typically divide this up into the actual symptoms that we see. But in many cases, for example, autism or behavior is a symptom, but the really question is, how does this impact? Yeah, does the symptom impact? And then there's, of course, the impact on the caregivers. So those are three domains, how STXBP1 affects people's lives through symptoms, through the impact of these symptoms, and then through the impact on caregivers. And what we've seen here is our study by Sullivan that I think Jim was referencing earlier. And this just shows you how the different components change over time. For symptoms, we have behavior, cognition, developmental differences, and seizures, and they change over time. It moves from seizures to developmental issues. And then the main thing is the symptom impact. How does this impact families? Schooling, autonomy, sleep, socialization are the main thing. And then, of course, how does this impact caregivers? And over life, we've seen this a very strong emotional impact. So this is STXBP1, lived experience. And this is something that we've presented now, I think, 3 or 4 times in settings with the FDA. And this gives people a very good idea of what we're actually up against. When we look at clinical data, we know that STXBP1 is a condition like no other. And what has puzzled us for a very, very long time, that STXBP1 was so hard to grasp. You had one clinician at one center that saw 5 patients, and they all had epilepsy. And then you talked to someone else in an autism center, and all patients had autism, but no one had ever had seizures. And then you talk to a movement specialist, and they had seen lots of patients with tremor, and some of them had epilepsies, and some didn't. So what we have seen, I think this is very important, especially when we think about trying to find our STX twin, sometimes our variant twin with the same genetic change, or a patient or a child that had the very same features at some point in life, that they may diverge afterwards. So we have patients who have the very same genetic change, but have completely different presentations. And we have patients who start out the same, but then work on 2 different trajectories. Our task over the last 5 to 10 years has been to kind of try to understand this, outline this, and make this predictable for trials. Yeah? If you cannot go into trials if you do not know what you're actually looking for. What you see here in the middle, is a so-called radar plot. And this just lists 50 of the most common features in STXBP1. We have seizures, different type of seizures, we have developmental differences, and we have now, in a way, outlined the entire spectrum of STXBP1 across more than 500 people. We know we have consistent symptoms. These are developmental differences, hypotonia, absent speech or speech differences. And then things that are variable is often when seizures happen, how severe the impact is, how severe the tremor is, and if children have what is called spasticity, which is the features that may look like cerebral palsy. So let's break this down into two different domains in this case, development and seizures. And this is not meant to be exhaustive. This is just meant to give you some of the, addressing some of the main questions that we had. Here is an outline now of 170 individuals with STXBP1, where we have reviewed seizure histories for every single month of this person's life. Those are the first 20 months here, and you can see different seizure types in different colors. Yeah? One of the most prominent seizure type, especially in very young children, is what is called infantile spasms. So those are seizures that your doctors will talk to you about in the first year of life. Those are seizures that we try to be aware of in the first 6 to 12 months. We know that they do not happen after 24 months, but this is a very important seizure type to be aware of. And we typically counsel all our families to know what these seizures are so they can react quickly. Yeah? And you can see over time there are other seizures. There are so-called focal seizures where only part of the body is affected. And there are generalized seizures where the entire body is affected. This spaghetti plot on the top right is our attempt to show how every single patient moves through different intensities of seizures over time. And this is one thing that took us really just a decade to really try to express in words, that STXBP1 can be extremely variable in the first year of life when it comes to seizures. So you see lots of blue and yellow lines going up and down. And you probably know this from your own discussion with other families or with your doctors, that sometimes seizures and STXBP1 behave very unexpectedly. Suddenly they respond and they're gone. Sometimes they're very refractory and we don't understand why. So this is a study that we performed 2 years ago, where we tried to go into this very first year of life. We know that 90% of seizures in STXBP1 start in the first year of life, but even there, we didn't really have a good sense on what seizure types happen when, and if there's any connection between seizure types. Do seizures in the first month, for example, make our children more predictable to have seizures later? Do we know at some point that we have to look at surgical therapies, that we have to look at dietary therapies very, very early because seizures are unpredictable? And the answer is we didn't actually know. Here, this looks at a weekly presentation of seizures in children who had infantile spasms. So the seizure type that happens in 40 to 45% of all our children, and that is often linked to very severe behavioral and developmental consequences. What we've seen here is that even in children who have infantile spasms, we cannot predict them. It becomes very, very tricky. Yeah? What we've seen, though, is that the last 3 months of the first year, between the age of 9 months and 12 months, this is the window where we can actually really predict whether a child is going to have seizures or has a good chance of being seizure-free. And this is something that we've used clinically since we discovered this two years ago. The age between 9 and maybe 12 months is the period where we have good chance of predicting whether seizures will go away, or whether these seizures will continue. This needs lots of refinement, but what was important for us is to have some information out there to see, are we dealing with an epilepsy where we have to, where we can think about taking medication off, or are we looking at an epilepsy where we have to be more intense in terms of treatment? And this has led to this one. This is actually one of the figures that actually inspired some of the outcomes that we're looking at in the Capsida trial. The ups and downs, the times when seizures become predictable and the times when seizures in STXBP1 become unpredictable, gives us windows. Yeah? And you can see here what is shaded in blue is a window where we know that seizures become very predictable, and we can use this information to actually look at patients where we know that we have a very good sense of what is going on in the next few months, if not in the next few years. Yeah? Bottom line is that our kind of understanding of our STXBP1 data can be very precise. And what we're doing right now is actually that we are running simulated clinical trials. So not actual trials, but we're kind of trying to go over this data and say, how would this look like? When are good windows for development or for seizures when we can intervene? Here's another point that I brought up last year, but I want to emphasize again. Clinically, many families, understandably, are very concerned about what is called seizure recurrence. Yeah? And you've seen this in the STX groups and in your discussion with your providers and other families. The question, do seizures come back during puberty? Yeah? Is there anything happening during puberty that kind of may help seizures come up again if they have been quiet for quite a while? So we looked at this across more than 500 years, where we have monthly data on seizures in our STXers. And the answer is we didn't really see this. So here is an example of what is called seizure recurrence. We asked the question out of our 114 patients that we had enrolled in our STXBP1 studies, how many of them had seizures coming back after seizures had quieted down initially for at least a year? Yeah? And this is one of the data sets that you can really use. This is really kind of data to inform this, trying to be a bit more precise, and there's this kind of feeling that something may happen. The answer is 4%. Yeah? We know that roughly 1 in 20 people with STXBP1 may have a problem having seizures coming back, but this is not linked to puberty. This is not linked to any phase. This can happen at any time in life. But again, this is only true for 4 to 5% of all patients who had seizures in the first place. So what have we learned about development? STXBP1 is not just an epilepsy disorder. STXBP1 is what we call a complex neurodevelopmental disorder with epilepsy, developmental issues, and many other features. So this is milestones for STXBP1 shown in two different ways. On the left, you can see certain milestones that are achieved. For example, the ability to walk, the ability to kind of use words. Yeah? And I'm going to focus on walking because this is, I think, one of the time points that people can understand quite intuitively. So we know that 90% of all our STXers who will eventually walk do so by the age of 5. Yeah, and this is not so much good or bad. There's no value judgment to it. This is just information of what our patients do. Yeah? And this is important, especially when we have children who have very low muscle tone in the first years of life. And there's this kind of thought is, will they ever be able to sit? Will they ever be able to walk? We know that many children eventually will, but it takes until the age of 5 to actually get there. Yeah? 90% but by the age of 5. Again, here, we're trying to use information, we're trying to use data to put some of these concepts into very clear meaning and very clear kind of statements that will help you to understand where is the natural history taking us. And on the right, you can see an overview of specific, more finely grained milestones, the ability to vocalize, to use nonverbal communication. Yeah? How many individuals achieve this? This is very important, especially when we have families of young STXers who kind of read all this. Yeah, we had this earlier. If your doctor tells you to Google, then you will come up with these things all these things that our patients will never do. In reality, it's way more nuanced, and we know that the vast majority of our STXers have a very good way of communicating non-verbally. So here is now these things putting together. So we're going to use the same data again. We use milestones, we use achievements, and we're going to ask the question, what would we actually expect in a gene therapy trial? And what I'm going to show here is like two measures. I think Sarah will kind of mention them in a bit more detail afterwards, but what we do in STAR is that we take all these ideas of gross motor or language or cognition, and we apply scales. So there are instruments out there. This is why natural history studies take an entire day for a single patient. because we apply all these specific measurements to ask the question, where is a given STX at a certain age for a certain scale? And what we've done here, for example, we've used this data to say, how would STXBP1 look like if it was 10% better? We're anticipating what will happen in gene therapy trials and other trials by just saying, let's just kind of use our data and just suggest that this might happen, and then we can, in a year or so, go back and say, how does the actual data compare to what we had? So this is what natural history data is very, very important for. This gives us the baseline to where our patients are, especially in very complex conditions such as STXBP1. The last thing I'm going to talk about are the mysterious recurrent variants. Yeah? And the way that I want to think about this, I just got the 2-minute warning, but I'm on track. You're not going to gong me out, Charlene. Yeah? So the recurrent variants are actually quite interesting. So let's think of this as an ongoing STXBP1 mystery that we're still trying to fully understand. Here again is STXBP1. The colorful figure with the spirals is a protein model of the STXBP1 protein. So this is what it looks like. And at the bottom, we've taken this protein and stretched this out. Yeah? So the colors match roughly where these certain domains are. And what you see there as these lollipops popping up are specific genetic changes. And the lollipops that are very high are genetic changes that are recurrent. For example, the highest one is the 406. This is the most common single genetic change in STXBP1. At the top left, you can see just counting how many people have this, and we know that worldwide, we now are aware of more than 50 people, for example, this is a little bit older, but more 50 individuals who have a recurrent 406 variant. So what do these variants do? The answer is, even today, we don't actually know. Yeah? We think that largely STXBP1 is a condition that is haploinsufficient, what Jim introduced earlier, that STXBP1 is due to not having 2 functioning STXBP1 copies. But there's a bit more detail to this. So here is again this graph that I had earlier about the seizure frequencies in our patient with STXBP1. And you can see when we break this down into mutations that break the protein and some of the missense changes that are spelling mistakes, we actually see a difference. Yeah? Here's now one idea, and I'm going to just put this up, not so much to be fully understood, but to just give you an idea how we try to plot the seizure intensity in our STXers across the entire protein. And in the middle, you can see lots of dark red dots. And I think the latest thought that we have is that there is some sort of maybe change in STXBP1 with regards to seizure frequency and missense variants. But it's way more complicated and way more nuanced than we would have. And probably it's not really in the recurrent variants itself. Yeah? I'll leave it here. I'm actually running out of time, Charlene. Yeah? So I just wanted to give you my yearly update on the clinical aspects of STXBP1, fastest growing knowledge. I'll finish with this. Yeah? I'll give you an update on what we know about seizures, development, and the mysterious recurrent variants. Thank you.
We're going to take quick questions, real quick. Anybody? Questions for Ingo?
So I finished on time. I should get more than one question.
Okay. Does anybody have 2 quick questions? Questions? If you think of questions later, Ingo's available, right? Ingo?
Perfect. Thank you.
All right. All right, everybody, we are running way behind, so I apologize for that. We are supposed to be taking a break. We were supposed to take a break already, but I have just a couple announcements before we go to break, real quick. First of all, we have a wonderful author who has a book, How to Handle More Than You Can Handle. Amanda Griffith-Atkins is here with us. She has her books available in the lobby. She's also speaking tomorrow. She'll be also doing a session for us this afternoon. More information on that to come, but please see her in the lobby. Also in the lobby, you'll find Searchlight. Please check them out. They are one of our wonderful partners. Capsida has a table. Please go see Capsida if you have questions for them. They're happy to answer them. Lundbeck is also in the lobby, and they have a study you might be interested in. And then also, please remember we have research happening. We want your blood. Okay, we have research happening down the hallway right before you get to the lobby. There's a hallway. Please, please, please consider participating in research, you guys. This is an amazing opportunity. You are here now, and you can make that happen, okay, for this community. And then I I think that's it. So we'll see you guys back in 10 minutes. See you guys. What time is it? 10:50. 10:50. All right, please take your seats. Let's get started. All right, come on in. Let's take our seats and we'll get started. All right, come on in. We've got Allison Michaels with her parent story for us, her family story. And we'll give it away.
My family is going to try and join. We'll see.
You got it? And I see, Allison, you're joined by somebody.
Yes.
Go ahead and get started.
Okay. Hi, everyone. My name is Allison Michaels, and I'm going to give you a little bit of our story. So I'm here today joined by my family. For the first time, all four of us are actually at a conference. My husband and I have been at a few. My daughter and I have been at a few. Mason was at the very first one in 2019. But it's really exciting to have all of us here. I'm here with Ed, my daughter Harper, who's 9, and Mason, who is 7. Mason is our STXer. I actually kind of want to start at the end of the story, or at least where we are right now. Today, we live in Colorado. As of Monday, we moved here. So, I know. And we're a ski family. And if you would have told me that when Mason was diagnosed at 6.5 months old, I would have never believed you. Back then, we were just trying to survive. We were trying to understand what the diagnosis meant. I didn't know what life was really going to look like, but for sure, I didn't think it was going to involve ski boots and mountains, and yet here we are, and it's really hard. It's been really hard, and yet it's been really, really beautiful. So Mason was 6 months old when we got the diagnosis. He had infantile spasms, really low weight gain, and extremely low tone. Check, 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 everything that Ingo was talking about earlier. I remember the conversation. I remember the way the doctor's voice changed. I remember the way that time really started to slow down. It was devastating. We grieved a lot. We grieved the life that we thought we were going to have. We were scared of what we couldn't control. Like many of you, we were thrown in a world of specialists, procedures, emergency protocols, and round-the-clock care. And we faced realities we were not prepared for, like seizure management or seizures coming up without warning, feeding tubes that became necessary, layers of complexity that stretched us emotionally, physically, and financially. And in the middle of it all, we loved him deeper than we ever thought possible. We became fluent in a language of medical acronyms, G-tube care, seizure management, and we learned how to advocate for him in hospital rooms and in school hallways. We've discovered that resilience isn't just about surviving, it's about thriving and showing up again and again. So, yes, having a non-speaking child is really hard. There's grief and sadness in not hearing mama or I love you the way that I expected. And then we discovered AAC, augmentative alternative communication, and a whole new world opened up. We started learning Mason's language, and he started showing us his world. Just last week, he was using his eye gaze, and he asked me and my mom, what do you like to do? And before we could even answer, he said lounging. And if you know me or my mom, that is not anything that we do at all. So it was quite hilarious. And then I just have a really short video of him participating in Trick or Treat. So let's see if this goes. Trick or treat! Trick or treat! Go Mason, yeah. All right. Yes, this journey has been really hard. It's tested our relationships, our marriage, our friendships, and our family, but it's also deepened our bonds. We've learned how to show up for each other in ways that have mattered most. We've grown together in every hard conversation, every worry, and every small moment of joy. Yes, our other child, Harper, sometimes gets less attention, and that's really hard. And she's growing up with empathy and grit and a front row seat to what unconditional love looks like. I cried this morning when I was practicing this too, right here. She's not just a sibling, she's an advocate, she's a teammate, and she's one of Mason's biggest cheerleaders, if you know Harper at all. And you can see my lovely photos. Okay. Yes, I'm gonna go back one. Yes, this feels isolating. Watching other families reach milestones we're still working towards even after all this time. And yes, it's also true that we're not alone. These are the few other STXers that joined us at a Move to Cure event a couple years ago. And the one in the pink, her and Mason actually were at school together too, so it was a lot of fun. Yes, it's really hard, but there are other families, there are other therapists, there are other advocates who truly get it. You all in this room, people who show up, people who remind us we're not alone and we're in this together. So if you haven't participated in a Move to Cure event, it's an incredible way to get your community connected. And I've got a really great video from a few years ago, and this is just a good example of what Harper is like for cheering for her brother. Mason, 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 Mason. So Mason's walking across the finish line with all his cheering. So cute. And if anybody has any qualms about the next generation, don't. They're fine. It's us that we probably need to worry about. All right, so therapy. Yes, we have spent countless hours in therapy. OT, PT, speech, feeding, in our home, and traveling across country for literally the best possible care. Yes, the progress can feel painfully slow. And we've learned to measure it differently, to celebrate moments, the inch stones, not the milestones. And it's so hard to put into words the smallest gains that make truly the biggest difference. Like, I remember exactly the time where Mason could sit in a shopping cart for the very first time. Yes, I used to count the delays, and now I count the connections, the courage, and the victories that no chart can actually capture. All right, celebration. Holidays and birthdays can be really bittersweet. They're reminders of milestones missed, and they've become some of our most joyful days. Every Halloween, we go all out as a family with costumes, decorations, the whole thing, because even Ed has a wig on that day, because it's Mason's birthday, and he deserves to be celebrated. We've learned that joy isn't about what's typical, it's about what's true for us and our family. This was really one of my favorites when my mom showed up as Captain Hook. I think we were all a little frightened. But it was great. All right, I'm doing good. Ski. Yes, we moved to Colorado for a fresh start. We have so many boxes to unpack, so if anybody's staying next week, feel free to come to our house and help. And in doing so, we've made room for something new. This was actually a picture of spring break when we were on the top of the mountain at Winter Park. We participated in their adaptive ski program, and truly it was incredible. And I wish I would have put a video of Mason skiing in here, but he absolutely loves going as fast as he can through the mountains, through the trees, and the highest peaks. But skiing has really become a metaphor for our life. learning to balance, falling down, getting back up, and celebrating every single run. As you can see here, we have like a little GoPro so we can watch his face and see him just like laugh. His dad whips him around all the time. I can just follow up really slowly behind. So this is us on the top of Winter Park not too long ago. Yes, the future is uncertain. You've heard it a little bit this morning, and we believe in it anyway. We believe in Mason. We believe in the science. We believe in the future where our kids have more options and more breakthroughs and more joy, because our story isn't over yet. There's a million things that Mason hasn't done. Just you wait. And that's us. He's an avid Hamilton fan, so. All right. Thank you, and I have 56 seconds left, and I will not take any questions, but follow me on Facebook for more.
I love it. I love it. And welcome to Colorado.
Yes.
Thank you, Allison, and Mason, and family.
Oh, that was great, Allison. Thank you very much. Okay, so I'd like to continue with our talks for this morning. I'd like to welcome Sarah Ruggiero from Children's Hospital of Philadelphia. She is a licensed genetic counselor and is very much involved in the STAR study. Really, she's everybody's boss in the STAR study, including Ingo's. But she's going to give you a STAR study update, and I'll turn it over to Sarah.
Thanks, Jim. Oh man, what an introduction. I like that a lot. I'll start off by saying the first thing, when I got the agenda for the conference, I saw that I was going to follow Mason and the Michaels family, and that was kind of my first thought, like, oh no, that's going to be hard to follow. It is hard to follow. We'll make it through okay. It's an honor to be here as always. I always love seeing all of your kids, seeing everyone. It's nice to see so many friendly faces in the audience. As Jim said, I'm a genetic counselor at CHOP. I have a role in kind of keeping the STAR study running in many respects, and I work at the CHOP site to take care of kids clinically as well. So I've been in the world of STXBP1 for a long time, and it's an honor to be here. What I'm hoping to do is introduce new families to the STAR study, because we always have new families joining the STXBP1 community. And then for the families that have seen this first part of the presentation before, I want you to see what we've been able to learn in the past couple of years because of the incredible activation of the community and all of you showing up so routinely for this study. It's been really amazing, and let's show you the progress so far, okay? So we'll go through what the STAR study is as a reminder, right? Let's talk about why the STAR study is important. What's the point of doing all of this? Can I participate? Where can I participate if I'm interested? And what have we learned in our first years of the study? That should say years. So first, what is the STAR study? So the STAR study is our first prospective natural history study that's intended to achieve clinical trial readiness. And there's a few buzzwords in that statement. So I want to explain what this means kind of step by step. So prospective means looking forward. So we decided as a community with the STXBP1 Foundation a couple years ago that we were going to design the study of all studies to put numbers on STXBP1 and follow kids over time to see what development, what seizures, and what communication looks like if we follow the same kid year after year, every 6 months, right? We have multidisciplinary experts to evaluate kids. So we have expertise from many different domains of medical expertise, many different medical experts that can all give their opinions and help you take better care of your child as we go forward. So it's based in clinical visits often. We perform tests of development. We take medical histories and we do thorough exams of your child. We ask a lot of questions before, during, and after. And this is all for the goal so that we can better define this condition, so we can give better medical care to your kids in the future, and we can give better counseling to your kids in the future. STXBP1 is a condition that is generally most often diagnosed very early in life. So what's most often, or what happens most frequently, is you all are receiving this diagnosis when kids are between 6 months to a year of life, right? And what we want to be able to do is give you a better trajectory of what to expect in the future and give you more specific information. Because right now the information that's given to newly diagnosed families is very wide, and there's a lot of I don't knows in that picture. And it's not I don't knows from lack of trying, but we want to fill in some of those I don't knows, right? And then, importantly, we need to prepare for clinical trials. So we have clinical trials that are ongoing. We have a clinical trial that's going to be starting up soon. And we need to be able to prove that these are working. And one of the ways that we can prove a clinical trial is working is by being able to have a great data set of what STXBP1 looks like typically, and then be able to compare it to what STX looks like if someone receives a new drug. So that's a big goal of our study, and that's why we're doing this. When we were designing the STAR study, our first question was, what is most important to families, and what are the domains that we need to capture? So this study has been referenced a couple of times already, but we have a disease concept model of STXBP1, where we interviewed parents systematically, and we defined what is most important to you all. We're defining the disease from the perspective of the people that are affected by it most. And these are kind of the top symptoms listed in order of importance ranked by families, or how many times they were mentioned by families. And so when we were designing this study, we kept this in mind, and we made sure we had a test for every one of these things that were mentioned. So when any participants of the study, when you're asking yourself, why are there so many questionnaires? It's because we wanted something to get at every one of these domains, right? This is a really busy slide, and you don't need to read all of it. The thing I want you to know is, there are a couple of key things to get away from this. First, there's a lot going on behind the scenes of the STAR study. So we get our data by asking you questions through questionnaires, by evaluating your children in clinic, and then we have some exploratory things that we're doing. So at some STAR sites, you might get an EEG, or you might get blood draws or cheek swabs. You might have sensors put on your child. And all of these kind of more exploratory measures, or all of these measures in general, we're trying to put numbers on STXBP1 and find aspects of the disorder that we could target in clinical trials, or we could try to improve in clinical trials. Okay, and now the exciting part. So how far have we come in the past couple of years? So we've come really far. You all have really come out in vast numbers to be evaluated at our sites across the country. So we have 146 individuals that have been evaluated in this study in just 2 years. And yeah, clap. Yes, you should clap for yourselves. And you can see there's lines on this line graph showing how many kids came back for visit 2, visit 3, visit 4. So these returning visits are going to become super important when we're analyzing the data. We want to see what the trajectory is for every child over time. And the only way we can do that is with return visits. You all have done awesome in coming back for these returning visits, and we have some great what's called longitudinal data to show you from those return visits. On the right side of the graph, of the slide rather, is an overview of how many kids we have in each age group. So you can see the really tall bars are for kids between 0 and 5 and 5 and 10. So we have a lot of kids that are in that younger age group. And then we have less kids who are 10 and up. It doesn't mean that those kids aren't out there. We know kids are out there who have STXBP1 and are in those age groups. It might just be more challenging to travel with kids that are older. There might be other factors we need to look into, but we have, but yes, so I'll skip this slide just to keep on time. So just to highlight, we really want to, if you have kind of a teenager or an older individual who has STXBP1, we'd really especially love to see you. And we really want to have a little bit more data to kind of to fill out that picture of older kids with STXBP1, right? So just a little call to action there. And as a reminder, so why is this data important? So every time, even with 146 people evaluated in the STAR study, we are constantly learning something with every single one of these clinical visits, truly. So I can say for our site at CHOP, we will kind of review the progress of every kid that came into our study. We'll review the results of every child that came into our study kind of in the week following your study visit. And in those meetings, we're constantly making new observations about how this condition can present. And so truly, we are learning something new with every study visit. And so it's important that we keep this going. And I already see how we're able to offer you better counseling and information based on all of these study visits in the STAR study. So we're able to offer you more specific information already, and I think that trend's only going to continue. We hope, and we're getting ready for clinical trial, like I said before. So if we're interested in participating, where could we participate? So we have sites across the United States. So we have one at Weill Cornell Medicine, Children's Hospital of Philadelphia, Texas Children's Hospital or Baylor College of Medicine, Children's Hospital of Colorado, of course, and then Stanford. And there's information on the website, on the STXBP1 Disorders website, on how to get in contact with sites. So some of the first data I want to show you comes from all of the surveys that you fill out before coming into the STAR study. So and what we're trying to capture through all of these surveys, we see your child just for a maximum of maybe 8 hours, one day of a clinical visit, right? And we know that that is not reflective of what every single day looks like for your child. And that's why these surveys are so important. It helps give insight into things that we cannot study in clinic. We can't make your child sleep overnight so we can study what their sleep looks like in the hospital, right? And so we need you to answer questionnaires about it so we can learn more about what this looks like in STXBP1. And so here's data from 2 different measures we collect in the STAR study. On the left-hand side is the Vineland-3, which is a scale of adaptive behavior. This is a little bit of a busy slide. I'm going to try to orient you to it, okay? So you might see a lot of gray dots on the left-hand side. That is a spectrum of many different genetic conditions besides STXBP1 that have filled out this measure in the past. So you can see where other genetic disorders kind of all cluster together. And then the blue and the red, or the blue and the pink, purple, are STXBP1 answers. So you can kind of see what the pattern looks like for STXBP1 compared to even other genetic conditions. And what we also see here is these come from two different survey collectors, but the data looks pretty similar, even though it came from two different studies. And so we're already starting to kind of see this pattern of adaptive behavior in STXBP1 from these surveys. On the right-hand side, there's a few less points on this side, but this is called a QI disability test, or QI disability inventory. And this is looking at quality of life in STXBP1. And so this is this is the first time this data has ever been available for this condition. Just a couple of observations is that quality of life in kids changes from age to age. So it's not something that remains stagnant across the life of a child. It ebbs and flows even between individuals. Importantly, it also is, these scores are kind of comparable to some other genetic conditions, which helps scientists make comparisons and use data from other disorders to inform our work in STXBP1. And then, oh, thanks, Charlene. Then the next part of the study is the clinical evaluations. So this is where you come into the clinic and we do a variety of tests on your children, developmental tests, to see how they're performing when we evaluate them. Not just when you evaluate them, but when we evaluate them, right? And these developmental tests are supposed to be play-based most of the time. So you will see clinicians using different toys and some more fun than others, if we're honest, to try to get the kids engaged and see how they're responding developmentally to these when they're asked to do these tasks. And again, this is a pretty busy slide, and you don't need to understand everything, but there's a couple of key things I want to point out here. So the Bailey-4 is our big developmental test that's play-based with all the different toys. And what we're showing here is what Bailey scores look like across the age range of STXBP1, and these are in raw scores, so it's hard to know exactly what it means unless you're really familiar with the assessment. But there's a couple things I want to point out. You can see that if we look at just one age, if we pick an age, let's say pick age 5 on one of these graphs, kids have a huge range of scores that they can have even if they're at age 5. It's ranging from more towards a score of 5 all the way up to a score of 100 at the very top. And so this is a huge range, a huge developmental range that we see in our kids, and it's something that you all know and see as parents already. Parents are always asking us when we come into clinic, why is there such a huge range of development in kids with STX? And this huge range of development that we knew about and saw is now there on this graph, right? And this is really important that we put the first numbers on this and can show it can show it for the first time. We also can see how kids progress over time. So if people have been evaluated multiple times, they're connected by a little gray line, and you can see the different patterns that people with STXBP1 can show us over time and how it's different in every child. Then let's zoom in on our gross motor scores, our tests of gross motor function. So you can see kind of the same pattern, where if we look at all 5-year-olds, there is a huge range of motor outcome. That's all the way from 15 on the scale to about 75 on the scale. Not just me, and so every child has a different pattern. But what you can see, again, individuals who are tested multiple times are connected by a gray line. You can see that the pattern of their development, or the rate of their development, is a little bit more consistent when we're looking at gross motor. And then this is maybe the most common question I get in clinic. Is the difference that we see in the presentation of kids with STXBP1. Is it because of my child's variant type? Is it because of the specific spelling change or difference that my child has in the gene? And right now, though we still have a lot of work to do on this, we're not seeing this pattern. We're not seeing results of developmental testing be influenced by variant type. This is still a big question, and I think you'll hear a lot more from us on this in the next years or so, but this is something that we're not seeing influence the results right now. And I want to point out, I want to finish my presentation with just one other really interesting thing we've learned from the STAR study so far. So when kids come in, some kids are coming into, and this is data just from the CHOP site, some kids are coming into our clinic already with a diagnosis of autism spectrum disorder. And atypical autism or autism spectrum disorder is a common feature in this condition. And what we were really interested in when we started the study is what would it, if we were evaluating every child for autism in clinic, would we see the numbers change and how many people truly had a diagnosis of autism? And what we did see is when we evaluated every child for autism with STXBP1, we increased that diagnosis number by about 20% or so. And this is even older children who have had the condition and diagnosis for a long time. So this is something that again, is already influencing how we take care of your kids and some of the recommendations that we make. And so in conclusion, a couple of final points. We are still learning with every new participant, so we would love to see you, love to see your child, love to have you if you're interested in coming to the study. We all offer kind of expert care for your children, so we are trying to learn from your children, but also give something back to you, give you kind of a better, give you tools that you can leave with to take better care of your child. We really are learning what is typical for STXBP1 and learning more about what we could target for clinical trials, which is very important. And we're learning what kind of a meaningful difference is in STXBP1, meaning what do families think is a meaningful difference? This is something we're learning through the study as well. So with that, thank you so much to everyone who has participated, families considering participating, and families who have participated and will keep coming back. Thank you so much. Thank you. Yeah. I get a question. Does anyone have any questions? Okay, that's okay. Thank you.
Excellent. Thank you, Sarah. So we're going to continue STAR study discussion. So Andrea Mele from Children's Hospital of Colorado, right here. She's a neuropsychologist, and she actually leads the STAR study here at the Children's Hospital, and she's going to talk more about kind of what Sarah briefly discussed, which is the developmental time course of what's going on in STXBP1 kids. So, Andrea, welcome.
Well, I'm so thrilled to be here. It's so great to see so many familiar faces and new faces out in the crowd. Thanks for traveling. We hope you're learning a lot today. As Jim said, some of my talk, thank you, Sarah, for launching me so well. Some of my talk is, you're gonna hear kind of some of the same things, but hopefully that might get, kind of some questions going, thinking about your kiddos and what the assessments kind of mean for them. So, just a disclosure slide. Thank you again to the foundation for generously supporting our grant, and then I have some other funding that's not relevant to what I'm presenting today. And so starting off with kind of a thank you slide to all the families who participated, our group in Colorado, our coordinators, who we would not be here without. And this is an outdated photo, so I know our group is already looking forward to taking a new one this year. All right, so just to kind of reiterate, I think you've heard it probably a million times already. So again, what are we trying to do with this study? It's a natural history study, so we're trying to understand what does STXBP1 look like over time, and as many different kind of individuals, as many different kind of ages, races, ethnicities, as we can. The study started with what's called a cross-sectional design, and so we kind of had a vertical snapshot of just kind of one visit, what are all the ages, what do things look like, but now we're going horizontally in kind of this longitudinal design. So as Sarah mentioned, like seeing kids for repeat visits, which has been really exciting. So Sarah mentioned some of the RARE-X measures, including, so on RARE-X is the CBCL, this aberrant behavior checklist, QI disability that Sarah presented, and then the CCSA. And then in Colorado and on RARE-X, the Vineland-3, which Sarah talked about. And then we have these performance-based assessments. Sarah spoke about the GMFM, the Peabody, and then we have the CARS, which looks at symptoms of autism, and then the Bailey, which is kind of one of my jams. We have this kind of picture, if it kind of looks familiar. Sarah had this slide up on her presentation as well. And it's just to kind of point out the variety of objects that are in this kit. We hope that they will be interesting and exciting to your children. I think one of the things I hear the most is, do you have anything that lights up? And no, unfortunately, we don't have anything that lights up. I wish we did. Some of the toys do make sounds, which can be kind of fun for kids. But there is a lot of variety, and one of the things that I also want you to notice is there's a lot of color, and we think that this is particularly important in STXBP1 because of the high rate of diagnosis of cortical visual impairment that we see. And so I like that this measure has things that are red and yellow. I had a family recently tell me their kiddo's favorite color was blue. And so, we're kind of checking the boxes that these should be things that we're trying to remove barriers to your child participating in the assessment, and at least we've got colorful things that sometimes make fun sounds. All right, so the first thing I want to talk about is kind of how is the Bailey doing now that we are 2 years in, and expanding on some work presented previously by CHOP, just that now that we have kind of double the amount of time that we've done. And by the way, yes, we do feel like the Bailey is working, and so we're happy about that. So what I have in kind of combined data from our site and CHOP is 93 Baileys. So this is already extremely exciting for me as a neuropsychologist. I work in this rare disease, and I do work in other rare diseases, and I'm kind of lucky if I get 10 kids sometimes, 10 Baileys. But now, wow, we have 93. And so average age range of 7. And then what we did next was look at what are called floor effects. So the Bailey has the different kind of scoring systems, but in order to we looked at the percent of the very first items, the first 3 items where nobody got any points on those kind of first 3 items. And that was nobody. So nobody had no points on the first 3 items. So we already know that kids were able to access those items. So we don't have kind of what's called a floor effect, where kids, we needed to kind of have different items to have kids show what they could do. So this is kind of one of the really important things that we want to show, because we know that we can track change. We then kind of took, so that's kind of the most stringent criteria, would be 3 scores of 0 on the very first 3 items. Then we kind of took a little less stringent criteria and just looked for an imperfect set of scores on those very first 3 items. And we still found pretty low rates of that, ranged from 6% to kind of 24%. On the Bailey Expressive Language Index was the one that maybe had kind of the most variability. Now I think we're going to try to unpack that to understand why on that measure are we seeing those, and that's going to take some item analysis, and my personal opinion is that some of those items are either not appropriate for kids because they're too old, or we're kind of experiencing some effects from perhaps a diagnosis of autism that are affecting those scores. Because some things, another thing that families tell me a lot is that participation in an item depends a lot on motivation, kind of in that moment. Do we want to do this? Do we not want to do this? And so I think that can kind of affect some of the scores in that domain. So the next thing we looked at, so we know that the Bailey is useful for kids with STXBP1, but then we wanted to look at kind of the top of the items. So the last 3 items, or the last 5 items, actually, in each of the indexes, to see if a lot of the population was actually able to do those items, and then we would need to do another measure after the Bailey to better understand your child's development. And so again, what we found is that the Bailey is working very well. The complete ceiling effect, so 5 scores of 2, so full credit on the last 5 items, was 0 to 1%. So we know that the Bailey is capturing the skills of your child kind of on its own. And then again, if we kind of relax the criteria and we just had kind of imperfect scores on those last 5 items, we had 0 to 8%. So, so there were some children who were able to get full credit on some of those final items, but not all of them. So what we feel that we can say pretty confidently, I think at this point in the study, is that the Bailey is working and it's telling us what we want to know, and we're not going to really need to look for other measures to fill in kind of early skills or more advanced skills, if that makes sense. So we're really happy to see that at this point. And so taking the Bailey, what I want to talk about next is just kind of some averages of where scores are. So this is one of the things that I go over in my clinical evaluations, is kind of the age equivalents that we get. So on the Bailey cognitive domain, the average age equivalent kind of across the study was around 11 months of an age equivalent kind of. So no matter what age the child was, the average ability was kind of approaching 1 year old. The minimum level that was demonstrated was around a 2-month-old age equivalent. And then what's interesting is the maximum, so the Bailey goes up to an age equivalent of 42 months. And so some children were actually able to show an age equivalent of 40 months. So pretty close to the top of that scale. So we have quite a range. And we see that range represented in the lower table, where we have the standard scores. So we only get standard scores if your child is in range, in the age range for the Bailey. And so we have standard scores ranging from 55 to 90. That standard score of 90 is in the average range. So there are some children out there who are performing consistently to same age peers. I'm not sure what age they were when they were meeting that, but we know that that is out there. Now I have the language domain. So there's 2 measures on the Bailey that talk about language, receptive language and expressive language. And these age equivalents are pretty close to the cognitive. Receptive is only a very small difference. Expressive language is a little harder in our population, which I think families would agree. But then we have a very wide range of some children just beginning to show us communication, and other kids almost going to kind of the max age equivalent, so showing us quite a bit of language. And so, again, I think it's really nice that we have that range like that. Similar standard scores for the kids who were in age, 45 up to 96. 96, again, is average. So we do know, so I just bring up the standard scores, even though that's a small proportion of our population that we would have standard scores to discuss. I think it's important because we want to not assume that we know how a child is going to perform. We want to actually have them show us, because we can be happily surprised. So the motor domain, again, very consistent, around a year kind of age equivalent. The minimum scores are a little bit higher for motor, and I think families also kind of tell us that their kids are achieving motor milestones perhaps a little bit sooner than some language milestones. And again, we have some kids who get right up to the top of kind of what the Bailey is measuring. Standard scores are, again, very consistent. So those are kind of the average scores that we have so far for the Bailey. Now, again, thank you, Sarah, for emphasizing the importance of these multiple visits. So the data that I have to present today on multiple visits is from 42 participants, which is really just stellar. So this could be just more than one visit. So some families have done more than 2 visits. But again, really kudos out to everyone who's traveling and making this time commitment, because this is just thrilling. So now that we have multiple visits, when I see a family for the first time, I am able to compare your child to their peers in terms of norm scores if I have them, or age equivalents, and that's kind of as far as we can go. But when I see a child for multiple visits, then I can start to talk about your child's individual trajectory. And I can do that by looking at change in raw scores and several other different types of scores. So up here on this table, I just have some raw scores from 2 kids on the Bailey. And so we have kind of time 1 has the 1 next to it, and then time 2. So we see for cognitive, for example, the raw score went from 83 up to 90. Then the next child had 2 raw scores that stayed relatively the same, 54 to 56. And then the last child's cognitive skills, so I have 3 kids up here. We have what seems like a bigger jump, score from 48 up to 69. And so I have all these raw scores across time. And our group is planning on doing significant analysis on our raw scores to try to really understand what their differences are telling us in terms of movement. One of the other things, though, that I find a little bit hard to interpret for raw scores is what do they mean in the moment? Because I don't know what 83 up to 90 kind of means. Like, is that common growth over time? Is that a big jump? Do we actually expect more growth? I don't know. I'm happy about it. It seems good. But from a research perspective, we really, need to do better than that. And so, and especially if we are looking for change in a clinical trial where hopefully we're looking for gains, but you know what? We also need to be able to capture declines if they're there. So we need to really have a pretty rigorous approach to understanding the movements in these scores. So this is a paper not related to STXBP1, but it's related to measuring change in a neurodegenerative disorder that we see in children. And I think that we can take some important lessons from it for our group. So there's this kind of table that talks about the different types of scores, and I've mentioned some of them. Standard scores, we get those only if we have norms, so only if your child is within the range that the measure was created. We have raw scores, we have age equivalents. Age equivalents are certainly, the most kind of, I think, easily translatable to families. It's helpful for me to say, okay, 12-month age equivalent. I kind of feel like I know what that means. I know what that means more than like an 83 on the Bailey cognitive, even though I give that measure a lot. And so then we have these things called GSV scores. And so it stands for growth scale values. And I would say that this is probably one of my favorite parts of when I'm seeing a child or an individual kind of for multiple visits, is to kind of look at these GSV scores. And so while our group is going to continue to look at all the different types of scores, raw scores, age equivalents, and try to understand movement, I think one of the other things that I'm excited to do is try to see if these GSV scores can also help us understand change. And so this is a picture of a table that I can get if I run an additional analysis using the Vineland. So you can see we have test 1 scores, test 2 scores. The test 1 is 2022, test 2, 2024. So we have about a 2-year gap. And we have the adaptive behavior composite and then kind of these other scores from the Vineland. And you can see that, wow, there looks like there's been some significant decreases. All the scores are moving way down. And if my initial look at something like this would be, wow, what do we have here? What's happening? But then when we look at the GSV scores for this individual across time, you can see that not only have all of the scores actually increased, there are some that are in a gray box, and that means they've increased in a statistically significant way. So to me, again, this takes one step away from me kind of having to use my gut to say, that seems good, where this is actually already built into the Vineland, And it's, we actually have stats to show us that this movement is really meaningful. So, so the way I think that we can kind of understand the gap is that when I see a loss in a standard score, this just means that the gap between your child and peers has increased. We don't necessarily know until we look further into raw scores or GSV scores if that's because your child has actually lost skills or have they just been slower to gain the skills that we would expect them to gain because time has moved on. And so I feel like the GSV scores also tell me a lot about, or can also kind of help me plan with families for how is it going? There aren't enough hours in the day and you guys are working so hard to get your kids into therapies and extra activities and everybody's really busy. And I think sometimes it's useful to say, hey, we have, we're making a lot of gains here. See, our work is doing something, like this is being justified. Or if we don't have gains, maybe we want to focus our time there. Maybe we can pull time back from something else that we're doing. So I think it can help plan. And that's something else that I really like. So just coming back to our example, I have the GSV scores. Oh, sorry. I have the GSV scores in there. So we have the raw scores, which is like the 80, the 90, 54, 56. The GSV scores are in bold. The GSV score itself doesn't mean anything. So it doesn't matter that it's 510. It could say 710. It could say 1110. The number is meaningless. The point is the movement. And so here, I have the statistical significant difference that's in the manual for the change in scores. So we already know kind of what we're looking for. And if you look at the bottom row, I think these scores kind of make sense even if you just look at the raw scores because we have a big gap, 48 up to 69, 35 up to 42, 66 up to 71. So all the ones that are starred are statistically significant. But then I have the top line, kind of these boxes, because to me, so we have an increase a decrease rather of 5 in receptive language, 42 down to 37. Is that something I need to worry about, or is that just normal variability? And this would tell us this is normal variability. We don't need to worry about it. In contrast, we have 83 going up to 90 for gross motor. That's a statistically significant change. But 83 going up to 90 in cognitive is not a statistically significant change. So again, I just think that it really helps that this is grounded in some statistics, and it really helps me know what we need to focus on when I'm talking to families. So what I'm hoping that we can do is expand, since I'm talking about this on a very individual level, I'm hoping that we can apply this to our entire sample. So that's some of our coming work. So thank you so much for participating in our study. We can't say that enough. We are still hoping to add individuals that are older, increase our racial diversity. We kind of already talked about that. We're happy with the Bailey. We're excited to kind of be using this measure. We appreciate you having patience with us. If some of the tools seem a little bit babyish, we're just hoping that your child still likes to interact with them, and we're just trying to kind of discover what that instrument can tell us about movement over time. So yeah, hopefully we'll continue to see you. Please come for 6-month visits. Excited to include other data from other sites who are also here, and look a little bit more into behavior and kind of some stuff around autism. So that's kind of what we're hoping to do next. Thanks.
Thank you, Andrea. Does anybody have any questions? We can take one question for Andrea. Anybody? If not, you can find Andrea. Anybody have any questions for her? Can I just say real quick that we see Andrea, I'll just out ourselves. We see Andrea, love working with her. This has been super helpful for us. We saw our son actually start to dip down, but then he came back up, and it was really cool to see. So it was really cool to see these numbers like in real time for your child. So it is really cool to be part of the study and to be able to get this information. All right. Thank you, Andrea.
Thank you, Andrea. So we're going to continue with another talk from the Children's Hospital of Colorado group. This is Megan Abbott, who's an assistant professor in peds neurology. and she is going to talk about the development of a new type of severity scale that can be used to assess our STXBP1 kids. Megan, thank you.
Well, hi, everyone. I will start how everyone has started, which I'm so thankful to be here. It's just wonderful to get to see all of the STXers and all the families that we get to see in clinic outside the hospital. So it's just wonderful to be here. And I am excited to talk to everyone today about a new clinical severity assessment that we have made to evaluate STXers. So we're going to talk about how we developed this severity assessment. Yep. Apparently I'm being too quiet. There we go. I'll talk about how we developed the clinical severity assessment and then go through some data of how it has looked so far in STXBP1. So before we get into the clinical severity assessment, I wanted to talk through why do we need this? Can't we just look at epilepsy? Can't we just look at seizures? We know a lot of our STXers have seizures, and a lot of clinical trials before have used seizures as one of their endpoints. And I think it's important to step back and think about kind of what else is involved in STXBP1. And so for a long time, we've thought about, as a community and as neurologists, what's really driving severity in these conditions? Is it seizures? Is it the gene? Is it both? And I think over time, it's been found that, as we know, it's STXBP1. It's the gene that's really driving all these different changes we see in our kiddos. And that's been shown time and time again in different conditions, including STXBP1 and SCN1A and SCN2A and other conditions that you guys know, which is that developmental delay often precedes seizures. Once seizures are well controlled, delays persist. And so it's not necessarily that seizures are driving severity, but that they're a part of the whole clinical picture. And so it was important to start thinking about, what should we measure? What do families care about? What's important to our patients? And what are we seeing as clinicians? And so we have several examples of this, one of which being CDKL5, where they kind of went through parents' top concerns, clinicians' top concerns, and you can see that seizures are up there as one of the concerns, but they are not the only concern. We know that we care about communication, motor, sleep. All of these are things we want to measure and potentially things that we hope would get better in a clinical trial. And I luckily had so many people come before me to talk about the STXBP1 disease concept model, and I think you can see how important this study was and how far-reaching its efforts were into getting us where we are today. But just wanted to point out a few things, which is that, once again, while seizures are part of the disease concept model, there's many other domains that are very important, including behavior, vision, motor, communication. So I'm starting to sound like I'm on a soapbox, but while epilepsy is the major concern, it's not the only concern, and so we needed to think about an outcome measure that could measure the other things we care about, being speech, motor, sleep, behavior. And so that brings us to the clinical severity assessment that I am going to focus on, which actually was originally designed in CDKL5. There's a team that got together for CDKL5 at our institution, Dr. Demarest and Dr. Banky among a few, who started to design and then validate a clinical outcome measure in CDKL5 called the CDKL5 Clinical Severity Assessment, or CCSA. There's a lot of acronyms in this work, but they were able to validate that in CDKL5 and show that it works really well and is able to cover multiple domains that I was talking about. And so I wanted to show an example of some items and then talk about how we've modified it for STXBP1. And so the scale in general is on a 0 to 100-point scale, with 0 being the least amount of impairment and 100 being the most amount of impairment. And so these are just some examples of motor items which involve, how does your child stand? How does your child walk? Is that with maximal assistance? Is that with 2 hands or 1 hand? And so we can grade that over this scale from 0 to 100. Same thing is true for communication. So when we're evaluating your child in the clinic, we are looking to see, do they make purposeful vocalizations? Are they non-purposeful? And we actually can use their age as well to help us know what to grade. And as well as knowing, how many words do they have? Are they word approximations? Are they using an AAC device? All those things are built into the scale. And the other domain that the severity assessment covers that we do in the clinic is vision. And so these are a couple of our vision items. If you've been to clinic with us, you know that CVI is something we like to talk about and diagnose, and the vision items help us give that diagnosis as well. And so some of these items are fixing and following, our optokinetic nystagmus reflex, which if you've been to clinic is that iPad with the lines that swirl through your child's face. And we are able to see if your child can track and how their eyes are responding to that test. And so we were able to take this assessment, the CDKL5 Clinical Severity Assessment, and the Colorado team and the CHOP team got together in a few sessions and talked through the items and talked through what items would be missing for STXBP1 and what items would be good to add. And we were able to add some trimmer items as well as some vision items to try to just get more at the kind of nuances that STXBP1 has that are different from CDKL5. And then we started piloting the STXBP1 Clinical Severity Assessment, or SCSA, through the STAR study. And I'm really excited. We have 123 patients that we have the SCSA scores in, and I get to share really exciting results, which is that the score has worked really well. And what does that mean? What does it mean that a score works well? Well, we can see that there's really nice distributions through most of these domains, including the overall score has a nice bell curve, which means that everyone was not all the way at the bottom and everyone was not all the way at the top, what we call floor and ceiling effects, as well as that we were able to demonstrate the score can capture a wide range of severity, even within STXBP1. You'll see that the vision score has some scores kind of clustered near the bottom, or the less severe range of the score. And I think we have an explanation for that, which is that around 50% of STXers have a diagnosis of CVI, or cortical visual impairment. And if you have a diagnosis of CVI, you tend to score higher on our vision domain score. However, the other half of STXers do not have a diagnosis of CVI and therefore score lower on the score. So about half the scores cluster in the lower end of the range and half are on the higher end of the range, so more of a bimodal distribution. This is once again just showing the scores in the 3 different domains. So we have motor, communication, and vision for our clinician-administered SCSA. And in terms of severity, we see that the communication scores tend to be on the higher end of the range, showing that maybe we have more impairment in the communication domain, followed by motor, followed by vision. And after we look at the distribution of scores, and we look at kind of how did these scores compare across STXers, we also want to make sure we're looking at, are the scores skewed? Do they have kind of good means and standard deviation? And these are ways we tell if the score did well or performed well in STX in the same way that it did in CDKL5. And we were able to see that, once again, the scores had a wide range of scores, that there wasn't skew other than in the vision score, which I think can be explained with the CVI that I talked about. And the other piece of validating a score is something called factor analysis, which I'm going to break down, is essentially, do the items that are in the scale still fit into the buckets we thought they fit into? So I talked about motor, vision, and communication. Those are our buckets or factors, and we look to see if the items that we have in the scale still fit within those buckets for STXBP1 and still make sense for the condition. Similar to, like, these are variables, education, family situation, and income that all fit within a factor, socioeconomic status. So this is what we're looking at with the scale. And these are a lot of numbers that you guys do not have to look at, but we have set cutoffs for if these different variables or items within the scale are fitting within these buckets or domains appropriately and with good metrics, and that the scale still had the same number of factors or domains as it did in CDKL5. And I'm excited to say that all of the items listed did fit within those factors or domains, and that the domains still worked well in CDKL5. And so the takeaway from this is that this was a measure that did a really good job in STXBP1 demonstrating a wide range of severity and capturing what your kids can do in motor communication and vision. There wasn't significant floor or ceiling effects other than what I talked about with vision, with CVI or no CVI. And the way that the factors or domains were structured in CDKL5 continued to work in STXBP1. All of this leads to an exciting thing, which is that we could use the SCSA in clinical trials, and that it is going to be used in the upcoming Capsida trial. So we're very excited about that. Whoop. And I just wanted to end with a thank you. Thanks for letting us see your kids. Thanks for letting us get to do this work. And we're excited to continue. This is a pic of my family. I think the last time I was here, I was very pregnant with twins. So they're here now. They're 10 months old. And just really thankful to get to share in your families and share mine. Thank you, guys.
We have time for one question. And you can also get Megan during the breaks. Okay, thank you so much.
All right, for our final speaker of the morning, I want to welcome Jillian McKee from Children's Hospital of Philadelphia. Jillian is a neurogeneticist and epileptologist, fellow in Peds Neuro, and she's going to give us kind of a primer on understanding EEGs. So, Jillian, thank you.
All right, thanks, Jim, for that introduction. My talk's going to be a little bit different than the ones we've just heard in the last section. Really just wanted this to be an overview for families about EEGs, why we get them, what they can tell us, and then give you a little bit of an understanding of some of the basic science behind them. But the reason I wanted to talk about this today is we've been getting lots of questions about families, about EEGs, how to understand reports, when we should get them. And then since incorporating research quantitative EEGs into the STAR study, had a lot of questions about the differences, what the difference between a clinical EEG and a research EEG is. So I just wanted to give you guys a basic overview of that. And then feel free to grab me with any questions throughout the weekend if anything comes up. So brief outline of the talk, gonna do some EEG basics, very, very brief history. What is an EEG? Talk about some types of EEGs. And then very, very briefly, I'm gonna focus on how EEG is helping us understand and treat STXBP1. So EEG is actually very, very old. There's been lots of buzz about it lately, but this is a super, super old test. The origins for EEG go back to the 1800s when scientists first discovered that there's electrical activity going on in the brains of animals. And then really, really took off in 1924 when Hansberger performed the first human EEG. Then EEGs have been in clinical practice around the world since the 40s or 50s. So this is a really, really old technology, but there's a lot of new, exciting ways to analyze this data that have come up in the last few years. So what is an EEG anyways? An EEG, it's a medical procedure, very non-invasive. to help understand the function of the brain. Kind of like an MRI gives you like a big picture overview of the structure of the brain. EEGs can really help get a sense how do parts of the brain communicate with each other. So you have small electrodes that are either glued onto an individual's head, or you can use a cap-based system. It measures the electrical activity, as I mentioned. And then we have both visual and computational techniques to decode distinct activity patterns in the brain. And as I mentioned too, EEGs can be performed for both clinical and research purposes. So this is a very, very basic schematic of an EEG system, one using one of those cap-based electrode nets. So you can see a patient sitting there with this cap of electrodes on his head. Each is connected to a wire that takes the signal to an amplifier. And you need an amplifier because these electrical signals are very, very tiny, so we need to magnify them many, many times to be able to see them. And then the signals are fed into a computer where we can display them on a screen and then perform different computational analyses. So this is kind of a scary picture, and I'm not going to go into all the details of this, but just want to give you a brief overview what actually makes the EEG signals. So as I mentioned, brain cells talk to each other using electricity, and this is transmitted across synapses, which are like the gaps between those brain cells. And when many of these cells talk to each other, they generate electrical signals that can actually be recorded on the scalp, on the surface of the brain. So this is a picture of a normal teenager's EEG. When I'm sitting in clinic reading EEGs, this is what I'm looking at. There's many different ways you can visually display an EEG, but this is one of the more basic ways that we do this. And just to orient you a little bit, blue squiggles are coming from the left side of the brain, red squiggles from the right side of the brain. Each of those little groups of 4, the top lines are electrodes towards the front of the head, and the bottom ones are coming from the back. And when you look at this just to get a overall gestalt, you see that there's some sort of organization there. In each of those groupings of 4, you can see towards the top, it tends to be a little flatter with faster activity, and then towards the back, you see these more higher amplitude undulating waves. So this is what a normal EEG looks like. Contrast that to this. Ingo mentioned that infantile spasms are very common in STXBP1, and this is a snapshot of an EEG from a baby with spasms. You can see this is that pattern that some of you whose children have had spasms may have heard of called hypsarrhythmia, where you get these high amplitude disorganized waves. It's kind of messy. If you turn the page upside down, it kind of looks the same. You don't really see any clear organization. And then you can see that period in the middle there where it becomes flat. And that's the EEG signature of an actual infantile spasm. So when looking at these visually, we can see clear differences, and this is how we read EEGs for clinical purposes. But we can also look at these signals a little more detail. When you're talking about EEGs, we tend to break the frequencies down into specific frequency bands, from very slow undulating waves, delta frequencies or theta frequencies, up to very, very fast squiggles and beta and gamma frequencies. And we can measure the amount of the signal that falls into these different frequency bands. So just keep this in mind. I'm going to come back to this in a minute. First, just want to talk about clinical EEGs. So why would your child's doctor want to get an EEG? So EEGs are really helpful for diagnosing seizures and epilepsy, and then also looking at disease-related brain activity, things like slowing, like are those waves slower than we would expect for a child's age? Is there any asymmetry? Is something happening on one side of the brain that's making those waves look different than the other side? They can be useful for classifying the types of seizures. We talked about infantile spasms already. There's other types of generalized seizures as well, and kids can also have focal seizures, meaning they're coming from just one spot in the brain. And EEGs are also incredibly useful when trying to localize where in the brain a seizure is coming from when you're considering certain treatments, such as surgical treatments. And then also, once you've started a seizure medication or some sort of therapy, EEGs can help you see whether that's working. So there's many different types of EEGs, and these differ from institution to institution. But Some broad categories are what some people might call like a routine EEG. That tends to be like a spot EEG in clinic, normally about 30 minutes. Often the child's only awake. We're not lucky enough to capture sleep with these EEGs. Sometimes, especially for infantile spasms, we'll do something called a 4-hour EEG, which is exactly what it sounds like. It's a longer EEG. The goal is mainly to try to capture sleep, especially in infants. And then if you need even more data, you can be admitted to the hospital for something called long-term monitoring or continuous video EEG, where you can stay a few days with the EEG in place. There's normally a video in the room, so you can correlate things you're seeing the child do with changes in the EEG. You can do a version of that at home, too, called an ambulatory EEG. And then for pre-surgical workups, people considering epilepsy surgery, there's more advanced forms of EEG, such as stereo EEG, where you actually implant depth electrodes into the brain. And then an older technique called grids and strips, where you'd put the electrodes that you put on the scalp for a normal EEG, but under the skull on the surface of the brain. So what to expect? Many of your children have already had EEGs, but for those who haven't, it's a non-invasive test. You do sometimes need to sit still at least for a little bit to get a good sense of the brain activity, because movement can shake those wires and move those electrodes and make it harder to read. There's no pain or discomfort. Sometimes, especially if you have the EEG electrodes on for a longer period of time, you can get some irritation where the electrodes are. And then sometimes people will perform what we call like activating procedures, such as photic stimulation, where they flash those bright lights, or have your child do hyperventilation, like blowing on a pinwheel or pretending to blow out the birthday candles. Those are nice tests to do too, because they can bring out some abnormalities in the brain and help make them easier to see. So we get lots of questions about what does your EEG report mean. And this is just one example actually of a normal EEG. And this is also varies from center to center what these look like. But they all should have certain key components. They should describe the background frequencies, so those the fastness or slowness of the different squiggles in the background. If it captures sleep, we'll describe sleep. Talk about any seizures, obviously, and then any other like focal abnormalities such as slowing or epileptiform discharges, which are like spikes or sharps, those little signs that your brain is prone to make seizures. All right, and now switching gears to talk more about the differences between clinical EEGs and research EEGs. So as I mentioned already, for clinical EEGs, the main goal is diagnosing and treating patients. We use these in hospitals and clinics to really provide the best clinical care for your children. Research EEGs, on the other hand, have a different goal. We want to analyze the brain activity for research purposes. They're often more detailed and include complex computational analyses. These can help us identify biomarkers of disease, which I'll talk about a little bit in a bit. And then they can also identify subtle patterns that you might not be able to see just with your naked eye when you're looking at a page of EEG. There's also some differences in the way we acquire clinical and research EEGs. They tend to have different sampling frequencies, so that's how many times per second you're looking at that signal and measuring it. For clinical EEGs, that can be a little lower resolution, but for research EEGs, we really want very high quality data, so we sample it at a much faster frequency. We also sample the surface of the head at a higher density for research EEGs. So for our research EEGs, we use these caps that have 128 electrodes, versus clinical EEGs only have 19 typically. And these are a lot of words, but in the sake of time, I'm just going to go, pictures are sometimes much easier. So this is just an example of two subjects getting both a clinical EEG and a research EEG. And for full disclosure, these are my children. On the left here is my son, Wolf. When he was a baby, he's 4 now. But he had some very, very scary breath-holding spells, so had a clinical EEG. But you can see those electrodes are like glued and taped on and then wrapped up by an EEG tech. And this is just done in an outpatient clinic. And this EEG lasted about 30 minutes. And then on the right there, you can see my daughter, Willa. She's 7, and she's a very proud participant as a control EEG in the STAR study. So just to put a plug in, if there's any siblings out there who want to help, we would love to, when you tag along for your visit, and we can gather some EEG data on you too. It's helpful to be able to compare between STXers and then healthy controls. But you see she's wearing this elastic net-based cap system. It's much easier to apply. You don't have to glue it on. Just have one of our research coordinators put it over your head. It's pretty well tolerated. And you can see there's many more electrodes. You get better coverage with that system. All right, and then very briefly, because I know I'm standing between you guys and lunch, I'm going to talk a little bit about EEG biomarkers. So what is a biomarker? And there's many different types, but broadly, they're measurable signs, so that's important, they have to be measurable, that tell you something about health and disease. There's EEG biomarkers, there's blood biomarkers, there can be CSF biomarkers, there can be biophysical biomarkers. But when we're talking about EEG biomarkers, we have several goals for what we want to be able to determine from them. So biomarkers can be diagnostic, so it can be a unique EEG signature of STX that shows something different than we would see in a neurotypical control. So that's why having those controls is important. They can also be prognostic or predictive, so they could track with the severity of a disorder and can help stratify patients into different groups. And they can also be responsive, meaning that they change with treatment. And that's ideal for an outcome measure for a clinical trial. Ideally, we want it to be all three. We want to have a biomarker that's unique and different in STX. It corresponds with severity, and it changes with treatment. So we have developed a QEEG, or quantitative EEG pipeline, to analyze these research EEGs to try to look for biomarkers. So what you can see here is a noisy snippet of an EEG. And what we do is this pipeline cleans the data up and selects good, clean segments for further, more detailed analysis. And it's actually kind of remarkable. You don't need very much clean EEG to do this. We only actually need a few seconds. So if you're worried your kid moves around a lot, it's actually not a problem. As long as we can get them sitting very still for a few seconds, we can get some good data. And then we go and we look at the different power in those different frequency bands. You remember I showed you this before. And we can do this globally across the whole brain, or we can look at specific regions, so either in the front or the back. And then in addition to looking at just like the power of delta activity, we can look at ratios. So how much delta is there compared to alpha? But if you can think about that, we have all these different frequency bands, every possible combination of ratio, and every possible area of the brain. That's a lot of EEG features. So how do we know which ones to look at? So what we did first was developed a machine learning model that would classify EEGs based on whether they came from kids with STX or healthy controls. And then we used that model to pull out which features were most important. And you can see here on the right, this feature importance plot shows you which of those features the model used to say, this EEG comes from a kid with STX, or this EEG comes from a kid without STX. And the most useful feature was this alpha-theta ratio in the front of the brain. So then we can pull that out and look at that in more detail. So here what I'm showing you is that frontal alpha-theta ratio in 3 different age groups, in control individuals in green, in STXBP1 individuals that had clinical EEGs in that like light purple color, and then in the darker purple is our research quantitative EEGs. And what you can see is that pretty much across the lifespan, that alpha-theta ratio is lower in individuals with STX than in neurotypical controls. So that's really exciting that this could potentially be a biomarker of STX. And what we're looking at now is to see how well that actually correlates with the various outcome measures that Sarah showed you and Andrea showed you. I'm not going to go into all of that detail now, but we're making some exciting progress. So yes, I finished in time. Will not be the one to delay you for lunch. So I hope I was able to share a little bit about EEGs today and why we get them, how to interpret them, how they're useful. But feel free to flag me if you have any questions. I'm happy to answer them. Thanks.
We have time for one question. Jared.
Thank you. I have one from online here. John would like to know, has there been any movement on the approval of the cap-based EEG versus glue? Is the cap-based EEG FDA approved? Is that a...
So the ones we use are, yeah. There's many different very exciting EEG technologies under development, which may be something that we could use in the future, like home-based ones. There's ones with like only a few channels that kind of like a headband that you could wear at home to monitor seizures. Many people are looking into this and exploring it for potential outcome measures for clinical trials. It's all exploratory now, but expect lots of exciting changes in the next few years.
Thank you.
All right, I know I am standing in between lunch and y'all, but I wanted to just close today's session, or this morning's session, by saying I know that was a lot of material, and there was a lot of technical information, especially in the last few talks about, ranges and floor effects and ceiling effects, and we wanted you to understand some of the approaches and the data and the science behind the way that we're looking at these measures as they apply to the STXBP1 population. As we mentioned in the beginning of the day, we are running. We are trailblazing and we are running because of the fact that we've only been at this for 16 years. It means that this is the first natural history study we've done. We've only been doing that for the last 2 years. We're starting the first gene therapy clinical trial this month. And so all of these things, we have a lot to do to make sure that as best as we can, the measures that we're using are appropriate for our population, and we understand the data that comes out, out of the trials based on that. So I know it's a lot of information. These talks will also be recorded, and please, the speakers are here, so find them and ask them questions. All right, we are gonna break for lunch. We will come back at 1:20. There is also a music therapist that is going to be in the Stanley Ballroom. So if you were going back down the hall and you went down where the research arm is, go to the end of that hall and the music therapist will be there. Okay, thank you all.
seats and finish up your conversations. That would be great. So this afternoon, we're going to kind of continue our conversation of a better understanding of STXBP1 disorders. And our first speaker is going to be Wendy Chung. I'm going to make sure I get this title right. Wendy's the chair of the Department of Pediatrics at Boston Children's, and she's also the principal investigator for the Simon Searchlight study. STXBP1 has been part of this study for many years, and Dr. Chung's going to give us some insights into that study this afternoon. So give her a warm welcome.
Thanks, everyone. I'm thrilled to be with you here today, and I was saying to Charlene at lunch, I'm going to pull an audible, and although my slides won't necessarily reflect everything I'm going to say, I don't want this to be duplicative, and I want to give you some insight into some things going forward. So let's see, hopefully my slides are up and running. Anyway, as we're trying to advance the slides, what I'll say is that Simon Searchlight has now been going on for about 15 years, so just a little bit less time than we've known about STXBP1. As we've done this, it's an umbrella, as the way I think about it, across neurodevelopmental genetic conditions. And within doing this, it's global, and we've tried to really de-risk this and make this a resource that makes it an amplifier for what families do from around the world to be able to increase their impact. So this is sponsored and funded solely by the Simons Foundation. It has been since its beginning, and it will continue to be. And with their generous support, we've been able to do many things in partnership with other groups. And as we do this, we try and do it responsibly. That is to make the information de-identified, so no one knows who anyone is, but be able to make it easy for researchers, whether they're in a company, whether they're in a university, wherever they might be around the world to do this, to be able to make the most of your contribution to research. And part of what I'm here today is to give you an update in terms of what's been going on, and to listen in terms of what you as a community need going forward so that we can position ourselves to be able to help you best. So as I was alluding to, and thank you for those of you who have seen Gabi out in the entryway and contributed samples, blood samples to Combined Brain to be able to power this. As we've been doing this, there are over 130 publications so far across the Simon Searchlight conditions. And one of the beautiful things about this is it's not just STXBP1 in isolation, but it's the ability for many researchers to look across conditions and to be able to see how one condition fits into the ecosystem overall. So that's a relatively unique way of being able to do things, and one of the features that I think many of the investigators have used. As we do this, part of the goal is to translate this back into things that are meaningful for your daily care and for your information, for your daily lives. And one of the ways we do this, we believe very much in open data science, making sure the information that's published that comes out is freely available to anyone in the community. And one of the easy ways to do this is through something called gene reviews, to be able to make sure that gets updated in a very sort of quick way that your clinicians, your doctors, when they're seeing you, can be able to go to that website, see up-to-date information, and be able to process what might be new information to them, but very quickly in real time in a way that helps you going forward. That also helps in terms of eventually getting services covered, like insurance, in terms of different recommendations, and it builds the evidence as we go forward. So again, coming out of this, our original, this is just the count in terms of the number of papers that have come out of this for STXBP1. And in addition, we have, through the Simons Foundation, funds that come to this family meeting, as an example, as well as to the investigators who are doing the research. So it's not simply just you putting in information, but it's also funding some of the researchers to be able to use the information for you. So let me give you a brief update then in terms of what we've been learning, and to say that I do think it's changing, and this is actually, to me, dynamic and important, that over time, I think the natural history is changing. So in other words, what we're seeing, and I think that's actually, for me, an opportunity and signifies hope in terms of what we can be doing for the future. And I'm going to put in a plug for that in just a second. So as we do this, we, I think, do a very good job of making sure that people in the registry really truly have verified diagnosis in terms of STXBP1. I will say it doesn't happen very often, but I'm a geneticist and I actually review the genetic reports in some cases. And every once in a while we have someone who thinks that's their condition, but it's actually not, and we help them get to their correct diagnosis. And this is very helpful in terms of the researchers that use the data being very sure that these are in fact the data that they want to. Individuals, as they're going through the process, I'll emphasize this is not a one and done. This is, as you've been hearing about, really a living, breathing, longitudinal registry. And the beauty of this is it's all online. So no matter where anyone is in the world, they don't have to be able to go to one of the clinical sites, as you saw from the beautiful natural history data earlier. And that's important globally, especially. So people can be anywhere in the world and still contribute. And it's synergistic, additive to what's going on with the in-person assessments. As we're doing this, another portion of this is the blood sample that comes in, and I'll get to that in a second. Obviously, that's something that we do at in-person family meetings, but we also have services for people to be able to do it from their homes and send that in. And again, this is something that's living, and every year we continue to fill in the data. I'm not going to talk too much about this because you've already heard about this and you're going to hear about this next, but I will emphasize that this is a stick plot. It's not very fancy, unlike some of the three-dimensional plots you've seen earlier, but this is that lollipop plot you heard Ingo talk about before in terms of all the different genetic variations. And the ones I'm showing on the lollipop here are single amino acids or single building blocks in the protein that get swapped out. And as you've heard about, it is interesting that certain of these positions, the numbers in the parentheses, means that there's more than one person with the same genetic variation, and everyone isn't represented here. This is just the people who are in Simon's Searchlight. But there is, and again, I won't go deep into the biology, but I don't think all the mutations are acting by the same mechanism. You've heard this a little bit today, but there's a deeper dive in terms of that, what we call genotype-phenotype correlation that you heard that many times we and the genetic counselors get in advance, and it may actually have an implication for therapeutic strategies going forward. So to me, it's an important area, an opportunity going forward. In addition to this, but what I haven't shown is that there are all sorts, this is that gray box in the upper left, there are a bunch of people who have, we think, functionally a copy of the gene that just doesn't show up to work. So what I mean by that is it has a premature termination, it has a deletion, but something so that you've got half the amount, haplo insufficiency, half the amount of protein. And for that, it makes sense in terms of being able to restore the function, give that one copy back in some way. Whereas with the missense variants, like I said, it could be more complicated. And I'll let others talk about that are much more knowledgeable than I am. In doing this, we have an international, as I said, group, but we do have a huge number of people here in the United States. I will say, and I get this perspective simply because I can see across conditions, you are very lucky. You're very lucky that the leadership you have in this community in particular is extraordinary. And I will say that in terms of across, I see a lot of conditions and rare diseases, not just in terms of brain conditions, but across everything, literally hundreds of them, and you are really uniquely positioned in terms of having leaders that have been very thoughtful and strategic in terms of moving you forward. So I'll just put that out there. In doing this, it is, as I said, a global condition, and there's no reason to think that it should be any one place more than another. So even though I'm showing you that we have a large number of people in the United States, just to set the sort of, put it in your head, it's not because this is an American condition. Really, this is, we think, equal opportunity around the world, but it simply reflects access to genetic testing. We were actually talking about this over lunch in terms of some of the other things, but I'll show you the age distribution as well, and that's skewed. I don't think it's just what we see. I think there are many more people out there. This is what I was alluding to in terms of the different cell lines, and again, the Simons Foundation has been maintaining this repository that, again, is available to researchers in terms of being able to use this, and importantly, to make these induced pluripotential stem cells or brain cells in a dish, or even organoids or mini brains to be able to test out before they go into people. This is a resource, and it's important that it's not just one person that's represented here. It's actually many different individuals with many different genetic genetic variations. And with this, as I said, it's a very nominal, literally the cost of shipping in terms of researchers being able to do this. And so this is what's going on behind the scenes in terms of the blood samples that you've been donating. With this, the Simons Foundation continues to both distribute as well as expand this, and each one of these lines that's made costs about $15,000, so this is no small investment in terms of powering your community. These are the second list of variants. So within this, what are the data we see? And I'll put out the limitations of what we see, because there's what we see, and what I worry about is what we don't see. So as some folks have already pointed out, we're skewed in terms of who's accessing genetic testing in this era. And based on who's accessing genetic testing, we're largely seeing what I think is the beginning of the lifetime journey. So we're seeing individuals really, almost exclusively, not quite, but almost exclusively, who got their diagnosis as children. We're watching them age up. So based on the fact that we've known about this for a while, some people are now adults. But what you're not seeing here is you're not seeing individuals largely who are in their 40s, 50s, 60s with this condition. Now the question is, where are they? Or do we have them? I'm sure they're out there. I'm absolutely positive, because I myself have done things where I've tapped into some of our adult communities to know that our conditions are in those communities, but they're not accessing the genetic testing. And I'm not blaming them. I'm not saying they have to, but just to say that I don't have a lot of great long-term outcome data, because we simply don't know all of those people, and they're not represented in the registry. As we do this, not surprisingly, we're almost equal male-female, and this particular snapshot that I'm showing you represents 133 individuals. Again, less than, you've got an overlapping, but not exactly the same as what are in the natural history study that you've seen already today. I'm going to put in a little plug for something that's coming, because you're going to have some people coming into your community that are coming in through one of my, I call it a sister study. So I've got another study that I'm doing called the Guardian study, which is called Genomic Uniform Screening Against Rare Diseases in All Newborns. And in that particular study, the point that I want to make for you all is we're identifying those babies, those little tiny babies that are just a few weeks old before they have symptoms, and identifying some of these genetic conditions like STXBP1 and encouraging them to join your communities then after they receive the diagnosis. I tell you this because I actually spent this morning with one of them online. They're coming in and they don't know what to expect. Unlike you all who came in at least knowing something about what was going on, they're coming in as a blank slate, not knowing what to expect, and they're looking to you all for guidance. And as we're doing this, I really truly believe this is the case, because clinically, I still see patients every Monday. I do know that my younger children, I think, are doing better than my older patients that have grown up with the condition, where we didn't have some of the tips and tricks that I think we've all learned together. And so I think you've got very valuable information that I know you're sharing with each other, and that I hope you're starting to share with the next generation of children growing up as well, because I do think there are more things that we can learn from doing this to make the next generation better. And clinical trials and the genetic therapies for sure are one of the important ways going forward. But even without that, I think there are other things that we're learning that we want to be able to implement as soon as possible. And part of the justification and the reason that I have this other study going is to be able to identify these individuals before the epilepsy starts, with the hope that if we get that under control, that we may be able to have additional possibilities in terms of brain development for them. So largely, I'm not going to go into most of the neurological manifestations, because other speakers have done that even better than I would do here. But just to say, not surprisingly, this is largely a condition that's affecting the brain, and to the extent the brain sends nerve cells to other parts of the body, but there are various different diagnoses. I'm going to focus instead on a few of the medical issues, and I want to reassure you that largely there are not medical issues coming on. So not surprisingly, this is something that's primarily affecting the brain, and to the extent the brain affects the body, that's what the effect is. But what we're not seeing, and I look for very, very carefully, is we're not seeing things like cancer. We're not seeing an increased risk of diabetes. We're not seeing an increased risk of heart conditions. We're not seeing an increased risk of kidney disease and other things. We didn't see a huge increased risk with COVID in terms of other things, any more so than we saw with kids that are medically fragile. So granted, we have that as a baseline, but we're not seeing any additional problems with the immune system or the way the immune system's working. So that's the good news. Not that life wasn't complicated enough already, but I'm not going to add to your plate in terms of other complexities going on. So what are some of the things that it might not be obvious how those things connect, but we do have the brain cells that are affecting, for instance, the gastrointestinal tract. So I do think it's largely through those connections that we see problems like constipation, reflux, to a certain extent problems with motility that we see, but I don't think it's primarily an anatomical problem with the way the intestine is structured. I think it's really a functional effect. We are seeing some issues when it comes, for instance, to orthopedic issues, which again, I don't think are primarily that the bones have a developmental bone problem. Other conditions I know do have that. I don't think that's this. I think it's the muscle tone problems that we see that are having an effect on how strong the body is and whether or not we see scoliosis or curvature of the spine or what the muscle tone is that may cause problems. But I don't think fundamentally we're seeing a problem with the bones themselves. In a similar way, sometimes we can see problems with growth, but again, that may have more to do with feeding and nutrition in terms of how much the kids are feeding rather than primarily a pituitary or primarily an endocrine problem with growth hormone deficiency. Vision, you've heard a little bit already. Some of the visual problems I think are really in the brain, so problems that we have with cortical visual impairment in terms of that, but we also have some problems with the eyes in terms of innervation to the eyes, the muscle tone in terms of the eye movement. We are seeing some of those issues. But a good news, again, to the extent that I can give you good news today, I don't want you to worry about any additional things. Again, these are some of the neurological findings. I'm not going to go into those in addition because you've heard about those already today, but largely the neurological findings have been treated medically with medicines, occasionally things like a vagal nerve stimulator, but haven't required a lot of surgeries. And in general, I would say the amount of surgery has not been excessive once we get out of the first couple years of life. Seizures you've heard about, so I'm going to flip through those quickly, and you've heard about the course in terms of the seizures over the life course and what we're still learning in terms of puberty. For the eyes, as I was alluding to a little bit, I think the eyes to me are important because it's the window in to get information in, to be able to take the world in around you, to be able to know literally what's coming at you, and to be able to learn and interact with the world. So I do think this is a very important thing to be able to do as much as we can for vision, but I realize also how hard it is to be able to assess vision. And I think most of you are probably going to a pediatric ophthalmologist, but a pediatric ophthalmologist who specializes in children with developmental disorders, even better if you can manage to do that, because there are tips and tricks that they can use to be able to even just get a good eye exam and to be able to see what's going on. So far, I'm not seeing problems with the retina itself. And I say this because there can be some eye conditions where we have to do very specific eye exams because there are problems with the retina. I am not seeing that here. So I don't think we're going to have to do any special types of things. We'd have to put the kids under anesthesia or do anything like that to be able, it's just a standard good eye exam, but with a pediatric ophthalmologist, preferably with developmental disabilities experience. The main thing in terms of surgery is that we are seeing as the kids are going through puberty and they're going through their growth spurt, a little bit more scoliosis, a little bit more curvature of the spine that we're seeing. So it is one thing to watch for. We're not seeing a huge amount of kids that need to have surgery or rods in their spine to be able to help with this, but that is the one thing that changes over the life course, and we'll see as we have more kids going through puberty. As I said, in terms of endocrine, a little bit in terms of growth, not massive problems, but a little bit that we're seeing in terms of growth issues. And again, with the heart, I would say these are minor things. Sometimes a little bit of a hole in the heart, sometimes it closes on its own with a septal defect, many benign murmurs that don't need anything. But again, we'll see as the kids are growing up if any of the sort of adult types of heart conditions start coming up. Gastrointestinal issues are the thing that we see most commonly in terms of other parts of the body. For many of you, this can be used with a combination of medications for reflux, medication for constipation, and dietary adjustments. And many times, once you get it right, you can sort of control things a little bit better. But I know until you get to that point, sometimes it can be problematic. Not seeing a lot in terms of things like inflammatory bowel disease. Again, not a lot of very specific other things other than I think things that are related to muscle tone within the intestine. This is what I meant in terms of surgeries. There are a few different, I think of them as mostly common childhood surgeries that we do, ear tubes, adenoids, sometimes G tubes that are necessary, but thankfully not a huge number of other things, hernia repairs occasionally, but not a lot of, like I said, major surgery that require lots of long hospitalizations or long times in the intensive care unit for recovery. So that's the good news. Finally, I'm just going to go through quickly a couple different medications. The reason I list medications are these are conditions that for me feel like they're serious enough that someone's going to use medication. So that's a good factor to see how serious it is. Within this, I'm not going to go over epilepsy. You've heard about that already. But besides that, sleep can be an issue for some individuals, again, related to the brain and behavior. Antidepressants, not always just for depression, but around other behavioral issues. We're seeing that as well. And then, as I said, different things in terms of gastrointestinal issues. For this is just a sort of survey in terms of different medications used for epilepsy. Keppra frequently used, but also many other medications used. And I'm not endorsing any one of these, but just simply to say what medications have been used. Finally, you've already seen this in terms of the Vineland data, but at least from the Simon Searchlight data from the Vineland, I would say the kids have been very stable in the sense that we haven't been seeing regression. We are seeing improvement, but it's relatively slow improvement over time and a lot of stabilization at some point. But again, there is some gain to be had. And one of the things that I'm waiting to see, but I do think as we have some new technologies in terms of expressive language, not simply saying words as words coming out of the mouth, but other ways of being able to express themselves, I do think the generation coming up who have more use of ACCs and other communication devices, I do think we're going to be able to have more progress in terms of communication. So just in summary, to put all of these things together, the good news is there's no bad news from coming out of this, that really what we're thinking about are things that we know. We're not having surprises. I think we're pointed in the right direction in terms of the clinical trial, the clinical trial readiness, the measures that we're looking at going forward. I'll just simply plant the seed that, and you've seen it already, that I do worry about a medication or something we might use, excuse me, in a trial, that our measures are not the best measures, that I do think there's a possibility that we might see something that would show us an improvement, but we don't necessarily have really good measures to be able to be sensitive enough to small enough amounts of change. And so I'll just plant the seed that as you all, as a community, are going into clinical trials, you all, as Dr. Mom, Dr. Dad, Dr. Grandpa, Dr. Grandma, whoever you are within the unit, the family, you actually are first line in terms of observers. And you may be seeing things, and you may actually be able to help collectively for us to see what's starting to move the needle in terms of a treatment. And so I urge you, as much as you can, take notes in terms of what you're seeing, try and keep track and share that with your study teams and your doctors as you're doing this, because what we predict sometimes might change in a trial, at least this is my experience, is I'm not always right. And I'm happy to be able to say that out loud, but when you do it, you do need to be a careful observer because we need to collectively be able to learn to move this forward. So thank you, good to be here.
All right, I think we do have time for a couple of questions. If anybody has anything for Dr. Chung. All right, job well done. Thank you. Okay, our next presentation is going to be about understanding STXBP1 genetic variations, and Katie and Joan from Colorado Children's is going to help us with that. Understanding our kids' genetic reports and their variants and mutations can be difficult, and so Katie's going to make that all simple for us.
All right, thanks everyone for joining. I've had the pleasure of meeting many of you in clinic and also this morning, so hopefully this will be kind of a back to basics review for a lot of people, but we'll go for it. All right, so objectives today are just to review some basic genetic concepts and terminology, go through kind of a long list of different terms that you might have come across in your children's genetic reports. Discuss different types of genetic changes and kind of the differences between a benign versus a pathogenic variant, as well as uncertain variants, which many of you may have encountered. And then discuss how this all relates to STXBP1 specifically and its relevance to therapies either now or in the future. So this is kind of the basic diagram that we always put up here when we're talking about genetics. So we all have our cells that contain our genetic information in the form of chromosomes. The chromosomes are basically packages of DNA that are very tightly wound. And then our genes are just segments of DNA that give our bodies instructions to make different proteins that have functions in the body. A protein is made up of something called amino acids, which are just the building blocks that make that protein. And proteins can have lots of different functions. You know that STXBP1 is very important in the brain. And so that's kind of, we go from genes to RNA to proteins. So a gene, again, is just a segment of DNA that codes for a protein. We have 2 copies of most genes. Those are called alleles. So for STXBP1, we each have 2 copies of that gene. And for your children and family members who have STXBP1, they have 1 copy with the mutation and 1 that is typical. So genetic counselors love a good analogy. So the one that I often use is that the genes are kind of like recipes. They're instructions that tell our bodies how to make something. And then the protein is kind of that final product. So the protein is what we are working towards, what the gene is telling our body how to create. And then the amino acids, again, are the building blocks or the ingredients that make up that final product. The genes are made up of different letters, and that code tells our body how to build proteins, again, made up of amino acids. And the sequence of those amino acids is what determines the 3D structure of that protein as well as its specific functions within the body. The proteins can do things like provide structure and support to different body systems, transport materials, protect the body from viruses, and carry out all the chemical reactions that are needed for our bodies to work the way they're supposed to. So a genetic variant, which can also be referred to as a mutation or a change, is any alteration in the DNA sequence that's different from what's seen in the majority of people. So there's no perfect gene, there's no correct version of STXBP1 or any other gene. We all have variations, that's why we're not exact copies of each other, we're not all just clones. We have different versions of what is normal or what's typical. So a variant can be benign, meaning that it doesn't cause any problems, it's just a version of normal. It can be pathogenic, meaning disease-causing, or it can be somewhere in the middle, so of uncertain significance. So many of you who've had panel testing or exome testing might have also encountered variants of uncertain significance. When we see those, we try to take our clinical interpretation into account and determine whether that variant is potentially contributing to your child's symptoms or if it's just a normal variation of that gene. So pathogenic or disease-causing variants are what we usually mean when we use the word mutation. So you might see those 2 terms used interchangeably. There are many different types of mutations. So there's going to be a long list here, but I will kind of point to missense and truncations, which is what we see for most pathogenic STXBP1 variants. We know that missense mutations account for about 50%, and then those pathogenic truncations account for somewhere around 25, maybe a little bit less than that. There also are, and we'll go through some of these specifics, but we also see changes called nonsense mutations that cause the body to kind of stop short. There is kind of a stop signal that the body uses within the DNA code to tell the body when it's done building a protein. So sometimes you can see a single letter change causing one of those stop signals to come up before it should. We can see insertions, deletions, or duplications within the gene. So not to be confused with a deletion or duplication of the entire gene, but sometimes we see single letters or small strand of letters within a gene that are added or missing. So this is where my fun little animations come into play. If those of you who were here a couple of years ago have probably seen a version of these slides before. This is just kind of my way of illustrating how the body reads our DNA and how we can see different changes or mutations happening. So the body has a very specific way of reading the DNA code. It can only read 3 letters at a time. So you can imagine a sentence made up of 3-letter words, like the cat ate the rat. One example of a missense mutation might be if you change 1 letter. and then you end up with the cat ate the bat. So it is a sentence that still makes sense, but it is a very different meaning, especially if you're the rat. So we can see certain sense mutations that still maintain some sort of meaningful sentence, but then you can see others where you might change a different letter and end up with something that really doesn't make sense. So the car ate the rat. Because we're in Colorado, of course, it's a Subaru. We can see something called silent mutations or synonymous variants. This is something that oftentimes does not cause problems, but sometimes it does. And that's because there's sort of another level of control on our genes called epigenetics. We won't get into that, it can be very complicated. But most of the time, silent or synonymous mutations do not cause problems, but there are definitely exceptions to that rule, like there are for everything in genetics. A nonsense mutation would be where, again, there is that stop signal that's introduced early, and it stops that sentence or gene short. So this kind of leaves us with an incomplete sentence or an incomplete version of that protein where there is a piece that's missing. So you end up with the sentence, the cat doesn't really tell you anything. You can't really make sense of what that sentence was intended to be. So that's sort of what we see with nonsense mutations with proteins that end up kind of being these incomplete versions of the protein that the body does not know what to do with. We can see insertions. So if there is a complete new word added to that sentence, it changes things a lot. We've got a very different situation now. So sometimes we can have an insertion that gets added into a gene and changes that final protein product to the extent that it works differently from how it's supposed to. We can also see deletions or duplications that can confuse the meaning of that sentence or gene. But if one of those insertions, deletions, anything happens that shifts that 3 at a time reading frame, you end up with kind of this jumble that doesn't make sense anymore. And that's where we can often see early truncations where there's one of those stop signals that's introduced too early. So usually when that happens, the body is creating this version of the protein that it doesn't really recognize and oftentimes ends up recycling those materials and not being able to use that protein in any meaningful way. So how this all relates to STXBP1. STXBP1 is located on chromosome 9, which is one of the autosomes, which means it's not one of the sex chromosomes, X and Y, which comes into play for inheritance. We see that chromosomes, genes that are on chromosomes X and Y can behave differently when it comes to inheritance. And this is why we see STXBP1 pretty equally in males and females. So the STXBP1 protein, as we all know, is very highly expressed in neurons. It regulates the formation of a protein complex that allows for vesicle fusion. And that's necessary for different neurotransmitters to be released in the brain, which is important for all types of different functions that the brain has. So any change in those neurotransmitter levels can lead to uncontrolled activation or excitation of neurons, and that's where we see seizures in this population. And then it also has a role in positioning and growth of neurons during brain development. So things that are very important for memory and learning and all the functions that our brain needs to carry out. So this is an autosomal dominant inherited disease. When we use the word inherited in genetics, it does not necessarily mean that this came from somewhere. We know that in most cases, it's a de novo or brand new change in the child, and it's not something that was passed down from parents. There are exceptions to that, which I will get to in a minute. But we know that it just takes one mutation and one allele to cause the symptoms of STXBP1. So there are rare cases in which a pathogenic variant may be inherited from a healthy parent who might have either somatic or germline mosaicism. This has been seen in very infrequent cases in the STXBP1 population. It is rare, but again, in genetics, we never say 0% for anything. So this is part of why we always recommend parental testing, just to have a more clear confirmation of whether there is a risk of having recurrence in future pregnancies. We know that for siblings or other family members who are healthy and don't have any apparent symptoms of STXBP1, the recurrence risk for them and for their future children is very low. So a little bit more about mosaicism. Mosaicism in genetics is very similar to mosaic tiles like this, which basically just means that people have more than one population of cells. So they have cells that are typical, that have a normal copies of STXBP1, and then they have other populations of cells that might have a mutation. And that can sometimes vary from one tissue to another. So what we see in a blood sample or a cheek swab sample might be different than what is expressed in the brain. So just a kind of more detailed illustration of what this looks like in cells. When there are cells dividing, if there is a cell that has a mutation, all the cells that arise from that will also have that same mutation. So that's how we can see levels of mosaicism over time. So again, most of the time, this is a brand new change in the child. It's not something that's inherited from mom or dad. These types of mutations are something that happen completely randomly. So it's kind of a product of just our normal biology, is that there are always new changes introduced. That's why we have evolution. That's why we are able to adapt to different things over time. So it's a normal process that sometimes just introduces a change in a very important place within STXBP1. Our body has a spell check that helps to correct those changes when they happen, but it's not perfect. So sometimes we see completely randomly these changes happen. When I talk to families, I always try to really drive this point home because we want everyone to understand that this is not something that happens because of exposures during pregnancy. It's not because you had a glass of wine before you knew you were pregnant. Nothing like that is what causes changes in STXBP1. They really are truly random in the vast majority of cases. So again, in very rare cases, the mutation may have been inherited from a healthy parent. We know that there's been at least one family in the literature where germline mosaicism was suspected. So that's where there are egg cells or sperm cells that have a mutation that are not present within the rest of the parent's body. And in those cases, the parents might actually have normal genetic testing. If they're included in trio testing, exome testing, we might not identify a change there because we're not looking at the egg cells, we're not looking at the sperm cells. And even if it is kind of a low-level mosaicism in other parts of the body, it's not something that's always detectable on genetic testing for parents. So just something to keep in mind. Anyone who's considering expanding your family, it's always helpful to speak with a genetic counselor, either within one of our clinics or a prenatal counselor who can talk through these things in more detail. I just want to quickly walk through what a test report might look like. So this is just an example from an epilepsy panel. You can see the name of the gene, of course. You guys are all very familiar with that. And then the letters and numbers in the middle there are the coding change and the protein change. So the C stands for coding, it's a change within the DNA, and the P stands for protein, which is the change in the amino acid or the protein. The numbers within those just kind of say the address of where that change lives within the gene. And then for this one in particular, you see the FS*8, so that's how the labs delineate a frame shift mutation. And the 8 just means that it's ending the protein early 8 amino acids later. So we have a lot of jargon in genetics, and it's kind of its own language. So it's always nice to have someone kind of walk through what all of those letters and numbers mean. A test report will include details about why a variant was classified a certain way, whether it's been seen before. STXBP1 has some variants that are recurrent, but many families have their own unique change. That doesn't mean that it's worse or that it's bad to have your own unique variant. There's just certain areas within the gene that are kind of mutational hotspots and are more likely to have changes, and some that are present in only one family in the literature. So understanding your or your child's specific genetic variant or type of variant can be important in determining eligibility for certain mechanisms of disease-modifying therapies. You guys do not need to worry about this for the current gene therapy because that is adding an extra copy of the gene. It's not dependent on the exact mechanism of the mutation that your child has. But for some therapies, it does matter what type of mutation there is, so it is helpful to know. So if there are additional therapies that become available in the future, it might be relevant to know exactly what type of mutation your child has, and that might help determine whether they qualify for that therapy. So just some online resources that I think many of you are probably familiar with, but always good to have. references. And thank you to STXBP1 for inviting me to speak, and always to my Children's Colorado team for being awesome and being here. And thank you guys all for joining.
Okay, I think we have time for one question, if somebody has a good one.
I'm also happy, I put my email address up there for a reason, so if anyone has specific questions, please don't hesitate to reach out. I'm always happy to walk through specific reports.
Perfect. Thank you, Katie. Okay, now we're going to have another one of our family stories. So I'm going to invite Jennifer Wilson and her family.
Well, thank you. I'm excited for this opportunity to talk about Nile. I might need the 2-minute warning. I didn't really time this out exactly. And sorry for the change of order. My son is having so much fun meeting new friends with the other siblings. We did not know where he was at when we were supposed to go on stage. All right, so next slide. A little about Nile. So Nile, you know, the first word I use to describe her is hilarious. Right on time, right on time. She really uses laughter to connect with people, and kind of think Jack Black meets some twerking type of comedy. And I know for me and others, it's the best laugh you've had all day or maybe in a while. So she has that real ability to bring joy to people. She's also very loving and sweet. Through ABA, I'm really glad we got the autism diagnosis and got into ABA therapy. They work their magic. She doesn't totally understand personal boundaries, so a lot of times she was approaching people like this, so they kind of taught her a little bit of space and this side thing, and so she uses that to show affection. And then also, I'm the oldest of 6 girls, so my 2 youngest sisters have had 7 babies in the last 6 years. So those poor first babies were getting a lot of jabs in the eye and mouth. But now she's like really gentle with them, and I know my sisters appreciate that too. And as you can tell from this slide, she loves gorillas. That's her obsession right now. And we have a membership to the zoo. We go almost every weekend. And if you try to talk to her, you know, like, okay, let's go do this. First, zoo, gorilla. You say gorilla? So it is nonstop. And our massage therapist, or her massage therapist I'll talk about, he knew someone who worked at the zoo, so we got to go backstage and meet Cal. And he did like all this stuff for us. He's so amazing. So she really loves Cal and Gunther. And other similar things. Music, water, pacing, and mirrors. So next slide. So the pacing is hard for school. She's gonna be a freshman this year. So school has been one of the hardest things. I'm optimistic for Centaurus. They've got a lot of great support there. She'll be in the autism classroom. She'll have a para, so she'll have 4 different paras, 1 for each class, and she'll go half days. Usually she's a little over it by the afternoon. So, you know, I think middle school's hard in general, but she spent the last 2 years in a classroom totally by herself with paras who, you know, I don't think really got her. And, you know, near the end of the year, one of them made a comment, she acts like a toddler. And I'm like, yeah, that sounds about right. And they weren't changing her. So we pulled her out of school a little early, and she didn't get to do her continuation, graduation. But so school's hard, and I know they're not getting the best version of her, because as we do the STAR study, Andrea will tell you we had to spread it over 2 days because just being in one room is really hard for her, and she was ready to tear down those walls.
But Children's has been great in accommodating, helping her out, and we did that across a couple days. So yeah, as a teenager now, so she'll be 15 in September, and she's showing some teenager tendencies. She wants some privacy, so she'll go to her room and shut the door. And the first few times I'm like, Nile, okay? And she'll gently, she kind of pushed me, said, bye. I got the hint. And then she's also emotional. I think a lot of our kids, like even with pain, she just doesn't show emotion or crying. And just really this last year, she loves her Nana and Papa. She knows directions, so we were kind of, and I have to be careful because we were going there the next day, but when we went to the store and I didn't turn the way she thought we were going, she just started sobbing and just really upset. But that's a huge inchstone, I would say, just being able to have that awareness. So this next section, so this is her massage therapist, and kind of this whole thing, I'm the state expert for Colorado. Thanks. I'm still learning because Colorado offers so much. So I've been through kind of the initial 2 years. I'm originally from here. She's born and raised in Michigan, so we're back 2 years now. So if you have any questions, let me know, but I'm also interested to learn from other Colorado families because there's a lot of opportunities here, a lot of support here. So one thing is massage therapy with her CES waiver. That's something I would never think of doing. And it's been so great because the first, he has experience with other kids as well, like her, but, she would barely sit for 5 minutes. Thanks, babe. And you see Chris? And he said, you'll see. And the last few weeks, she's done, she's done 40 minutes of sitting and getting a massage. And I'll just kind of share his wisdom. He views it as like the more time you spend in your parasympathetic nervous system, mood, digestion, behavior, sleep all improve. So for him, it's just like 1 extra minute there is a victory. And so that's how I kind of try to view it as much as we can, getting her in that calm state. One other thing, I think I'll talk about that on the next page. Yeah, go ahead. So her medical history. So she started having seizures at 3 days old. I ended up having emergency C-section. So we were still in the hospital, and you can see there, that's pictures of her in the NICU. They happened to be doing a photo shoot, so we got some pictures taken. She was on IV phenobarb for 7 days, which totally stopped the seizures. But then, unfortunately, it was like the day we were leaving, they're like, we're going to switch to liquids. And so you're trying to figure out how to even get an infant to take the meds and then send us home. And they're like, we don't know the right dose. So, of course, the seizures came roaring back. So it was like daily. Then we got a second opinion, got her on some Keppra, started slowly going to weekly, weaned her off the phenobarb. And because we didn't have a diagnosis, they kind of for years were just like, the phenobarb can lower IQ, or that's the seizures, so she'll outgrow this. Yeah, eventually, especially when she started getting to school, we learned that that was not the case. But she is one of those kids, when puberty came back, or when she hit puberty, the seizures did come back. She didn't have any seizures from 5 to 10. We were off meds for 2 years, but then she started her period December 2020, and then we actually got COVID April 2021. So I don't know if it was a double whammy, but the month after she had COVID, her seizures came back. And that was a really rough year, but I know she's lucky because it takes some time, but when we find the right combination of meds, they're under control. And so she's 3 years, no seizures now. So, yeah. So she was diagnosed at about 6.5 years old. And so this was all in Michigan, but it was just very rough to get therapies. We practically had a bag. She was 1 year and 3 months by the time
She got PT. You can see there in the middle picture, she's about 8 months there, and she's really struggling to sit up. And then the next picture is her at 3 years, so she still needed help standing up. She did end up taking her first steps around 3 years, probably walking by 4. But so we had to work hard to get therapy, and then also with the diagnosis, this has kind of been mentioned. 1 minute, okay. I mean, we were so relieved. First, the mom guilt, right? Like I had dental work during my pregnancy, and then her first seizure was after the Hep B vaccine, so we spent years thinking she had a vaccine injury, and we did chelation therapy and all this alternative Googling, and so that was difficult, and I can imagine, like, I see the kids getting diagnosed early, and that must be very, very difficult, but I think it does open up the therapies that are needed. And then, I guess I wanted to say this too, just finding this community. I remember when we were searching, and I can't. I can't imagine, like, still being on Google, trying to figure out what's going on. And so the sport's been great, the learning's been great, but we also know with that comes loss, too, in our community. So when I was pregnant with him, a couple teenage girls, we lost them, and I had to kind of step away from the group and get therapy. And I was terrified of her becoming a teenager, but she's almost 15. The seizures came back, but she hasn't lost any skills, and we got them under control. And so, I guess my message is don't be too afraid. I think it'll be okay. And last page, I just want to thank my family. My mom and dad are here. We have a great support system, and I think the really important thing is her forming relationships, and that's what matters the most. And I think a lot of these skills that we tried to get therapy for and stuff help open up that communication and ability to interact with the world, and just the bonds she forms I think are the most important things for us. And she's got 2 great siblings. Her and her little brother fight a lot. It's so funny. And then Nora, I'll end with this. Even when Nora just started talking, I remember her being a little toddler, just being like, "Where's Nile?" Because it's me, she's always pacing, "Where's Nile? What's Nile doing?" And so she's just always been super aware and helpful. And she wrote a paper in school. She loves being the middle child because she can eat hard candy when these 2 can't, and because she's in charge. So, thank you, everyone. I know.
All right, thank you, Jennifer and Nile and the rest of the Wilson team. That was great. All right, we're going to have one more talk before we take another break. So you guys have heard a lot of results of research in the presentations today, and Charlene's going to hop up here, and she's going to talk about some of the studies that we are prioritizing here at the foundation and that we think will help gather insights for the community. So I'll turn it over to Charlene.
I'm back. So I hopefully am going to just give you a short few minutes to talk about the studies you should participate in. I know that, and if you, I can go to the next slide. I have the power. So we've been talking a lot over the last couple of years about clinical trial readiness, and I know that maybe it feels like we're drilling this in to everyone's heads, but a lot of these, even for me, after learning about this for 5 years or so, some of these terms are still a little hard to, kind of completely grok. So wanted to, go through this in a little bit. So clinical trial readiness, all the work that we are doing with gathering data from patients is really around defining what we want to measure and what we can actually measure in clinical trials so that we know that a future therapy is working. So, and some of this discussion has happened a little bit today. You've seen this disease concept model on the left that was developed a couple of years ago, developed and published a couple of years ago on what our patients and families care about in terms of the symptoms that impact them. And we've communicated that to the FDA in our patient-focused drug development meeting in 2023 as well. So this is what we would like to measure. And now, how do we measure that? What can we actually measure? And this is a really busy slide, but what you'll see is the slide that Sarah presented this morning in terms of the protocol that we're using for the STAR study, as well as the measures that you see in the Searchlight study and other studies, RareX. These are all efforts to get at these different areas. So this is also why we're asking you to give biosamples, because getting those samples enables us to look at biomarkers and ways that we can, hopefully identify whether therapies are working. So I wasn't expecting that, but okay, I showed this morning, but I wanted to just emphasize this around the speed that we're trying to work, because for better or worse, a lot of other disorders have actually had even decades of data collected. I was I went to an Angelman conference, an Angelman syndrome conference a few weeks ago. They have more than 20 years of natural history data. We have two of clinical longitudinal data. And so because of the fact that we're trying to work so fast to compress time, that's the reason why what my next slide is going to talk about is the studies we want you to participate in, which is going to be more than one. And I know that this is how, this is not my original one. Sorry, I did actually license a version of this. So this is, I know, how we all feel at the, in the morning. It's been a long night. Maybe our kid or kids have been up, and we're just really working to try to make it through the day. And now here I am up on this stage asking you to complete another survey or participate in another study. And you probably feel a little bit like this. So what I want to just emphasize to you is that it really is, every single piece of data that you contribute is valuable. It really helps us to build this picture of what we want to measure as well as what we can measure. So you may have seen this. It's our Get Ready checklist, and you can see the items here on the Get Ready checklist. It is very focused on supporting the STAR study. So I'm going to say that up front because there are additional studies that we would like you to participate in. This is, if you can do all of these things, and especially since we're here at the conference, do the biospecimen collection, it will really help us to advance our understanding of endpoints for STXBP1. I want to bridge the STAR study to additional studies because Wendy, who I think covered, a year worth of information in about 20 minutes. I'm always impressed, Wendy, about how you're able to break it down and make so much data understandable. But I wanted to show this, and Sarah Ruggiero showed this morning. This is how we're actually bringing data from multiple studies together. So I want to emphasize this because no study like STAR, has 146 participants, which is amazing, but it's only 146 participants. And so if we're able to augment that data with data from other studies, we can really start to build and kind of cobble together some of the pieces that are really needed during this critical time that we're developing clinical trial readiness. So what you can see on the left is it's actually a combination of data from Simon's Searchlight and data from RareX for Vineland. And those gray dots in the background are all from Simon's Searchlight for other disorders. So that's actually pretty interesting because you can see the comparison of STXers as compared to other neurodevelopmental disorders. Here's just some data that's coming out of RareX. So RareX is a standalone registry for symptom data and other studies. We're also using it for our natural history study. So when you go to your site, they will also tell you that you need to complete these surveys within RareX, and that's for the patient-reported or caregiver-reported outcomes. And so here is one example of some data in terms of behavior as well as impact on different aspects of the CNS or the brain and the CNS. And then I wanted to also just highlight Citizen. So we haven't talked about Citizen probably in a year, and it's not because we're not partnering with them. We're continuing to partner with them. And I wanted to emphasize that Citizen can be helpful for two reasons. One of them is that they gather medical records from different providers that you have seen. So when it's very easy to sign up, and like 5 minutes, and you just sign up and then you add your medical providers, and they will pull and structure all of those medical records. There's a benefit from a research standpoint, but there's also a benefit from a family standpoint. When we did our first visit at Colorado Children's, I just gave them a link to a provider link to my Citizen record for Juno, and I did not have to request or bring any other medical records. It was pretty fantastic. Yes, very easy. And then they structure those medical records, they pull and structure those medical records to support additional research for STXBP1 and other disorders. So it's a really great benefit today from a clinical care standpoint, and also tomorrow. You can also get your genetic report from them. So since I know that that's been difficult to get for some people. Okay, so I think these are my last couple slides, but biomarker collection, or biospecimen collection. I know that Jim mentioned this morning, but wanted to just break it out that there are 3 things that you can do: give blood, do the nitrous oxide measurement, and give a nasal swab. These will be used for different types of studies, but all looking at is there data that we can get from these different types of specimens to help us to advance research. Okay, for those of you who are online, if you're not able to give today, there are several other conferences that are happening for the balance of the year, and Combined Brain is our fantastic partner who is doing the data collection and manages the biorepository for us. Okay. If you have any questions, please email research@stxbp1disorders.org. This is actually the area that Jackie Steinberg manages for us, but she has been running in and out to manage all of the research that's been happening here, so I was stepping in for her. So, okay, I will leave it there, and if anybody has any questions, we can probably take one. We can take one. Oh, okay. So there's a question about Citizen, and since it has rebranded, if you need to do anything new. So you don't need to do anything new. You don't need to do anything new because of the rebranding. If you have new providers, You do need to go in, and you should just do that on a regular basis. Like definitely when you have a new provider, but if you kind of do go in once a year, then you'll make sure that you're up to date, because then they'll go and get those medical records from the new providers as well. They will keep going and getting your medical records for the other providers when they do a data refresh. You always need to give blood. No, seriously, there is actually a reason for it. We are very interested in longitudinal data, and we've actually been asked for longitudinal data. So to be able to see, do those biomarkers change over time? Do those things in your blood change over time? Am I going to let people go to break, or?
I think so.
Yes.
Just a couple things real quick before we go to break. So if you have siblings, I don't know if there's any siblings in the room, but if you have siblings with you, we do have somebody doing a little paint party in the sibling activity room, so they can go in there and do a little painting. I would love for them to paint some rocks, because we're going to use them as decorations this evening. So if you want to encourage your kids to go in there, paint some rocks, even your STXers can go in there and paint some rocks. And then the other thing, I'm going to be putting these on the tables, so when you come back, you'll see these. But this afternoon, totally optional, but our one speaker that we'll have tomorrow, Amanda Griffith-Atkins, is offering a session for families, kind of like a processing session after today. If you guys just want to sit and chat, talk some things through. She's a licensed counselor, happy to do that for you guys. I'll put these on the tables. One more thing. That's it. What else you got?
I was just informed that the nitrous oxide machine did not arrive. So you have two things. You have two things to go and give samples for.
I did remove that sign, yes. We don't have the nitrous oxide. Okay, so yes, please participate in the research, and then we'll see you back, what time? How long? 2:50. See you back at 2:50. You can find these on the tables when you come back, okay? Thanks, guys.
advance it to the first one? Oh. Well, I pressed something. I already messed it up. I already messed it up. I already messed it up. Yeah. Are we? Okay. Hi, everyone. I am Kristen Baum, and this is Casey. And we are the founders of the nonprofit Clara Inspired, but more importantly, we are Clara's parents. Clara's our STXer. We were asked to share our story with you today, from diagnosis to dealing with grief to running 1,000,000 miles, not really, but kind of, raising a bunch of money, and inspiring as many people as possible along the way. So Clara was born on December 3rd, 2013. Her birth was exciting, but pretty uneventful. She was born on her due date. And we were thrilled to add a second daughter to our family. Clara's sister Avery is 3 years older. She's now 14. She's not here today because teenagers. She's usually here though. So Clara's first year was pretty typical. Honestly, we didn't really have any concerns except for, a couple of developmental things. She lagged a little bit behind her sister and her sister's development, but, not any huge concerns. And as more time went on, more milestones were unmet, and we started looking for answers. So we met with a developmental pediatrician who eventually sent us to a geneticist. I'm sure this sounds very familiar. And we heard a lot of she'll catch up eventually and nothing to worry about. But eventually our doctor decided to send us to a geneticist to test just in case. So fast forward to April 2016, Clara was 2.5, and we finally received the results of our whole exome sequence. Clara had, you guessed it, a mutation or change on her STXBP1 gene. In 2016, there was only about, I think, 100 to 150 of us, so definitely a small group. So the doctors sent us home with a Google printout, and we started the next phase of our lives, which was post-diagnosis. Slide 3. So I immediately went into crisis mode. We did a benchmark EEG right away. At the time, Clara was not having seizures. Unfortunately, she is now. We also did intensive physical therapy sessions. I spent hours online trying to find a sliver of information, and of course, begging to be let into the Facebook group, like literally begging. I asked to be joined, and then I messaged people right away. And that's where we finally found our people. It was a small group at the time, but very mighty, and some of these people have become our family. Casey, on the other hand, also went into crisis mode, but channeled it in another direction. He looked at our daughter in the midst of grieving, the life we thought we had, and he felt inspired. Clara was his inspiration, and if she couldn't grow up to have a typical life and a typical profession, do all the typical things, then we were gonna help her get her first job, Chief Inspiration Officer.
Yeah, so in the 2017, 2018 timeframe, I didn't quite know what to do or how to handle this, and I wasn't much of a runner. I was kind of an athlete in high school, but hadn't done anything in 15 years, just kind of hung out. But this was kind of the perfect opportunity to sort of get back out there and kind of start spreading the word a little bit. So, Clara was recently diagnosed, and we thought we'd get the word out a little bit. So I had a friend who was running up in Boston, and marathons to me seemed like no fun whatsoever. Why would anyone want to do that? But he sort of talked me into it, and I was like, well, this is a good opportunity to raise awareness for STXBP1 and the new diagnosis that we have for Clara. So we ran a marathon in 2017 with our STX, shirts, and everyone thought it was great. But they were like, yeah, that's great. I have a friend who ran a marathon. I have, a family member who ran a marathon. I was like, okay, but I'm running the marathon because it's hard, but we're doing it because raising a child with special needs is really difficult, as all of you here know. So I'm like, this is really hard. And they're like, yeah, but marathons, they're okay. And I was like, I don't think the message is quite getting across that it's hard to raise a child with special needs. So I was like, well, what's harder than a marathon? So I started kind of doing a little research, and found just a few hours from here, there's a race called the Leadville 100. It's 100 miles. And you have to kind of enter a lottery to get into it and get selected. The chances of getting selected are very small. It's like, I don't know, like 5% chance, 10% chance that you get picked for a lottery. So this is my first time. I don't know any better. I think, well, let's go ahead. I'll just throw my name in the hat. Like, I ran a marathon. I'm sure I could do something else. Sure enough, they select me to run 100 miles. I was like, okay, well, this is something new for me here. So what we did is in the 2018 timeframe, we formed Clara Inspired. So Clara Inspired was born in 2018. And the message that I wanted to get across was that, we can do hard things. We see all the hard work that Clara does through therapy, and we see all the hard work and all the difficulties that everyone in this room has experienced. So we would talk to each other, and we'd kind of have a little internal motto that was like, well, today was difficult, but we can do this. Like, today was hard, but we can do hard things. So I wanted to really sort of prove that we could sort of put ourselves out there and do a really hard thing. So sure enough, in 2019, went out there, didn't really know what I was doing, but 29 and a half hours later, we're able to finish, go across the finish line and raise about $50,000 for the newly formed Clara Inspired. Thank you. And sort of get the Clara Inspired story going. So, from there, we've sort of continued throughout the years. Kristen kind of took the reins after 2019, and she ran.
I can run too.
She ran a marathon during COVID, which was very difficult because it was kind of like a virtual. You kind of do it on your own. She just crushed it, and then we've had friends and family along the way who have helped us. So in 2022, Clara ran her first marathon. This was a team of six of us. Again, raised some money and pushed Clara. It was we're in Richmond, Virginia, and this was November. So you're thinking a 40-degree day, like this should be fine. And sure enough, it was like 81 degrees in November. We're like dumping water on our heads throughout. It was almost, no kidding, it was almost more difficult than the Leadville 100. Yeah, and since then,
we have done a lot of running, and we're getting tired. So if anybody has any suggestions on other things we can do, please let us know. But we have done a few other things. After Leadville in 2020, we obviously, I think everybody was inside, and so we were trying to figure out what our next fundraiser was. And Casey, who comes up with the crazy ideas, and I always say they're crazy right away, but then I'm happy afterwards, he also plays the guitar, so he decided to do an 8-hour guitar session. So he played online for everybody for 8 hours, and we raised like $20,000, I think, that day, which was cool. So we've done that, we've done running, Clara's involved, so just a lot of fun things. And I think the most exciting part is watching our friends and family also get inspired and start doing things that they never thought they could. It doesn't have to be a marathon. People who haven't ever run before, just running, small little races or walking or, just doing things that are hard. And so it's been really exciting. We've also have a merch store, so if you want Clara Inspired gear, feel free to get that too.
Yeah, and I'll just say that none of this would be possible without Clara. None of this would have happened. So, she is our inspiration. She's the reason why we're doing this. So. We want to thank her for being the Chief Inspiration Officer, and this is what her profession will be for the next several years. And we're yeah. But sort of to wrap up here, the money that we've raised over the years have gone to various causes we've worked closely with Charlene and the STX Foundation to contribute to some of the clinical trials. And our thing in a year or two ago was we bought a mouse. So that's bullet point 3 here, which we thought was pretty cool. And we know that there's a lot of people who do so many things for this organization, this community. We're happy and just thrilled to do a small part from there's so many other things that everyone is doing. So we're just so grateful and thankful to contribute as we can.
You said it.
Thank you so much. Appreciate it.
Thank you.
All right, thank you, Baum family. So you guys heard a lot about our disease concept model, and one of the key concerns that was identified in our disease concept model is behavior. And so we have another representative of the Children's Hospital of Colorado, Morgan Jolliffe, who is going to give us a little presentation on behavior in STXBP1.
Hello, I'm Morgan Jolliffe. I'm a neuropsychology fellow at Children's. Thank you so much for that introduction, and looking forward to being here today. I'll be speaking about behavioral symptoms of autism in STXBP1. So wanted to credit my team, my PI and mentor is Andrea Mile, who was able to speak earlier. We're sharing some clinical data from Children's, but also some data from the STAR study. So I wanted to thank my co-investigators at CHOP, especially Carlene Glatz, who's not here today, but was really instrumental in figuring out with me how to look at this and how to interpret the findings and stuff. So thank you to CHOP, and yeah, I'll jump in. So the purpose of today is just to give everyone an update on where we are with assessing behavioral symptoms of autism in this population, kind of present a little bit of data and talk about what we're learning about how to best use these measures, and talk about what's coming in the future too. All right, so as you know, behavioral features of autism are commonly reported in STXBP1, but formal diagnosis is really complicated by overlapping symptoms like lower social communication skills, and there's a lack of well-validated assessment tools in this specific population. So because of that, we suspect that there is some underdiagnosis, and accurate diagnosis is incredibly important for informing targeted early interventions, opening up doors and access to services and all of that. So we definitely want to better sort through our most accurate measures and not be missing diagnoses so that we're not delaying any type of early intervention that could shift the trajectory for social and language development. So before we jump in, I just want to make sure we're all on the same page with what kinds of symptoms and behaviors we're trying to describe. So autism is a behavioral diagnosis, so it's based on symptoms, not based on etiology or why the symptoms are occurring. And as long as there are sort of enough criteria in these two buckets, so social communication interaction and restricted interest and repetitive behaviors, we would classify the combination of those types of symptoms as autism. So to give you some specifics on what those symptoms may look like, social communication weaknesses may include limited or reduced eye contact or facial expressions, joint attention or reduced social smile. There can be delayed or absent nonverbal gestures, or there are gestures may be poorly integrated with speech. A lack of imitation skills is quite common, reduced language for social purposes, and sometimes the lack of social motivation, although we don't always see that. Within the restricted interest and repetitive behaviors category, we think of things like repetitive motor movements, so spinning or hand flapping, can be head banging, things like that. There could be repetitive speech, which could be like speech for non-functional purposes, kind of repeating things that have been heard. Inflexible patterns of behavior, so rigidities, kind of getting stuck, and also sensory sensitivities. And then those arrows on the bottom just kind of depict that within this diagnosis, there's a wide range of expressive language skills, so ranging from nonverbal all the way to highly verbal with some notable social communication differences, and same with the level of support. There's a wide range, kind of shifting from needing to depend on caregivers all the way to maybe needing little or no support at all. So the purpose of our study, kind of our long-term goal, I guess, is to clarify the presence of autism and make sure that we're not sort of under-capturing it in this population, and help clinicians feel more comfortable diagnosing autism. So to give a little bit more assurance that these are the right tools. In order to do that, we have lots of work to do. So some of these things are what we're working on now. Of course, we're gathering data every month, kind of adding to our study. But we are really trying to describe how individuals with STXBP1 are performing on these measures. We're looking at how these measures correlate to one another. So not only do we trust this measure, but does it align with some of the other pieces of data that we're gathering? And then a really important one is number 4, which is determining the degree to which these measures are picking up on other broad developmental difficulties like lower cognitive skills or language skills rather than autism-specific skills. So we have access to 3 measures at this point, the Social Responsiveness Scale and the BASC, Behavior Assessment System for Children. Those are both parent-reported measures. Parent data is incredibly important to us. We know that we only see them in a brief assessment setting, which doesn't really mimic the real world and kind of the experiences that parents are seeing on a day-to-day basis. So those first 2 are really extra important to us. And the CARS 2, this is a clinician-rated measure, and this is filled out by a clinician who's attuned to paying attention to the specific behaviors that we're talking about. They integrate information from parents, from their own observations to fill out the CARS. And this gives you an idea of kind of our sample size. So in the larger STAR study, we have, you heard earlier today, over 100, but with these behavioral measures, we have a slightly smaller N that we're working with, but enough data at this point to do some analysis. So first, the Social Responsiveness Scale. Here, I've plotted out the means for each of these indices. And just to orient you, the T-scores indicate more impairment, so a higher T-score would be more symptoms of autism. And the blue line is sort of where our means are falling. The colorful green, orange, and red are kind of indicating different cut points. So anyone below 60 would be scoring within sort of normal limits. And then between green and orange would be like mild symptoms of autism, 65 to 75 would be like moderate severity, and then 75 and above is the most sort of severe. So on average, for most of these subscales, so we're talking about social awareness, which is what it sounds like. Social cognition is like the ability to think about what someone else's perspective may be. Social communication, also what it sounds like, and repetitive interests and behaviors. All of those are kind of approaching the severe range. And then, of course, all the indices. So SCI total would be all the indices, the subscales that relate to social communication, and the RRB total is a larger index scale as well, and the SRS total includes everything. So as you can see, we're reporting a lot of different symptoms. The one that you'll see that dips down and that's very preserved is social motivation. So we're seeing that fall in the normal range. So within STXBP1, social motivation is largely preserved, maybe a strength that we saw this earlier at AES. I presented on the SIM topic with a lot less people. We're seeing the same pattern, so this is just kind of an update to that. And then we also looked at the SRS compared to the Bailey to see if we're picking up on broad developmental problems or autism specific, and we had no significant correlation with the Bailey, so that was reassuring for the SRS that we are indeed looking at more of those autism specific behaviors and not broad delays. On the BASC, there's a number of clinical scales, but the ones that are noted to be often elevated in autism are the atypicality, which is sort of a broad, includes less social interaction. It also includes some strange behaviors and repetitive movements. So atypicality you can think of as kind of a broad autism indicator, and we are seeing that fall between orange and red, which is sort of in this at-risk or elevated range. While withdrawal, which is more of a social isolation, that one is under the yellow or the orange line, which means that that one was within normal limits. So if you think about the comparison, also this one was not correlated with the cognitive skills at all, so that's great to see. But when we compared the SRS and the BASC, we are really reassured that we're kind of measuring the same thing, or we're measuring what we think we're measuring. So the SRS total was moderately positively associated with the BASC atypicality score. So not only are both of these measures not sort of implicated with lower cognitive skills, but they're associated with one another. And same with social motivation and withdrawal. So we're more confident too in that suggestion that this is sort of a unique profile of autism where there's not a lot of problems with the withdrawal, or people are more motivated, because those were positive to moderate to strongly associated as well. And then the third measure that I wanted to talk about is this clinician-rated measure, the CARS. So on this one, we have a group of 35 people that we have CARS and Bailey scores for. And this is the piece of our work that we're doing with CHOP actively right now. So each bar represents an individual, and we have raw scores plotted. So anyone under 30, sort of within this normal limits, we only have 2 individuals that were falling into that group. Most people assessed are falling above 30, so between 30 and 36 is sort of mild to moderate severity symptoms of autism, and above 36 was in that more severe range. So 50% fell above 36, so a lot of people are falling into that range, and 94% are at least mild to moderate symptoms of autism. So similar to what you saw in the BASC and SRS, we're capturing lots of these symptoms, but our next question again is this one related to cognition? So first, we looked at individuals that had taken this measure that were over 2 years of age, because it is recommended that this measure is used for kids above that age, so that for that same reason, so that we're not picking up on areas of development that haven't developed yet. So we did see a significant relationship for these kiddos between CARS and cognitive ability, and between CARS and receptive and expressive language. So we then decided, because we do see some risk for overdiagnosis in this range and misclassification, we decided to look at individuals above 30 months, so that's 2.5, give a little bit more of a buffer. And when we looked at this group, those effects disappeared. So above 2.5, we're not seeing a relationship between autism symptoms and cognitive functioning. Although we are still seeing a relationship between cognitive functioning and language development. And that is expected because language weaknesses are a core aspect of autism. So this makes a lot of sense and gives us some assurance that these measures are working well, especially when we are careful not to use them in too young of a population. We're still a little wary. These are very preliminary findings, because the individuals that fell within that 6-month range, it was a small group, only about 5. So it was a little surprising that the effects completely disappeared when we took out that small sample. So we are curious if when we add more people, these kind of results hold up. The last thing that I wanted to share is some item level analysis. So we kind of dug in and saw what are the most highly rated items on the CARS. And we looked at specifically anyone that where the mean for the subscale was in the moderate to severe higher range. And we came up with 4 items. So one was imitation. A lot of kids are struggling to imitate. This is a very important finding too, because this is a core treatment goal in a lot of autism-specific treatments, is teaching that imitation skill, which is crucial for learning long-term. So that was one to pay attention to. Another is body use. So for this one, we're seeing lots of posturing, repetitive movements, kind of motor things that fall into this category. So that was very common. The third one was this sensory responsivity. So at least moderately preoccupied with sort of sensory input, and it can include either being sensitive or kind of under-sensitive to input. And then fourth, verbal communication. So at this level, in the moderate to severe, speech is often absent, but when present, it can be repetitive, include peculiar, like jargon or pronoun reversal, things like that. The least highly rated item was adaptation to change. So at this lower level, this is below the mildly abnormal range, so kind of within normal limits. Most kids may notice change, but are kind of flexible with it. I didn't bore you guys with all the sub-skills on the BASC, but there are a lot of adaptive skills, and this actually matched what the BASC showed too. out of all the adaptive scales, most were in the clinically significant range except for adaptability. So we thought that was also interesting that we're sort of starting to feel like we're forming a unique profile where we're learning that these kids are socially motivated, potentially more flexible than a typical kid with autism. So to summarize, this data is still very much preliminary, and we're adding people, like I mentioned, every day, but we're excited and reassured that a lot of these measures are kind of jiving together and aligning in what we're seeing. We're seeing a lot of significant symptoms, and that's just made us more excited to keep figuring out the best way to diagnose properly, efficiently, and early, because we're seeing a lot of symptoms, but we're seeing that profile of preserved social motivation and adaptability. So stay tuned, especially for the CARS results. We would caution use of that measure under about 2.5, and we are interested in just seeing how that looks at 3 and above, and if we're seeing even less significance there. And so thank you guys. If anyone has any questions, be happy to answer them. This is our larger team, so all of our collaborators at CHOP and Texas Children's and Cornell, and thank you to the foundation members as well for supporting this work.
Thank you. Thank you. Does anyone have any questions? I see one hand in the back there.
Maybe. Check. Okay. I was just curious, the imitation, did that correlate at all with visual impairment?
We haven't looked at that. That's a good question. I'd be interested to look at that. So thank you for bringing that question up.
We have time for one more question. Here we go. Sorry, let's do online.
Okay. Sorry, I gotta find it here. Okay. Do you have any age ranges where autism is prolific?
Like most common?
I think that's what the question is.
Yeah. Well, we do think of autism as occurring from birth. It's like a neurodevelopmental condition. So in terms of like the most common diagnosis time, there are, maybe Dr. Reynolds would know this better than me, but I think the average time for diagnosis is like 3 to 6. Does that sound right?
I'm coming.
Yeah.
I think typically it's been about age 4, but part of that is the long wait list to get the diagnosis and that kind of thing. So, and I think it's getting lower all the time with more awareness.
Yeah, great question.
Thank you very much. All right, we are in the home stretch here. We're in our last section for today. And this section, we're going to talk about clinical trials. We have 2 speakers, and I'm delighted to introduce the first speaker, who I have not met yet. It's David Campbell from Lundbeck. And I want to, he's going to talk about this in depth, but this is the first trial, I believe, that is actually for across developmental and epileptic encephalopathies, which means that you don't have to have like an LGS diagnosis, and it really opens things up. So for disorders including STXBP1. So I want to welcome David to the stage to give us information on I'm not going to even try. On the longboard trial. Thank you.
Before I jump in, I just want to say, like, the Leadville 100, that is legit. It's not just running 100 miles. Like, you are at elevation, there's climbs, there's descents. Like, that's nuts. Hats off to you. So my name is Dave Chapman. I'm a neuropharmacologist with 20 years of industry experience, and before that, about a decade looking at animal models of epilepsy and seizures. I'm a recent transplant of Colorado to Utah, so when the Michaels moved in, I knew it was my time to go. But I've really been grateful for the opportunity to liaise with some families that are in neighboring states and even in the same county that I'll be in Utah. One fact that is maybe critical for no other time than today, I am the worst dancer on the planet. So I hope to see you out there tonight, and you can try and wear the crown, but I think I've got it. So that's it. But yeah, so what we're here to talk today about is about Beexicasserin and about developmental epileptic encephalopathies. So Beexicasserin, again, it is a treatment that is under investigation. So it is not currently approved for any sort of treatment, but we are looking at it and evaluating it for the treatment of seizures associated with developmental and epileptic encephalopathies, or DEEs. So DEEs as a grouping are over 400 different largely monogenic gene mutations that have a primary common clinical consequence: seizures and developmental plateauing or regression. So STXBP1 is one of these DEEs. Briefly, who we are. Lundbeck is a global biopharmaceutical company who is headquartered in Copenhagen, Denmark. From the United States, we have offices in just outside of Chicago. We're one of the few pharmaceutical companies in the world that is focusing exclusively on brain health. Our legacy in neurological rare diseases started with the first treatment specifically for the treatment of seizures associated with LGS, or Lennox-Gastaut syndrome. That's clobazam or Onfi, and we hope to build upon that legacy. Epilepsy is defined as more than one unprovoked seizure. Seizures are brought about by an imbalance between excitatory and inhibitory neurotransmission in the brain. Two means of restoring this balance in most cases are either to elevate inhibition or to apply some more brakes, or to decrease the excitation, so to lift your foot off of the accelerator. So Beexicasserin is a highly selective molecule that binds exclusively to a receptor called 5-HT2C. 5-HT, 5-hydroxytryptamine, is serotonin. Serotonin is a chemical within the brain that signals across synapses different actions. There are 14 different serotonin receptors, and 5-HT2C is one of them. So when serotonin is released in the brain, it can act on any of these 14 receptors that happen to be in proximity. However, chemists have developed molecules that can selectively bind to some, but not all, of these 5-HT receptors. Within the human body, there are 3 specific flavors of 5-HT2 receptors: 5-HT2A, 2B, and 2C. Beexicasserin was designed exclusively to activate the 5-HT2C receptor. The reason for this focus of specificity is that we hypothesize that activation of 5-HT2C results in anti-seizure efficacy. This is in contrast to 5-HT2A and 5-HT2B, where we believe they don't impact inhibitory neurotransmission, so activation of these receptors produce physiologic effects that are not consequential to anti-seizure activity. So in this case, Beexicasserin and its selectivity is unique. So if we focus on a recently completed study called the Pacific study, it was evaluating the change in countable motor seizures in patients across a broad group of epilepsies. Patients needed to be on a stable dose of anti-seizure medications, up to 4 of them, and still exhibit at least 4 countable motor seizures per 28 days. Patients were randomized to addition of either bexicaserin or to placebo, and that is in combination with the medications that they were currently on. So even if they were in the placebo arm, they weren't taking no medication. They were still taking the medications that they were taking before they entered the trial. It was just, were we adding placebo to those medications, or were we adding bexicaserin? So following titration to a stable dose, patients were maintained on that dose, and then the primary efficacy endpoint was looking at the number of countable motor seizures at the end of maintenance compared to what they were at baseline. From a safety perspective, the most frequent adverse events associated with bexicaserin were somnolence or GI related. Predominantly mild to moderate in intensity, and were most often encountered during the 2-week titration phase. In fact, as it says in that second bullet point, about 1 in 6 patients on bexicaserin discontinued during titration due to an adverse event, and that adverse event was usually somnolence. During the open label extension, when we allowed 3 weeks of titration instead of 2, none of the 9 patients discontinued. In fact, during the open label trial, and I have a poster outside if anybody wants to discuss that a little bit more, only 1 patient has discontinued due to an adverse event, and this has now been going on for over 6 months. So this confirms really a favorable safety and tolerability profile of bexicaserin. From an efficacy standpoint, patients on bexicaserin had a numerically greater decrease in countable motor seizures than did patients on placebo. So you can see at baseline, both of them are up at the top. Bexicaserin, the placebo-controlled portion is the stippled or dotted line. You can see a reduction of almost 60% of countable motor seizures in patients on bexicaserin, and this is in contrast to patients given placebo, which had about a 17% reduction in countable motor seizures. Following that placebo portion, all patients were switched to bexicaserin, and then these are data just looking at the end of 6 months of being on bexicaserin, both patients that were originally on bexicaserin and then those that originally got placebo but then were changed to bexicaserin have a durable response in terms of the reduction in countable motor seizure frequency. So let's move now into kind of where we are currently. We are currently enrolling 2 global phase 3, so these are the largest clinical trials prior to marketing authorization. So this is kind of the go or no-go point in terms of submitting things to the FDA, saying this is why we think this would be important to patients with developmental and epileptic encephalopathies. So we're going to focus on the Deep Ocean trial just because that is something that would be a little bit more germane to this group today. So it is, as was mentioned during the introduction, it is the most inclusive study to date for patients with developmental and epileptic encephalopathy, regardless of what that etiology is. So it includes your favorite STXBP1, but it also includes, again, a number of other conditions that result in intellectual delay or plateauing and seizures. Both of these studies will then go into, so these are placebo-controlled randomized trials, and both of these then will move into an open label extension phase where patients will be able to receive bexicaserin for a longer period of time. Focusing on specific inclusion, again, I'm just going to focus on the Deep Ocean portion. Patients must exhibit seizure types and clinical signs consistent with other developmental and epileptic encephalopathies. Across both studies, developmental plateauing or regression, and must average at least 4 countable motor seizures over a 4-week period for 12 weeks before screening and then during screening. We've already seen a slide very similar to this, but again, just to kind of call out some of the differences. One, a longer titration period to make that period a little bit more tolerable to patients on Beexicasserin. Two, the age of patients is now decreased down to 2 years of age, whereas it was 12 in the study that we had looked at a couple of slides ago. A dramatic increase in the number of patients. So whereas that was around 50 patients total, we're looking now at about 160 in each arm, either Beexicasserin or a placebo. And then again, that randomization is 1-to-1. So this is my coming soon to a city, state, or country near you. I know that it is monumental to travel. And so if you feel like time or distance will potentially preclude you from making it to one of these sites, let's at least have a conversation. We have resources that hopefully decrease some of those obstacles and barriers. So let's have a discussion if you feel like this might be something that you are interested in pursuing. If I haven't addressed any questions, or if you'd like to revisit this information, the website is shown here. It is the deep-studies.com, or you can email us. Lastly, this is my email, my mobile. If you want to talk to me about, the best bike rides in Colorado or the study, please feel free to do so. But I thank you for your time and attention, and we'll take any questions that you have.
Are there any questions for David?
Thank you. I'm just curious if you have a breakdown of diagnosis of the first. No.
Yes.
Oh, okay.
It's going to be better if I'm talking to a microphone. Yes. And again, we're kind of splitting relatively small patient numbers already, but Dravet syndrome was only 3 patients, and they were all on Beexicasserin. The LGS was in the teens, and then the DEE other was around 20. So we're hoping for a similar equitable split between Lennox-Gastaut patients and patients with kind of all other DEEs. But what we saw in that was, again, and this was kind of what the FDA said, go ahead and try this trial in a broader patient population, was regardless of what that etiology was, the reduction in countable motor seizures was similar.
Awesome, thank you.
Yep.
Any other questions?
Thank you.
All right, our last presentation of the day. And I wanted to say that all of this work that we're doing to advance progress in STXBP1, it is really based on investing in relationships. And thank you for nodding, Terry Jo, because I really do think it is. And so we have a number of industry partners here, and of course our academic researchers, and these have all, the work that we've been doing has all been investment in, multiple years of working together and building this, hopefully really expansive future for STXers. And I was reflecting that I first met the Capsida team over 5 years ago, so I think 5 years ago and 1 month, and they were landscaping diseases and considering STXBP1. And they just obviously decided to start a program in STXBP1, and here we are now at the start of a clinical trial. And I am, really excited about what Melanie is going to present. And I also feel, I just want to say this as a parent, nothing happens fast enough. Nothing. No progress ever happens fast enough. But going from 0 to clinical trial in 5 years is incredibly fast from a pharma standpoint. And so this is really an exciting moment, and I will pass things over to Melanie.
thought I'd have to adjust the microphones, but fortunately Charlene got up here before I did. So I am Melanie Brandenburg. I am an adult neurologist. So I spent my clinical world taking care of people with Parkinson's disease. And then about 11 years ago, I moved to Ultragenics, where I was working on rare pediatric neurodevelopmental disorders. And so a year ago, plus a couple months, I got a chance to move to Capsida to work on this program and a Parkinson's program. So it's kind of the best of two worlds for me. And I'm so excited to be here working with this community. So I think there's been a lot of excitement about our program, which I'm very grateful for. And I'm also grateful for Scott and Jim kind of laying the groundwork with some of the not as quite as exciting parts for me, so my work is not quite as onerous as it could have been. So as you know, we are Capsida Biotherapeutics. We are working on a program, an IV gene therapy for patients with STXBP1 developmental encephalopathy with epilepsy. And we are very pleased that the study has now officially started, not with dosing, but with pre-screening of some patients. So very, very exciting. I stole this from the STXBP1 Association website, so it's a very cute drawing. You've already been through some of the importance of the STXBP1 protein. It's really important. In neurology, I always like to say we don't really know what everything does in the brain, but there are some things we've established. For example, that STXBP1 is a protein that's very important for synaptic function. And this is a very cute little drawing of a synapse. A synapse is the part of the neuron where it connects, sends a message to the next neuron so everything can function and messages can get around in the brain. So the synapse is where a little neurotransmitter is released to send a message to the next neuron. So the synapses obviously are critically important because we need all those neurons to talk to each other. So STXBP1, very important for that. Obviously, even kids with STXBP1 have some of that protein, but they generally don't have enough. So we're trying to augment the amount of protein. We already heard a really great explanation of how gene therapy works. So I don't necessarily have to go into that. But the idea is that we have an AAV9 capsid, excuse me, that is going to carry a little piece of DNA into the nucleus, probably will not incorporate into the DNA. As was mentioned earlier this morning, there's a very, very infinitesimal possibility that it could do that, but we don't expect it to. We expect it to just float around in the nucleus and enable the production of DNA, which will then enable the production of the STXBP1 protein. So Capsid is a company that's been working for years on developing capsids made from disabled AAV viruses that not only are safe to put in people, but also will cross the blood-brain barrier and distribute its gene cargo to neurons. That last part sounds pretty simple, but as you heard earlier today, it's not that simple because for very good reasons, the brain is very selective about what it lets in there. If you think about it, you don't necessarily want everything you put in your body to end up in your brain. Think about your college years, right? So it's good that the brain is selective, but if you want a therapeutic agent to get into the brain, you have to always, at some point, wrestle with this issue of how is it going to cross the blood-brain barrier. So these capsids are designed to do that. Typical gene therapy given intravenously goes right to the liver, and you always have to contend with that. Not that we're not at all worried about liver toxicity, because of course we're going to be monitoring for it very, very assiduously in this study, but our capsids are designed to avoid the liver, avoid other problem areas, so that more of the actual therapeutic cargo gets into the brain. And that's what we're so excited about, because not only could this work well in STXBP1, could work well in Parkinson's, could potentially work well in a lot of neurologic conditions. So we are very, very excited. But we're at an early step. So in our non-human primate studies, we saw up to 70% of neurons be transduced, meaning be able to make protein in the brain when this cargo was put in there. We saw much less targeting of the liver and the dorsal root ganglia, which are the potential nerve damage that Scott mentioned earlier. And we saw IV delivery, which limits certain risks of toxicity. For example, in Parkinson's disease, traditionally, gene therapy has been put directly into the brain, which means drilling a hole in the skull and putting it right into the brain tissue, which obviously carries significant risks. In other therapies, it might be put into the spinal fluid, which is also not without risks. So giving it via an intravenous therapy could potentially, and again, this is an investigational product, but could potentially allow more drug to get into the brain while avoiding the toxicity that's been seen with previous gene therapy studies. So this just sort of shows our expression from several of our capsids across the CNS, the central nervous system. And you can see it's because there is a capillary, a little tiny blood vessel, near every single neuron in your brain. Giving it intravenously allows really, really good access of all of those neurons to the drug. And so you can see we've got really good distribution across not only the cortex, the outside of the brain, but also the internal structures of the brain and cerebellum, the part back here. So you can also see in the diagram on the right that the liver is much less targeted with our therapy. So we're able to give a lower dose, detarget the liver, get more drug into the brain, and we're very excited. Obviously, still very focused on safety, and we'll be monitoring this 24/7. These investigators in the room, I just got their cell phone numbers, so they will be constantly hounded by me through the whole study, and vice versa. We'll be like a syncytium, a connected web of people and information during the whole study. So we announced our IND clearance a few months ago, and I just wanted to talk a little bit about what that means. So in the IND application process, our company gave information to the FDA on our preclinical pharmacology and toxicology studies, the manufacturing data for the drug product, the clinical trial protocol, the investigator information, and a whole lot of other things. I think the application, even though of course it was given electronically in this day and age, was about 5,000 pages of information. So after review of the application, the FDA notified us of clearance of the IND. This is not drug approval by any way, stretch, or form. This is authorization for us to take it into the clinic and study it in careful clinical trials. So the primary purpose of this first study, and this is very important, is safety. You've been hearing all day that there are safety concerns with gene therapy. We are very, very aware of it. Our preclinical studies, including our 6-month GPL tox study, looked very good. A little bit of elevation of the liver tests, and then they went back down again, and no other findings. No animals were healthy. They looked fine. But we will still be watching these patients for every minute of the day. So we are now able to go and study this drug in the clinic and see if it's safe. Obviously, we're going to be looking for efficacy, but as we all know, it takes time for things to happen in the brain. It takes time to learn new skills, learn new language, behaviors. As I think Scott mentioned, some of the behaviors could get a little bit worse before they get better. So we're going to be looking at all of that, but the primary purpose of this first study is to demonstrate whether this drug is safe, whether this investigational product is safe. This means baby steps. It means we go very slowly, and we look at the safety data for each patient before dosing the next patient in the early part of the study. This sort of shows, similar to what Scott showed this morning, a rare disease overview. And what I wanted to emphasize on this slide is that, see the red arrow, we are here. So I know some families have expressed a lot of anxiety, like, this is a very small study, what if my child doesn't get into the study? But I want to emphasize that first we have to show that this drug is safe. And if we do, there will likely be more studies and more opportunities. But that's the number one thing, is the safety. So we are here. Other considerations in rare disease drug development include the importance of natural history data. So those of you that are participating in the STAR study, I applaud you, because that data is so important, because at some point, if this drug works, we will have to convince the agencies that they should approve this therapy. And that means demonstrating that what this drug does in the brain is better than a child who's left untreated. And so that's what the natural history study is for, is to establish that baseline, that trajectory. Maybe there is some development over time, which we've seen in some of this data, but we need to show that we are better than that our trajectory looks better. That's why every single bit of this natural history data is absolutely critical. So thanks again for participating in those studies, because they will be very important. The other thing that the natural history study does is shows us which of those many, many forums and tests that you're all doing will help us understand what's happening in a clinical trial. Because as you all know, there are not out-of-the-box assessments that, the box does not say, use these assessments for STXBP1. People like Scott and Ingo and Tuan are developing them in their work, and we will be hopefully helping to validate them in the study, but there are no out-of-the-box assessments. So we borrow from other tools like the Bailey that you heard about today. All of these things are sort of borrowed for rare disease work. So doing a natural history study shows that those assessments are in fact applicable to this population. Very important. The possibility of historical controls. We may be asked to do a placebo-controlled study, but we don't want to, and I don't think you probably want to either. So if there's any possibility that the agency will let us use natural history or controlled data, we are going to try to do that. It'll be a lot of back and forth and a lot of data, but that is one of the things you may be able to do in a rare disease study. There are also potential accelerated approval options. So we have orphan drug designation and we have fast track designation. So we are hoping that those things which allow better communication with the agency and more meetings and things will speed up the process. So the other thing that's really important here, and this goes back to the natural history study, is that as you can just see watching your kids and everybody else's kids here, they're different. All these kids are different. So it's not like, 200 adult males with hypertension, where you could easily fill a study of 200 adult males with hypertension. These are patients who are different. Everybody has slightly different measures. And so again, the natural history study kind of gives us an idea, like how many of the patients are walking, how many of the patients have 5 words, 10 words, so that we can, again, use that as comparison data in our study. So I think I went through all of those things about rare disease. Right now, we are in the safety part. We're hoping that our phase 2A and hopefully if we're able to expand to a phase 2, that we are able to start seeing some efficacy. And then at some point, we may be able to squish some of these together and possibly do a phase 2 as a pivotal or approvable study. And then there will be some post-approval work as well. So that's kind of the landscape here. Now, the ability to progress along the path to any potential drug approval depends on the data at each step and a lot of other factors and hurdles. So we are here at this red arrow. We hope to progress along this path, but there's unfortunately no guarantee that we'll be able to do that. So that's like my 50 million caveats about the study. We're thrilled, we're excited, we're focused on safety, we're focused on all working as a team, and we hope by maybe next year we'll be able to bring some data back to you. Hopefully it'll be good. And so that's where we are. So let me tell you a little more about the study. It is obviously a gene therapy using an AAV9 virus that's modified so it can't give you whatever disease it was supposed to try to give you, and a transgene cargo. Now, one of the nice things is that this cargo is for STXBP1, the same one that's already there. So since these patients have one gene that's producing STXBP1, we don't have to worry as much about an immune response to the cargo because it's already in there. We have to worry about an immune response to the capsid. And then, as was mentioned earlier, we have to test to see if your child has antibodies already existing against the capsid. And this is going to slow us down because we have to test every single patient in the pre-screening process to see if they have these antibodies. And if they do, unfortunately, they will not be able to enroll in this particular trial. And I think Scott mentioned that we're trying to mitigate that in future studies, but that's down the road. But for right now, patients who test positive for that anti-capsid antibody will not be able to enroll in the study, which is disappointing for all of us. So other than that, the patients must be diagnosed with STXBP1 DEE. Seizures are not required for eligibility. Patients will be taking corticosteroids, dexamethasone and then prednisone for probably about 6 to 8 weeks total. And they'll be monitored as that is tapered. Somebody's happy about corticosteroids. Okay, that makes one person. But that's how we intend to keep the patients safe during the study. And I mentioned the pre-existing antibodies, and there's IV drug infusion, which is the whole point. That's almost the easy part. Okay, this is just sort of a little outline of the seizure, or of the clinical trial design. 3 patients dosed at a lower dose, followed for a month in between to look at their safety data. And then assuming everything looks good after those 6 patients, then we will move to another 6 patients with the highest safe dose. This thing is ticking away here. This just is an overview of the clinical trial with the pre-screening process where you're just tested for the anti-capsid antibodies and your genetic information is updated. Then there will be a screening period, which will sort of be like a waiting room because obviously if we have to dose patients at least 4 weeks apart, there will be some patients sort of waiting to get into that slot. If they wait too long, they'll have to have the antibody test again and could potentially fail out at that point, unfortunately. And then dosing on day 1, follow-up period for 2 years, very important safety follow-up. So don't think you can just pop in with your child, get the gene therapy, and then head to the North Pole, because that's not going to happen. We will hunt you down and do those safety assessments, I'm telling you. So there will also be other endpoints I'll talk about in a sec. But it's all about safety. And then there will be a long-term follow-up study for an additional 3 years. We want 5 years of safety data from this study. It's a big commitment. So the study objectives, safety, 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 safety and tolerability. And then the secondary objectives are all the things that have been being done in the STAR study, plus a few extra ones that I'll talk about. There will be a seizure diary, an electronic seizure diary, whether your child has seizures or not, because in addition to wanting to see if seizures get better, we want to make sure that seizures don't get worse for some reason. Key inclusion, exclusion, there are some other ones, but these are the key ones. Male or female, greater than or equal to 18 months to less than 8 years of age. At the time you sign the consent form. Diagnosis of developmental encephalopathy due to an STXBP1 mutation. Stable on medications, including anti-seizure medications. Again, the whole point of a clinical trial is you only want to change one thing. So if you are having to manipulate the seizure meds or some other meds, or suddenly decided your child was going to embark on like a 6-month intensive, like round-the-clock physical therapy program, it's not so great because we just want to have one thing change, and that would be the gene therapy. Everything else we'd like to remain relatively stable. Other investigational drugs within 30 days or fewer than 10 half-lives would be an exclusion criteria. treatment with an ASO or any other gene therapy or anything like that. Other genes, like if there's a second gene, which there sometimes are, causing similar or overlapping symptoms, we'd prefer to just treat STX1. Those are the main ones. You can look on clinicaltrials.gov to see a more description of all of the inclusion, or most of the inclusion-exclusion criteria. And of course, the main thing with the whole study is you review this with your clinical trial team. They are the medical purveyors of this treatment, and they are the ones who are going to make the clinical decisions. They're going to decide who's eligible. They're going to watch very closely with us for any types of adverse events. You're probably familiar with most of these, partly from today's talks. We have, in addition to a lot of the Bailey assessment tools, we've added a caregiver interview administered by an outside vendor called Lumanity. I've worked with them before. They're very good. The purpose of this is not to make you crazy with yet another survey, I promise. The purpose is to try to see if there's anything we could pick up that our assessment tools could have missed. So they're trained to do this in a very comprehensive and kind way, and they will be doing it at baseline and then at several periods during the study, again, to see if there's any other exciting change, positive or negative, that could have been missed through the trial. There will be a tremor sub-study at CHOP. There will be a QEEG study at all of the sites, looking for changes in the kind of the background rhythm for all of these patients. And I think, and we, as was mentioned earlier, will be using the CSA developed by Scott and his team. We will be using the clinician and the caregiver version of that. Okay, so, I'm down to 0 points here. Okay, or 0 minutes. So, the FDA clearance has paved the way for the trial to go into the U.S., not other countries at this point. We are hoping to open additional countries depending on our interactions with the relative health authorities, because as I'm sure you know, every country has their own version of the FDA. Fun stuff, right? We would like to thank the STXBP1 Foundation for inviting us today, and we are so grateful to the investigators, site personnel, families, and the participants, especially in the STAR study. Thank you so much.
Are there any questions? Oh, here, we'll start here. Go ahead.
I was just curious about the antibodies that you were talking about of the virus. So is that, you didn't really specify exactly what the virus is, but
yeah, I can talk about the antibodies. So basically, all of us get exposed to viruses all the time, right? And AAV viruses, every kind of virus. And so our body makes antibodies against those viruses, so that if anything that even looks remotely similar comes along, your immune system will attack it, so they don't kill you or whatever. So you have all of those antibodies hanging around in your body, and if some of them look similar to our capsid, they will jump on that capsid, disable it, and potentially make your child sick. So we have a special company that's made a test to detect antibodies that are to our capsid, in case anyone's picked those up along the way. We don't know how many patients that will eliminate. We will be gathering that data as we go forward with the pre-screening. In other studies that have looked at a different capsid detecting test, it's been, for the pediatric population, it's been around 20% of patients. So we're hoping it's less, could be more.
Julianne, or?
That was my question. Okay. I have a question about any potential publication or early sharing of findings as you go through the phases until the pivotal phase. Is there a schedule or anything to understand what's happening?
The question is about early sharing of data. So I don't think, this is obviously above my pay grade to decide when we share data exactly, but I will say that we're obviously going to be very careful. We're not going to be like, oh, we dosed a patient, oh, we dosed another. Because we need to look at the safety data, decide if we dose the next patient. So I will say that we will I'm hoping by this time next year, we'll hopefully be back here to share some data. And between that, there may be other data released. I will tell you that Charlene has me on speed dial, so if we have any data to share, she and her team will drag it out of us and put it on her website, right? So.
And you may want to mention that you already have like a resources area for the preclinical data that you have on your website.
Oh, yes. There is a lot of information on our preclinical program, presentations to like the ASGCT meeting just a few months ago with our preclinical safety data. And yeah, there's a lot of information on our website. I think it's kind of hard to find, but I think if you go under news, you should be able to find it under news.
Any other?
I have an online question. Someone would like to know what is the, I apologize, what is the actual virus you're using for the capsid? Is that possible to?
It's an AAV9 virus, but beyond that, I think it's a state secret and I can't tell. Sorry.
Any other questions? I have a question. So in your, kind of your broken out phases or stages of the phase 1/2A trial, there's a 2-year long-term follow-up. Does that mean that in order to go to the next phase of the trial, you're going to wait those 2 years?
No.
And because I think that this has also been brought up because there's been a question around.
That's a great question. So the early study will follow patients for 2 years, and then there's a 3-year add-on study. But during that time, as we get data, we will have additional talks with the FDA and the other health authorities in other countries about what the next part of the trial will look like, what assessment tools we should be focusing on, what additional safety data they might want. So that will be ongoing. It's not like we're going to say, 5 years, okay, now we can look at the data. It doesn't work like that at all. But thank you for bringing that up. That is a question we have had before, yeah.
Any other questions?
Hi, I know you said that you didn't know whether or not the FDA would require a placebo for the clinical trial, but when that placebo, if it's necessary and it's delivered, would it be delivered via the same virus vector, or would it just be something that wouldn't create any antibodies in the children?
That's a great question. So I just want to make clear, for the first study, no placebo. It's open label. Everybody who participates in the study will get the treatment. There's no placebo in this. I'm talking about down the road. It's possible that we'll have that conversation. And then as to how that happens, it's a really interesting scientific question because, like, for example, in other studies they've done, in Parkinson's studies, they used to do a burr hole in the skull so that you couldn't tell, if you were sitting next to somebody in the waiting room, you couldn't tell, they didn't really drill a hole in your skull, so you must have gotten the placebo, So there are a lot of different ways to do it. You can do it with a sham procedure where you get an IV with just saline in it. Don't know. There are a lot of interesting ways to do it, but it's a very good question. And I don't quote me on this, but I think it's unlikely that there would be an empty capsid given. So, great question, though. Any other questions?
One more.
Okay. How will y'all decide how long to follow these children around? Like, is, age expectancy, like, if the trial continues to have positive effects, or, when are you going to do the cutoff? Like, you've received the IV, so, like, we're going to follow you for 5 years, 10 years, like.
So 5 years is kind of the standard time for following a patient after gene therapy. At this point in time, obviously that could change. It's different in other countries. I think in the UK it's 15 years, for example. So that's kind of like the standard. In most clinical trials, you wouldn't follow someone for that long, but in something like gene therapy that could have longer term ramifications, 5 is kind of the current standard. So part of it is when we expect to see safety signals, but also what the agency's decree is the right length of time, and it could change. Other questions?
Do you expect the age range to change, like as things progress?
That is a very good question. Do I expect the age range to change? I don't know, because I hope it changes. I hope we're able to address both younger and older patients at some point. It'll depend on our safety data and our efficacy data. As Scott mentioned this morning, there are kind of two schools of thought on things like developmental windows, like when you could make a significant difference by giving somebody a therapy. And there are a lot of things involved, like what the disease is, what the mechanism of action of the disease is, what the therapy is. But there has been data and some other studies for other conditions that maybe you can see improvements in a teenage population or above. So I'm hoping that once we have the data for the younger population, we could expand it in both directions. But we don't know yet. We just don't know.
Yeah, it was a great talk. Thanks so much. And I was going to actually ask about the age as well, because in the adult mice, it looks like they see reversal of a lot of the symptoms even at that age. But I was going to maybe ask also about the first dose, and if you were able to agree with the agency on a dose where you might expect to see some benefit.
So I will say that in terms of, this is about dose and benefits. So in our clinical trials, you heard from Mingshan earlier that there does seem to be good treatment effects in the mouse model, and then so we use that to sort of establish what might be a therapeutic range. And both of the doses we're taking into the clinic are in that range. So we expect both of these doses to be therapeutic, as much as we can tell that with the data we already have, since we haven't given this to humans yet. So we're optimistic that both doses should be potentially therapeutic. Does that answer your question? Okay.
Any other questions? I have one question. What was the age of the primates who were part of the tox study?
The age of the primates, I don't know that off the top of my head. I can get back to you with that. It doesn't exactly correspond well to human ages, so it's different, but I don't know the exact ages of the primates. I don't know if there's anyone here who does. Is Swati here? Oh, there you are.
Yeah, these were juvenile primates, so not adults. So they were on the younger range, similar to what we're looking at for kids. But like Melanie said, it's not a one-to-one correspondence.
Thank you.
Jared.
Thank you. I've got a question from online that's asking, can we get more information on the dosing? Will the first 6 patients get the higher dose, or will the first 6 get a low dose? And if all goes well, then the next 6 get a higher dose?
So the way the study is structured right now, the first 3 patients will get the lower dose with minute examination of all of the safety data, and then assuming it all looks good, we will go up to the higher dose for the next group of 3 patients. So that's the phase 1 part of the study. And then we will have a committee of experts meet and review all of the data. And if everything looks good and we aren't seeing a safety signal, we will most likely move to the phase 2A part, the next 6 patients with that higher dose. Sorry if I didn't make that clear.
Any other questions? All right. Thank you very much.
My pleasure.
Well, we have definitely had a full day. It was so much information today. My head is full. I'm sure your heads are full. But hopefully it has really given you an update on what is happening from a research perspective, and what we're really seeing in the STAR study and other studies. So you have a break now. Oh wait, Melissa is going to announce things, not me.
right. Okay, so I know your brains are full of information. On your tables, remember Amanda's offering that session. It's just kind of a processing session, seriously, just to talk with some of your fellow parents, to kind of talk through some of these things if you're interested. I know it's warm outside, but it is going to take place outside in the courtyard. So find some shade. Amanda will meet us out there, and we can do that. In addition, while you're leaving, our photographer has arrived. If you would like to take a quick picture with your family, she will also be here this evening, though. Okay? So don't feel like you need to rush, but she is going to be out by the STXBP1 banner. She's waving right here. She's right here. She's going to come see you. If you want your picture taken now, she'll do it. Otherwise, you can do it this evening at the dance party. Don't forget about the dance party. Okay, we'll serve you some food, too. We'll serve you some food. Oh, when should you come? You should come at 6 o'clock. Dinner will be served at 6 o'clock, and then we'll get going with some fun awards, and then we'll have our dance party. All right? So we'll see you guys back here at 6 o'clock.